Please, don't extend bonus. Yeah. Just going to take a 4 millimeter endometrial remover. इधर ऊपर करके रखो. And give me a 9 millimeter reamer ready as well, please. This is the endometrial drill guide which I am going to use now to make my banner. Flush this. But generally my tunnels are always about 35 and this is exactly a 35 tunnel. That flush please. Flush please. So I'm measuring with a depth gauge and flush please. Yeah, we are about 35 or 30 actually. Uh, and I'm going to go ahead and read with a 9 millimeter roller. Right, please. I don't like to my hand so that I am damaging my articular cartilage. So my assistant is then going to roll till the ring comes to inside the joint, and then I will start using the power button. So the tunnel is about 30. I'm going to ring till about 20, 25 plus this. Remove the pen, please. So I made my femoral tunnel. I'm just going to show you that from the medial portal as well. So I have not created any kind of blowout posteriorly, inferiorly, and I'm not damaged the cartilage as well. Can you appreciate that? I'm going to go to the medial portal and have a look at the tunnel. And this is the tunnel and tunnel view. The small tunnel is the endometrial tunnel, and the bigger one is the 9 millimeter tunnel. And this one, Samu?
Yes, we can appreciate the beautiful tunnel with differential tunnel in the femoral side. So, what is your graft diameter? 9.
It's on the medial side. Give me a grasp, please. So you can see this peripheral.
Yeah, there is a tear in the red zone almost.
It's a
So,
complete red zone.
so it's a good chance of healing.
Stitch for uh, this technique now because this is a demo. I'm not going to the inside out. I'm going to the wrong side because I know what the plan was. Now I'm going to have to use maybe 5 or 6 stitches on the medial side because I want to stitch superiorly as well as inferiorly. So I'm going to go ahead and do that once I rasp. The rasp, it's like, kind of 3 edges in a fracture to make it logical so that it counts. And I'm going to take a sleeve and give me an extension, please.
So, how many stitches you are planning there?
Then 5, 6 over here, superior and inferior. That is what my plan is.
Okay.
Yeah. So I'm going to go ahead first. I'm going to go from Stitch into anterior. This is what my plan is. Fiber stitch, please open the. Now, make sure when you are using the sleeve, it is at below the meniscus. If it is kept above the meniscus, it might damage the cartilage once you go inside with your device. So it is important that uh, it, your device, that where the sharp edge of the needle doesn't touch the cartilage. Now, ideally, the orientation of the stitches should be vertical like this. Uh, So that is what I'm going to try and do. But before I do that, I want some fixation. So I'm going to go ahead and do a horizontal mattress first, which is much easier in this particular case. I fired my first anchor.
Okay. What is the position of the knee at this point of time?
It's in flexion, scoliotic extension,
Okay.
external rotation, and valgus.
Okay.
I'm going to come out
So your
slowly.
assistant role is very important at this position because I
Absolutely, I completely agree with you. Now, as I enter, I'm going to turn my needle downwards
okay.
so that I'm able to capture the critical part.
Inside picture, please. Audio visual guy, go for the inside picture, please. Yes, yes,
Come out.
yes,
Now, advantage of fiber stitch is that there is anchors inside. It's all stitch. It's all sliding knots. Being a arthroplasty surgeon, I don't like any kind of weak material inside my joint. And it's got a double fixation. So this is my first knot, and here comes my second one. And I've got a good fixation if you can see just with one stitch. I actually got my
yes,
flounce back if you can appreciate.
yes. The meniscus is now fixed with the capsule.
Absolutely, absolutely. I'm going to go inside, lock it a little bit to make my knot tight and confirm that it's sitting well. And then I'm going to cut it with my cutter.
Yes.
Yes.
So this kind of repair you can also do with inside out also. What is your take on that?
Safety is something on the middle side. And keep a spoon, uh, instruments, and the other muscle, and I need to do an inside out. But it takes a little more time. It's a little more tedious job to do. This is much more faster, much more easier. The only thing is that the cost is a problem over there.
Yes,
Running the vertical mattress, so I am behind, if you can see in the periphery. Okay, I'm going to take my bike, turn my needle down, fire my first, not an anchor, but a knot, and then I'm going to go and do the second time around the same thing. Now, this is a vertical mattress which I have done. Uh, Hopefully, I've done a pretty decent job in approximating. Now, with two superior stitches, it is important that I do an inferior stitch as well. Uh, So I'm going to do another stitch inferiorly. So I'm going to do uh, kind of a mattress again. So mattress stitches help me use lesser number of devices. Although configuration is not ideal, it should be a vertical mattress. I'll be doing a horizontal mattress to save the number of devices I'm going to use. Sleep, please. How to stitch? Yeah. Mm. Actually, I'll take a vertical mattress in this. That will be better. You shall give me extension, please.
So you are so close posteriorly. Any concerns about
The lessons are
poster?
far behind.
Yeah.
I don't even, so when I started out about 15 years back, I used to measure the needles and, now I don't even bother. Unless I am in the lateral compartment, I have to be a little more careful, but in the inside, I'm pretty okay. I've taken a working mattress inferiorly, if you can appreciate, and now I'm going to go ahead and tighten my second sliding knot. Now, we describe the sign, even over the paper, a meniscal, I don't see a meniscal sign which was described by me in the Journal of, Malignant Journal of Orthopedics. So this is the flounce which returns, the S-shaped flounce which returns after an adequate repair. Can you see that? Can you appreciate this S-shaped flounce which is there? Now, this is something which tells me that I have repaired the meniscus adequately. I just need to put one inferior stitch here, and I think I should be done. Uh, so I'm just going to change my portal now. I'm going to move from my medial portal, and I'm going to put my needle from my fiber stitch from my lateral portal, so that I'm getting the correct angle, and I'm going to put a vertical mattress here as well.
So this area we can sometime do inside out technique as well.
Yeah, you can go to the absolute posterior hand inside out sometimes. Cost is an issue. Uh, but as I was advised that we want to show an all inside technique, that is why I'm using the all inside fiber stitch over here. Sometimes it's very difficult to get the right angle, and can take a little time, but it is very important to find the right angle so that you are repairing the meniscus adequately. एक second मुझे probe देना please. I think we need to just tighten that a little bit.
But you outside in or like all inside?
Yeah, I think just that's fine. Uh, I'm going to probe the meniscus once I cut the suture to show how stable it is, and then we'll go ahead, fix the lateral meniscus, make the couple tunnel, and pass the graft. Can I have a probe, please? Maybe I want to put another one over there because I thought it's better that I do and keep it, make it more stable. So another one here, please. Soumya, Dr. Sridhar, you have anything to comment
Yes, yes, we
about
can see
this?
the meniscus is very well repaired. So it's a big tear.
Yes, it is. It is. It is.
It's not a small tear. Almost from entire posterior one third is involved.
Yeah. Yeah. So I've changed my portal now. I'm actually looking from the
Medial portal you are looking, I think.
and I am so I'm going to take a horizontal mattress here. Just going to push that peripheral part to the capsule, and I think we should be stable.
So what is your length? How much capsule length you are piercing? It's for the all delegate to, because you have a vessels and vessels.
Change the length, it's about 18, I think. And I'm in a pretty safe zone, and I don't need to alter my length. But when you're starting off, I would suggest that you measure your distance with a probe, and then adjust your device to that particular length. So just show me a probe. I'll just show them how to do it. So yeah, you need to have a probe with markings, and you just keep your probe here and
Yes.
see what the distance is on the probe, and then keep your needle accordingly. Yeah. Uh,
Maximum, I think 18 is the maximum, I think, for the juniors. More than 18 is always dangerous.
absolutely, absolutely, no questions about that. So I think you've done a pretty decent job. I would have loved to go inside out in this particular case to get more strength in my return. But nevertheless, we go into the lateral meniscus and repair that as well.
It
Now,
must be a chronic injury because some kind of abrasion of the medial femoral condyle is cartilage damage is some kind of grade 1 damage in the medial cartilage. So it's must be a long-standing tear.
yes, 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 I understand completely. So then this is more of an inferior tear, if you can appreciate.
Yes, we can
Um,
see the tear.
It's
It's
not ending superior, it's just the inferior portion. Can I make a fiber stitch in, please? Fiber stitch in, please. Yeah. What the name of this place? So I'm just going to close this tear with a vertical mattress. Uh, Start. Sleep, please. Sleep, please.
So, where is your popliteus? So, is it like taking your
So
bite?
there have been a lot of literature saying that it's okay if you pierce the popliteus. My popliteus is right over here,
Yeah,
okay, and my tear is not even extending beyond it. So I'm not going to. So this is my popliteus tendon. Can you appreciate that?
yeah, yeah, yeah.
And my tear is not even reaching my popliteus, on the inferior border. So I'm pretty sad. But even if I pierce the popliteus, there's a lot of literature which says that it's absolutely okay to do that, and it's not going to cause any kind of pain or impingement to the patient. And especially in a device like fiber stitch where there are no peak anchors, it's just sutures. It's okay to do that. Yeah. So can you appreciate that I am now in my peripheral zone? This is a little dangerous area. You have to be very, very careful when you are piercing this area. Uh, I can use a scorpion as well to do an all inside technique. But since we have the fiber stitch available and cost is not a problem, I'm going to go ahead and use the fiber stitch for this repair. Now, this is a little gray area. It is not exactly a red zone, it's a red-white zone. Uh, but it's a lateral meniscus. Remember, it is a very important structure, more important than the medial meniscus. So it is very important that I repair it. And that is exactly what we are planning to do so that this young gentleman does not have any arthritis symptoms later on. There have been a lot of controversies about, and even in the recent conference, about how whether or not you should repair a meniscus. It depends individually from patient to patient. Um and we've been repairing meniscus since almost about 15 years, and we've got excellent results. So we continue to do that. Uh, but uh, there was a recent paper by Dr. Anand Joshi which mentioned that he has 10 years of results with a partial meniscectomy, and that was an excellent paper. When I read that, I had doubted myself whether I should be doing repairs or not. But then I had a private one-on-one with him, and he told me that he repairs the meniscus as well when he feels that it can be repairable. So, one more, please. So I'm just going to do one more stitch, and then we'll make the tunnel and then pass our graft. Yeah.
So, again, what is the criteria between the two stitches? Like how much distance you want to keep?
So about it should not be very close to each other, and about say 5 to 7 millimeters away from each other. That is what I would prefer. Yeah. This is a very dangerous area. Please remember that. Uh, so when you're starting off, make the needle size a little smaller, uh, or maybe use a scorpion to repair this. How would you repair this, Soumya? Would you do an all inside, or would you do inside out, or would you use a scorpion device? How would you
Depend.
repair it? Sridhar?
It's
Sridhar? Yeah,
I am a. It depends on the tier and the financial issues is also important.
inside.
I've done all inside and inside out also. So
Yeah.
it's a very good demonstration. So we are the hall is almost full. They are watching you.
Sorry?
Hall is almost full in Sunday morning, watching your fantastic meniscus repair. Yeah.
Thank you so much. So I'm just going to prove it. I think it's going to be pretty stable. Yeah, I cannot. So lateral meniscus is always a little more mobile than the medial meniscus, and I think my repair is pretty stable. This is not even reaching the superior surface. So I think I'm going to just call it a day for the meniscus and go ahead with the tibial tunnel preparations. Now, the reason why I did my femoral tunnel was that, I required deep flexion. Uh, I require a deep flexion for my femoral tunnel. And when I repair my meniscus, I don't want to flex to about 120 degrees to give stress onto my repair. So it is important that I make my femoral tunnel first, repair my meniscus, and then make my tibial tunnel. I'm just going to show you the landmarks for the tibial tunnel. Can you see a small cyclops lesion over here?
Yes, we can see the cyclops in the anteriorly in the tibial eminence.
Yes, a lot of times we talk about CL preservations and all that, and we keep this, and then this gives rise to flexion deformity and to the patient. So it's important that we go ahead and remove. And when you're starting off, I'm talking to all the younger surgeons who are just starting off to do arthroscopic surgery. Please clean up everything before you think about make yourself comfortable with an ACL reconstruction, and then think about preservation and ACL preservation surgeries and all that. I need a shaver, please. Yeah, my open is better. Just going to clear this area a little bit so that we get a better vision. Shaver is very slow. Can you make it 3000, please?
So what will be your tibial jig position from the
Show you
tibia?
that. Just give me a second. Let me just clear
Okay.
this area.
Yes, the cyclops lesion has been cleared.
I have removed that cyclops. Now, I'm just going to show you the landmarks for my tunnel. Give me a pro, please. Uh, my tunnel, this is the anterior horn of the lateral meniscus. Can you appreciate that?
Yes, that's the anterior horn of the lateral meniscus.
So my tunnel should be in line with the anterior horn of the lateral meniscus. If you Campbell, very much that it is supposed to be a little anterior, but it is good enough to make it in line with the anterior horn of the lateral meniscus, and just about 10 millimeters anterior to the PCL. So just in line with the anterior horn of the lateral meniscus and just anterior to the PCL. So this is where my tunnel will be. Now this is a 9 millimeters tunnel. If you have a 10 millimeter or 11 millimeter tunnel, I would make sure that I have enough anterior tibia. Other tunnel, so if I have a tunnel here on the foot plate, and if I have a 11 millimeter tunnel or 10 millimeter tunnel, there's a good chance that I'm going to blow out the anterior tibia. So I'd
Yes.
rather go a little more posteriorly and then make my tunnel. So I'm going to put in my jig right now. Huh? Huh? Yeah,
So please, what is the angle of the jig? What angle you have kept the jig?
5 degrees. That is what I've been using since the last many years. and I don't want to change that. I know that recent literature suggests that you put your angle at about 60 and make your tunnel more vertical, but I've got good results with a 55 angle, so I'm going to do that. Now, if you see, there are two types of jigs. There is a tip aimer and an elbow aimer, and a central jig. Please remember what type of jig you are using, because if you are using a tip aimer, your bead pin is going to come out at the top. If you are using an elbow aimer, your bead pin is going to come out at the elbow of the jig. And if you're using a center reamer, like you see the markings here
Yes.
in the center,
Yes.
can you appreciate? This is where your bead pin is going to come out. So I know exactly where my bead pin is coming out. I have enough. Can you just hold this jig for 1 second? I have enough bone anteriorly, so I'm not going to blow out. This is a 9 millimeter tunnel. Okay, this is where my tibial tunnel I would like to place it. It's about 4.5 millimeters anterior and 4%, 9 millimeter jig, so 4.5 millimeters anterior, 4.5 millimeters posterior to where my placement of my jig is. Now I'm going to pass my bead pin. Uh, so my length of my tunnel I've calculated from outside is about 35 from the jig. Is it on the bone? Yeah, so it's about 35. I'm going to put my I'm going to put in a 3.5 flip cutter now and go ahead and yeah. Now my camera is facing downwards, so I have a bird's eye view of where my tunnel is going to be. I'm looking down, so my light source is, on the upper side. Go, please, please, please. Go ahead, go ahead. Okay, perfect. You just remove this. Give me a pro, please, just to show them. Now, if you see, I have enough bone anteriorly. I'm in the center of the footprint. My tunnel is going to be in line with my anterior horn of the lateral meniscus, and it is going to be anterior to the PCL. Are you okay with this tunnel position?
Yes, yes. We can see that it's okay.
I'm going to now, my flip cutter, I'm going to make it 9 millimeters. So I'm going to roll in that device. Can you see that? Can you see the outside picture?
Yes, cameraman, please zoom out the outside picture so that we can see the adjustment.
This is a wheel which I'm rolling so that I can make it 9 millimeters. Can you see the 9 millimeters?
Yes. Please zoom in. Please focus. Yes.
And you see the inside picture that it is opened up. And now when I'm going to start rolling backwards, I'm going to make a socket of 9 millimeters. Now my tunnel length is 35. Okay. Can you hammer the? Yeah. My tunnel length is 35, so I'm going to make a socket of about 25. Our graph length is my graph length is 65. So I will not have excess graph. So as soon as I'm on the bone now, okay, I'm on the bone. There's this black mark, black ring. Can you show the outside picture, please? There's a black ring which you can see. It's touching my cannula of the jig. Can you see that? This black
Yes.
ring on the outside picture, and I'm pushing it so that now it's sitting flush. Now this is to know how much I'm going to lean behind on reverse. So I'm now just focus on this, huh? Yeah, I'm going to go lean. I've come out about 5 millimeters. Can you see the black mark? Okay. I've come out about 10, about 15 now, about 20. That's 15, sorry. And
Now switch the outside picture. Please zoom out. Yes, we can see that. You
20. So we are 20 now. Okay. We are
okay?
at about 25. Yeah. So we're 25 now. I'm going to go inside again. Okay. And I'm going to now close my flip cutter to 3.5. So I'm turning the wheel now again, as you can see, and my flip cutter is now closed and I'm going to come out. So I have created a socket now, okay, not a tunnel. And it is very important that I hold my cannula in place and pass my deep pin with my fiber wire, otherwise I lose that hole. Okay? Can you appreciate that? Yeah, I want to clean it. And now I'm going to clean the soft tissue and the cancellous bone which has come out so that my graft is passed smoothly. Otherwise, my graft can get stuck in this. Remember, this is a socket and not a tunnel. Take the Ithobond behind slightly, please. So I've seen cancellous bone all around
Yes, we can see
in the
the.
tibial tunnel. It's at the footprint, okay, at the right space. One second, I want to remove this cancellous bone. And now I'm going to pass my deep pin with my loop. Yeah. And I'm going to take an ice tong and remove that from my medial portal. I'm going to now take a beat into my with an F1 and pass it through my femoral tunnel. Now, some people use a passport. I used to do that earlier. Now, when I clear the fact that I don't need to use a passport cannula, next please. I'm passing my beat in my femoral tunnel now. I can see. Use flex. Should go in easily. Something is blocking it. Just give me 1 second, guys. Just give me a beat then. Flex now, please. Okay. Yeah. Pull it, please. Pass my loop in my femur. Pull it with an artery forceps on the outside at the tip. And I'm going to now relay this loop again from the medial portal. Now, once I do that, it is very important that I create a trans, a cannula kind of thing where I'm going to use loops through this uh, uh, portal so that there is no suture uh, mismanagement. So, okay, so now both my loops are from the same portal. I'm going to first pass my graph through my femoral tunnel, and then I'm going to then pass it through my tibial tunnel. Graph, please. Any questions in the meanwhile from the audience? I'd love to take them.
Yes, so is the color coding of the two, the colors should be different so that there may be not confusion. It's easy for the beginners. So
Can you,
femoral and tibial thread should be in different colors.
yes,
So
you can do that, but
yeah,
if you see the outside picture, I'm going to lock my tibial um, I'm going to lock my tibial root in such a fashion that
okay.
I will not get confused. But yes, you can use different colors. You can use a vicryl as well to differentiate between the femoral tunnel and the tibial tunnel.
So what is your plan? How much graft you will keep in the femur?
I've got a length of about 65. I'm going to keep 20 millimeters in the femur. I marked it accordingly. And then I'm going to keep about 25 in the joint and 20 in the tibia. 20 in the joint and 25 in the tibia. Yeah. I'm going to pass my graft in the femur now. Okay. Hold the leg, please. Sorry. So this is my tightrope, and my tightrope button will come in the joint now. Can you appreciate that? Now, as soon as it comes into the joint,
Inside picture,
I'm
please. Yes, we can see.
as soon as it's going to come into the joint, I'm going to change my portal and look from the medial portal now so that I know where my tunnel is and where it is getting flipped.
Please zoom out the inside picture so that we can see the button going into the femoral tunnel.
Yeah.
Zoom
Can you
out.
see?
Yes, yes,
Yeah, let's go. Yeah.
yes.
Can you see
Button is
that the,
going.
it's just going to cross the tunnel now?
Yes.
Can you appreciate it?
Yes, we can see the tunnel going in the tunnel. So there is a mark there also. So that will confirm the your tunnel placement on the lateral cortex.
Yes, absolutely. And I'm going to pull it down and I'm going to rock the button on the lateral side. Can you appreciate the rocking movement and
Yes,
the
it's
button not coming down?
button is fixed on the lateral cortex now.
It's fixed on the lateral cortex, it's flipped. And this is my marking for my tunnel. So I marked it at
Yes,
about 30, and this is where my marking is. Can you appreciate that?
yes, we can see the marking matching with the length of the tunnel.
Now I'm to push my graft inside the femoral tunnel to about 20 millimeters, which I have marked. Hold the leg, please. Yeah. Yeah, let's go, guys. So my graft is now come into the joint from my medial portal. This is my first mark, and this is my 20 millimeters mark. Yeah,
Yes,
that's
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 20.
that's fine.
Okay.
That's fine. We pull it up again. Uh, I'm going to now pass the other side of the tightrope into. Oops. Okay, so if you remove the tunnel by mistake, the movement of the tunnel, we are going to just pass the loop again. Give me 2 minutes, please. No, I'm stinking. Give me anything. Give me anything. Sorry about this. Single. Mm. Now, this is going to be a struggle to find that socket. You'll have to bear with me for 2 minutes. Sure. Mm. This is the only flip side of having doing all inside is that, you really can't see the small 4 millimeter button or 4 millimeter hole of the socket. Can you hold it? Yeah, I want to take it out from there. Yeah. So I'm going to take this Ithobond from the same portal as I had earlier, and now I'm going to pass my graph from that. Yeah. 1 second. Where is the? Just pull the. Mm. 1 second. 1 second. Yeah. So I know that it's in the same portal, and I'm going to now pass my graph. It's like a virtual cannula that I'm making when I'm taking all these loops together. It's like a virtual cannula. So
Do you ever use passport cannula? Do you find this helpful or more cumbersome?
I'm passing my graph on the hill side now, and you'll see the button coming there soon.
Yes, we
And
can
the
appreciate.
graph now, and this is what my graph will look like once I fix the tibial button. So can you appreciate that? Can you have
Yes, inside picture, please zoom out the inside picture. Arthroscopy picture, please zoom out.
You want me to zoom it out?
Yes, we can appreciate very robust craft sitting in a perfect tunnel. So,
Yeah. So if you can appreciate, I'm right in the center of the footprint on the tubular side, and there is no screw now. I'm going to. Can you stop the arthroscopic picture? Let's show the outside picture. This is how I'm going to tie my button. Hmm? No. Can you show the outside picture, please? वो वाला निकाल दे जरा.
फर्स्ट आप लॉक करके चलो बताओ
दिख नहीं रहा है. Can you show me properly?
चलेगा ये वो बराबर रहेगा सीधे क्लियर है
So now I'm going to tighten my this still tight rope. Can you appreciate that now it's sitting? Can you see that? Can you see the
yes, we can see. Please focus on the. Yes, we can see the button there on the tibial cortex.
on the tibial side? And I personally like to make some half hitches on top of that so that it is well secured. Can you put a finger, please?
So, how many knots are you usually keep in over the
The half hitches and one reverse half hitch and then one again normal half hitch.
five
Just
or how many? Five knots, half inches.
yes.
Okay.
I'm going to now have my inside picture again.
Please go to the inside picture, arthroscopy picture.
And can you give me a probe and a cannula, please? I'm just going to just clear out all the muck to have a better vision. And I'm now going to give me a probe, please. I'm going to feel how my graft, how taut it is. Now remember, I have drilled to about 25 in the female tunnel. Um, my graft inside is 20 millimeters. I still have a 5 millimeter leeway. So I think my graft is a little lax, so I'm going to pack up now. As my assistant is tightening the tightrope, okay, my graft is getting taut. So this is the advantage of the tightrope or any kind of flexible device where you can shorten the loop and make the graft short. The only thing is that you should remember to make the tunnel move, just away from the lateral cortex, so that you have enough leeway for the graft to go up. Can you move a little more?
Yes, graft is now slack is gone in the graft, so it's
Yes, yes,
damn tight.
yes.
We can appreciate.
Yeah. So I think, let's call it a day.
Okay, thank you for a wonderful demonstration, Dr. Amin. Okay, thank you. We'll catch up soon. Thank you. We're closing the live now.
Thank you so much. Camera off, please.
Voice clear, but voice clear. Clear on the voice clear. So good morning, everybody. We'll get on with the first session of talks. So can I request Dr. Ramanamurthy and Dr. Naveen Palla, please can you chair the session again? Dr. Naveen? Yeah. First is on the approach to EMRA, radiologist. Okay. Good morning. First of all, congratulations, Sridhar, Aslam, and Praveen for conducting such a wonderful meeting. And of course, it's a Wi-Fi is giving us such a wonderful transmission. We have to adopt in everywhere. I think we need not have a wires. That also they proven. And now I request Dilip Kumar to give his lecture on approach to knee MRI. Dr. Dilip.
Yeah. Good morning, one and all. I would first of all like to thank the Indian Arthroscopy Society and Arthroscopic Association of Andhra Pradesh for giving me this opportunity to speak in front of this esteemed state and national faculty. There was a beautiful demonstration of arthroscopic reconstruction of ACL and meniscal repairs just now, and most of you might be well aware of these imaging techniques because you will be doing arthroscopy as well as you will be seeing the films. You can correlate well. We don't see those arthroscopic images very often, so you might over report or under report, but you will be more well versed with these images, and this will be just a refreshment of all the knowledge which you have already. I'll be briefly touching about the key imaging features of ligament injuries and meniscal injuries. So coming to the knee MRI protocol, whether to do it on 1.5 Tesla or 3 Tesla. Always 3 Tesla is better than 1.5 Tesla. In case there are any stainless steel implants or something else, then you can go for a 1.5 Tesla to decrease the artifacts. But if available, 3 Tesla is better. And the main important sequences which we use to interpret MR are PD fat sat images and PD non-fat sat images. And it's always better to do it in a dedicated knee MRI, a coil. If the patient is very obese and if the knee is not fitting into the coil, then we can use the body coil. These are the primary knee stabilizers, cruciate, collateral ligaments, and menisci. Coming to the most commonly injured ligament in the knee, the anticruciate ligament. This is intracapsular and extrasynovial ligament, and this is composed of from 2 to 5 layers of the fibers, and there can be fluid or fat in between the fibers. So if you see all the other ligaments, they will be very black on MRI, but this ACL sometimes can be bright even in a normal patient. This is because of the fat and fluid between the fibers. So we should not interpret that as an tear. We have to look for the continuity of the fibers. Here, if you see the ACL, you can see from the tibia to the femur very well on coronal images. And on sagittal, it is parallel to the intercondylar roof. So if there is any disruption of the fibers, we call it as partial tear. If there is just edema, then we call it as the grade 1 injury. If there is complete tear, then it's grade 3. So in partial tears, it can be either low grade if it's less than 50% of the fibers are involved, and it's high grade if more than 50% of the fibers are involved. So here we can see there can be focal disruption, or sometimes the, the angulation between the ACL and intercondylar notch can be altered. It can be flat ACL, or the ACL can be completely replaced by the fluid, and sometimes there can be wavy outline. These all points towards the partial or complete tear. So in axial images, we see for the empty notch because in intercondylar notch we have to see two structures, the ACL and PCL. If one notch is empty, then we can suspect ACL tear. Sometimes in chronic tears, due to there can be some cyst formation, ganglion cysts within the ACL. So this is suggestive of some partial chronic tears. And on X-ray, we can see joint effusion in the suprapatellar recess, and there can be concave depression in the lateral condyle. This is due to impaction of the lateral condyle with the tibia in the ACL injuries. So this is a very important pointer on X-ray to diagnose any ACL tear if suspected. So the same corresponding pictures on MRI. Here we can see the cortical depression of the lateral condyle with edema, as well as in the tibial plateau. So sometimes there can be anterior translation of the tibia in relation to the femur because of ACL injuries. In these cases, we can draw a line parallel, perpendicular to the cartilage of the femur and the posterior tibial plateau. If the distance is more than 5 mm, we can suspect complete thickness tear of the ACL. Sometimes there can be avulsion injury of the tibial spine, but the ligament can be still attached to the spine and the spine might be displaced. So it is very important to mention whether the ligament is still attached to the bony fragment which has been fractured. So the mimickers of ACL injury include ACL mucoid degeneration. In many patients, we see the ligament will be grossly thickened and hyperintense. But if you trace the fibers will be intact from the tibia to the femur. So in these cases, it is sometimes difficult to diagnose a low-grade partial tear. So we might label it as mucoid degeneration, but you might feel that there is some laxity. That might be because of difficulty in diagnosing partial tears. Of course, complete tears even we can diagnose on even in a background of mucoid degeneration. But in these cases, what we have to see is the secondary signs of ACL injury, like bone marrow injury, trabecular injury, all those things about the surrounding soft tissue edema won't be seen in a case of mucoid degeneration. But in case of ACL injury, we will have all the other features. Um, now, just now we have seen the beautiful demonstration of ACL reconstruction. In this, we can see the tibial tunnel. The tibial tunnel has to be posterior and parallel to the intercondyle notch roof or the Blumenstadt line. And we have to trace the fibers from the tibial tunnel till the femoral tunnel. And the femoral tunnel, the lowermost point of the femoral tunnel should be at the point of intersection between the intercondylar notch and the posterior quarters of femur. So we have to look for any widening of the tunnels or any fluid within the tunnels, and for the fiber continuity in both sagittal and coronal images. So in case of post ACL reconstruction also, always 3 Tesla is preferred because it gives a better spatial resolution, and the titanium implants will have less artifacts. So along with this, we have to look for any re-tears of graft if there is any recent injury. Here we can see the focal disruption of the graft fibers with intact fibers within the tracts. Sometimes there can be fibrosis of the synovium or the Hoffa's fat pad adjacent to the tibial attachment. So this is the cyclops lesion. So this can cause pain for the patient during flexion or extension. The graft might be intact, but there can be fibrosis. So this has to be treated. PCL injuries, the grading is the same. Grade 1 is just sprain, grade 2 is partial tears, and grade 3 is complete tears. Here in the first image, we can see there is a small edema, but the fibers are intact. So that is just sprain or some mucoid degeneration. But in the second image, we can see there's partial disruption of the fibers. So with intact rest of the fibers. So it's partial tear. In the next image, we can see there is complete disruption of the fibers. So it's grade 3 injury. Sometimes there can be, just like tibial spine fracture, there can be post-tibial fracture, which can be either displaced or undisplaced. And we have to mention whether the post-tibial plateau fracture, the fragment has attachment of the PCL, or even the attachment of the bony fragment and PCL is torn. So PCL injuries are very less common compared to the ACL injuries, and they can be missed. So we have to very carefully look for PCL injuries. And unlike the ACL PCL injuries, meniscal injuries are graded as grade 1, 2, and 3. But it's preferably better not to call grade 1 and grade 2 changes as tears. In meniscal injuries, only grade 3 signal abnormality should be called as tear, because grade 1 and grade 2 are just because of degeneration within the meniscus, and they can be seen in even young patients. Grade 1 is just focal nodular hyperintensity, and if the hyperintensity is little longer, then we call it as grade 2. We call it as grade 3 only when the hyperintensity reaches either a capsular surface or the inner margin or the superior or inferior surface. So only grade 3 signal abnormality should be labeled as tear in case of meniscus, unlike the other ligaments where even grade 2 can be a partial tear. So there should not be confusion between these labeling. So here we can see the first image shows the focal hyperintensity, it is grade 1. And if it is linear and involving more surface, then it's grade 2. But in both the cases, it should not reach the inner margin or outer margin or superior or inferior surface of the meniscus. And in the next image, we can see it is reaching to the inferior surface. This is the horizontal tear. This is grade 3 signal abnormality in the meniscus. So criteria is like there has to be a meniscal distortion or altered morphology in absence of a prior surgery, and the intrasubstance signal intensity should unequivocally contacting the articular surface. So in a radial tear, we can have a truncated triangle-like appearance. Anterior horn, you can see this very beautifully the triangle appearance, but the posterior horn there is a truncated triangle because of the radial tear of the inner margin. Sometimes we can see a bucket handle tear. So as I told, in the intercondylar notch, there has to be only two structures, PCL and ACL. But if you see any third structure, then you have to suspect a bucket handle tear, either from the lateral or medial meniscus. More common is medial meniscus. And corresponding coronal images, if you see, the medial meniscus, the volume has reduced compared to the body of lateral meniscus. This also indicates that there is a fragment which has herniated into the intermeniscal intercondylar notch. Sometimes in the horizontal tears, we have parameniscal cysts, which are very common. They can grow in large size and can impinge on the surrounding structures, giving rise to pain. So they have to be treated. These parameniscal cysts are less common in vertical tears and very more common in horizontal tears. So sometimes there can be complex tears where there can be either both vertical and horizontal components. We label it as complex tears. So one more tear which is commonly missed is the posterior root tear. It is near the medial most attachment of the posterior horn of the medial meniscus. And if this tear is missed, there can be lateral medial subluxation of the body of meniscus, which might lead to early degeneration and osteoarthritis of the medial compartment of tibiofemoral joint. So this has to be carefully looked. In the coronal image, you can see the medial meniscus, the posterior root is torn. So sometimes there can be like mimickers of tears, like there can be intermeniscal transverse ligament anteriorly, and the vertical line between the intermeniscal ligament and anterior horn should not be mistaken for a tear. It's a normal finding. And sometimes there can be fluid between the tibial posterior horn of lateral meniscus and popliteus tendon. So this should not be interpreted as tear. These are normal anatomical findings. Sometimes most patients we have the speckled appearance of the anterior root of lateral meniscus, which is seen adjacent to the ACL attachment. This is common finding. So this speckled appearance should not be confused as vertical tears. This is a normal finding. And just like the grading of ACL, PCL, collateral ligaments is the same. Grade 1 is sprain, grade 2 is partial tear, grade 3 is complete tear. Partial tear can be even high grade and low grade. So here we can see grade 1 is just like soft tissue edema, which is seen surrounding the collateral ligament, but there is no disruption of the fibers. We can trace the fibers from the femur to the tibia. In grade 2, the second image, you have that focal disruption of the fibers and there is some edema along the fibers, along with the edema surrounding the fibers. In grade 3, there will be complete tear either at the superior or inferior attachment or in the middle one third, and there can even be avulsion of the bony cortex as well. So it is very important to mention the avulsion fractures also. Coming to the patellar retinaculum, generally medial patellar retinaculum is lax and thin compared to the lateral patellar retinaculum, and it is wavy in outline. In cases of twisting injuries, most commonly injured is medial patellar retinaculum and medial patellofemoral ligament. This leads to lateral subluxation of patella. So when the lateral patella is laterally subluxated, the medial patella will impact with the lateral femoral condyle. So there will be kissing contusions. So there can be osteochondral injury. The cartilage will be hyperintense. There will be bone marrow edema. So you have to be when you see this picture like medial patellar facet and lateral femoral condyle edema, you have to carefully look for any medial patellofemoral ligament injuries and tears. So if not treated, there will be recurrent subluxation of the patella, leading to early osteoarthritis of the patellofemoral joint. So, MRI is an best imaging modality for diagnosing knee injuries, and proper diagnosis and grading of the injuries is very important because sometimes partial tears can be healed on their own, but complete tears have to be treated to prevent early arthritis changes, and careful examination of all the structures and associated injuries. If there is any ACL injury, you have to look for any meniscal injury or collateral injury so that comprehensive report has to be given. Thank you.
Thank you, Dilip. You stay on the dais. So there is some points wants to cover from live.
Sure.
Please connect to live.
Progress.
Yeah, please. Yes,
Can you hear me, please?
yes, Rajani, we can hear you. Yeah, please.
Just wanted to show what anterior drawer looks like right now. If you can see, I'm unable to fix the tibia anteriorly at all. It's a very, very quick stable joint. and I'm able to achieve full extension on table, which is very important that if your tibia tunnel is too anterior, you will not be able to achieve full extension. So make sure that it is not too anterior. And lastly, I'd like to thank IAS for giving me this opportunity. It's a wonderful program, IAS One. I think it's really, really helpful. And thank you to my team over here, Sister Chini, Dr. Gandhi, the entire OT technicians, Dr. Vishal, Pranay, and the NSA's team. And thank you, Dr. Sridhar. Thank you so much. Lovely hospital, lovely setup.
Thank you, sir. Thank you. Uh, any questions on the topic of MRI knee from the floor? All interested in surgeries only, then we'll go ahead. Yeah, thank you so much, Dilip. Now I request Ajay to speak on diagnoscopy talk.
Morning, everyone. I'm Dr. Ajay Gautam from Gautam Hospital, Coimbatore. First, I would like to thank the Indian Arthroscopic Society and its office bearers, and Prahlad sir and Sridhar sir for having me here. So, my talk is on diagnostic knee arthroscopy. So, going back in timeline, so the first diagnostic arthroscopy documentation was done by Severin Nordendorf, a Danish surgeon, and he described the endoscopy of closed cavities previously. After that, Kenji Takagi and Michael Berman gave their first ever publication on arthroscopy of the knee joint for tuberculosis. And finally, Dr. Masaki Watanabe was coined the term as father of modern arthroscopy. So these were some of the early pictures of knee arthroscopy being done with a needle scope, where the person is seeing inside the knee with his bare eyes, and they were able to diagnose synovial pathologies and cartilage injuries. So, what are the prerequisites for a proper diagnostic scopy? So, a proper patient positioning is required, and proper tourniquet is required. And the normal pressure is around 300 based upon the BMI of the patient. You should have a proper OT setup with an arthroscopic trolley and all the required instrumentation. You should have a proper knowledge about the camera and instrument handling, and you should have at most the proper portals and the maneuvers for viewing the medial and the lateral compartments. So I usually use the leg on the table with two side supports with the knee in 90-degree flexion and 120-degree flexion. The advantage of this position is that you can easily put it into leg hanging position also, and it will be easy for you to go into figure of four position also. Alternatively, some use a thigh holder and other such holders. So you should have the necessary arthroscopic equipments before you go into the surgery. So moving on to camera handling, you should always hold the camera in the upright position such that you anatomically orient to the joint, and you can move the light source in any direction like upwards or downwards. You can view on the left or the right. So normally I use the 30-degree arthroscope. There are 45 degrees and 70-degree arthroscopes, but the commonly used is the 30-degree arthroscope. Regarding the holding the arthroscope, you can hold it, you can wrap around the light source and hold it in your first web space, or you can hold it as the pen type. My preferred holding is the pen type, which is more comfortable and easily reproducible. Similarly, while using the shaver, you can hold it as a pen type or you can use it as a handshake type. Basically, you have to be well versed with both of it, because when you are putting your leg on the table, you have to hold it as a pen type. When you are hanging it down, you have to hold it as a handshake type. So moving on to the portals, the commonly used portals are the anterolateral portal and the anteromedial portal. So these are the two portals which are used for the normal diagnostic arthroscopy. And the other portals include the posteromedial, posterolateral, superolateral, supramedial, and the Gilchrist portal. So before making the portals, do check, do use disposable blades, because sometimes the blade might dislodge inside the portal. And making the portals, you can use a 11 blade. See to that the bevel of the knife is facing superiorly to avoid an iatrogenic injury to the meniscus. So you palpate the inferior pole of patella, which is usually just below and lateral to the inferior pole of the patella. You palpate the soft spot. So the anterolateral portal is the viewing portal created first, which is created blindly. So you palpate the soft spot and you insert the 11 blade. And after that, you insert the trocar. So the trocar should be inserted with the knee in 70 degree of flexion. Normally, 70 to 90 degree of flexion. You'll feel a giveaway. After that, you can extend the knee fully and go into the suprapatellar region. I'll show you the video in the last. But before making the portal, we should be aware of other things such as the patella alta baja and previous scars and revision surgeries. So proper portal placement is always very important, because if your portal is too high, there is difficulty in visualizing the posterior structures. And if your portal is too low, there is a risk of damaging the meniscus. So the appropriate portal makes us visualization inside the knee joint very easy. So the anteromedial portal is the working portal. So usually you can use a trans illumination technique and a needle technique. Usually you can do it at 70 degree or 90 degree flexion, but if you feel the fat pad is pressing against and disturbing your view, you can keep the knee in 30 degree of flexion, which increases the space in the intercondylar region. So always follow the principles of triangulation and rendezvous principle. So normally we go into the intercondylar region and we visualize the medial and the lateral compartments. So for visualizing the medial compartment, you put your knee in valgus and external rotation. And for visualizing the lateral compartment, you put in a figure of 4 position. So if you're not able to visualize clearly with these maneuvers, there are techniques such as the pie crusting techniques, as already discussed in the morning. Pie crusting for the medial compartment is already established. This paper by David Woodward in 2024 said that there is no evidence to show that there is laxity after pie crusting, and those patients do good with a medial opening. The other tip is that you can use a small arthroscope 2.7 or small joint instruments to prevent iatrogenic injury to the articular cartilage. So this is the paper by Vancha, which showed the matching point. You draw a line along the posterior border of the femur, and 1 centimeter above the joint line is the magic point where you will release the MCL for pie casting. Certain techniques papers have described lateral pry casting for lateral joint opening, but I don't personally do lateral pie crusting. Still, its efficacy is I don't know how much it is efficacious. You can one tip to improve the lateral viewing is after putting a figure of 4, you can keep a towel or a sandbag below the ankle to increase the opening of the lateral side. So moving on to the posteromedial portal, we make this portal for viewing while doing a PCL reconstruction or removing a loose bodies or attending a ramp lesions and such stuff. So similarly, we move the scope between the medial condyle and the PCL and go to the posteromedial compartment, and we transilluminate, and under visualization, we make the posteromedial portal. So usually it's between the soft spot between the medial head of the gastrocnemius and the MCL. So these three are the commonly used portals. Other than that, we use the posterolateral portal rarely. It's in between the junction of the biceps and the LCL. The other portals include the transeptal portal, the superolateral portal, and the accessory anteromedial and the anterolateral portals. We saw in the morning the accessory anteromedial portal, which was used to drill the femoral tunnels in the ACL. So what are the problems with the portal placement? The first one is the wrong placement of the portals. And second one is the shifting of tissue layers, because When you change your knee position from flexion to extension, there is a possibility of the portals changing. So in these cases, you can use a passport cannula to be sure. And there is always the chance of iatrogenic cartilage damage if your portal is too small, because you increase force for putting in trocar. And if obviously, if you make too large portals, there is always a chance of fluid extravasation. So this paper by Benjamin D. Ward says the step-by-step guide to diagnostic knee arthroscopy. So this is how I normally do diagnostic knee arthroscopy. Go in, see the patellofemoral compartment, suprapatellar pouch, slowly move over to the lateral gutter and look for any loose bodies or abnormal plica. Come down, go go posterior, visualize the popliteus tendon. Again, you have to come up, go to the medial gutter. Again, a place for lodgement of loose bodies, and again come into the medial compartment and the intercondylar region. So the next video shows how you can visually see the medial and the lateral compartments. So take your probe into the lateral compartment, place it there, and then put it in a figure of 4 position. You can nicely see the lateral meniscus. You can probe around lateral meniscus superiorly and inferiorly. And then again move over to the medial meniscus, put it in a valgus. So I just wanted to show this pie crusting video. You can see the tight space. This is after partial release, and you can see the opening of the medial side after proper pie crusting. So you will be able to easily pass the probe inside the medial joint line and visualize the posterior horn nicely. So complications are part and parcel of every procedure. So the most common is the iatrogenic injury to the meniscus, cartilage, and ligaments. So be careful whenever you're doing diagnostic arthroscopy. And arthropfibrosis, neurovascular complications like neuropraxia if you don't do a proper padding around the knee joint, and DVT if the tourniquet time exceeds beyond 1 hour, CRPS, and infections are other complications. I thank you, everyone.
Thank you, Ajay. Please come and have a seat. We can discuss later, I think, after the day. And I request Ashish to give his talk on craft harvesting technique, hamstrings, and peroneus longus.
Yeah. Good morning, everybody. My talk is on graft harvesting techniques of hamstrings and peroneus longus. So, actually, graft selection and graft harvesting, I think these are the primary and very basic steps for any ligament reconstruction. So, the youngsters who are contemplating into arthroscopy as their career, I think they should be well versed with what are the graft options are available, and they should at least master two to three graft harvesting techniques. And I think I can say this: hamstrings and peroneus longus, both are like very easy to learn techniques, and when compared to the PTP, these have very low complication rates, and even there is a negligible donor site morbidity. So coming to hamstrings, that this is the most commonly used graft, and let's start the video. So this is the most commonly and widely used graft for any ligament reconstruction, not only ACL. And this has been very popular since years, and it is time tested graft. So when generally for my all my ACLs I use hamstrings, both semi-T and gracilis. Where I don't use the hamstrings is if there is any associated middle side injury, or there is complete MCL tear. Then I think I would look forward to the contralateral hamstrings or the ipsilateral peroneus longus. So coming to the technique, so always as a youngster, I think when you are starting your career as in arthroscopy, I think or any surgery, I think bony landmarks, surface marking is very important. That will guide you to the precise to make your incision precise onto the spot. So uh, the incision, I think you can give vertical or horizontal incision just beside the 1.5 centimeters beside the tibial tuberosity, and I am comfortable with vertical incision. And once you give an incision, just go to the deep fascia, open the fascia, subcutaneous tissue, and clear all the fat. Take some time. Here you can a trick or a tip you can say that if the patient is obese, like if you don't if you're not able to see the hamstring insertion, then you can slowly roll your fingers on the posterior middle border of tibia. And then you can feel the insertion of gracilis actually. Gracilis is more tendinous uh, at the insertion point. And once you feel that, I think you can give an incision on the sartorius fascia and fish out the tendons from the sartorius fascia. Spend some time over here. Like, don't be in a hurry. Try to identify both the gracilis and the semi-T, especially if you are doing an all inside ACL reconstruction. I think you need to only take out the semi-T. So spend some time over here, loop the tendons, identify which is gracilis and semi-T. Generally, gracilis is the superior and the proximal graft, and semi-T is the distal and the inferior graft. So once you have identified, then slowly start either with the semi-T, or here I'm taking the semi-T graft. Slowly release it from the insertion point subperiosteally. So I think you get 1 centimeter more extra length if you do like this. Once you have released the graft from the insertion point, then you can take whip stitches and slightly pull the graft outside from the level of tibial tuberosity. Then I think you will be able to see if there is any attachments. Here you can see, don't straight away go and push the stepper inside. You can see some band-like structures, or we call it veniculi. So you need to release these veniculi. Otherwise, you will be, if you directly push the stepper, close stepper inside, you will be amputating the graft prematurely, and you will end up with a short graft. So you need to release the veniculi. Generally, these veniculi are with the semi-T. Uh, with the graceless, I think it's very rare to see, but in semi-T, you see at least 2 to 3 viniculi. So you need to release all the viniculi, use a curved scissors, and the sharp edge of the scissors should be away from the graft. And once you have released the graft, and then you take a closer stepper. Mind you, if you are a younger and beginner, I would suggest you to use a closed stepper, and don't use an open stepper, because you will easily skive off, and you will again either injure the surrounding structures, or you will even tear the graft itself. So use a closed stepper, and whenever you're pushing a stepper inside, maintain a gentle force or pull on the graft, and slowly gently push the stepper inside. Don't be over enthusiastic, don't be in a hurry. Spend some time, gently push the stepper inside, and the graft will be released. Similarly, again, follow the same step for the gracilis. Release it from the insertion with the subperiosteally, and then again pull the graft. Release if there is any bands. Generally, gracilis doesn't have band, but here in this video, we can see there is a band. So you have to release the band, otherwise you will not be able to get the whole length of the graft. I'll just skip it forward. So you can see another viniculi over here. So release it, and then only you put the stripper inside. So the tissue scissors should be, the curved tip should be far away from the tendon. Otherwise, you will directly injure the graft also. So this is regarding the hamstrings. And I'll go ahead with my other talk, that is harvesting of the Perennis longus. The Perennis longus is a newer craft in this field. Like it has gained what do you say, that it has gained a lot of importance recently because it is a very simple technique, easy to harvest, and it has a very high tensile strength when compared to the hamstrings graft. So it is thicker, wider, and longer when compared to the hamstring strap. And even the complication rate is very, very minimal. And even the donor site morbidity is also very, very low. There has been papers, but there are no longer studies on this. But these papers suggest that there is minimal morbidity, and even the foot and ankle scores are good even after the harvesting of the perennis longus tendon. So generally, I reserve my perennis longus graft only for my PCLs because PCL reconstruction requires a thicker and a longer graft, and perennis longus absolutely suits for the PCL reconstruction. So I'll go ahead with the video. Again, as I said, that it's always good to have surface marking if you are a beginner, and start your incision just 2 centimeters from the tip of the lateral malleolus, and give 2 to 3 centimeters. If you're a beginner, don't hesitate to give a wider, bigger incision. Once you incise, you go into the subcutaneous tissue and directly land on the peroneal sheath. So open the peroneal sheath and you see two tendons over here. So the identification care you have to take over here is to you need to identify which is peroneus longus and which is peroneus brevis. So the brevis is actually, there are points. The brevis is actually slightly deeper and anterior, whereas the peroneus longus is superficial and posterior. Another major important point is that peroneus longus is more tendinous. It doesn't have any muscle attachment, whereas brevis has a thicker muscle attachment, as you can see over here. After you have identified the tendons, you are sure that you have taken peroneus longus. Try to invert the foot so that the graft exertion is more into the wound. And here I do tenodesis of the peroneus longus with the brevis, with whatever advantage it has. I'm just used to doing this tenodesis. After the tenodesis, take a loop around the peroneus longus. I'll just forward it. Loop the peroneus longus, and distal to the peroneus longus, you cut the tendon. And before you are taking a whip stitch, it's all peroneus longus is a thicker and wider graft. Actually, here it is very thin. It's a female patient. You have a thick and wide graft, so you need to do bulleting. Otherwise, your stripper will not pass into the mouth of the stripper will not pass into the graft. So after you've done that, loop the take whip stitches again, and then you pass your stripper. One important point is when you're pushing the stripper inside, ask your assistant like this to put his finger as a guide. So you should know, you should not push the stripper completely up to the neck of the fibula. Otherwise, you will be doing an iatrogenic injury to the common peroneal nerve. So be careful. Ask your assistant to put his fingers below the fibula head, then push the stripper inside, and just restrict your push stripper up to the fingers of the your assistant, and then you can get the graft nicely. So this is the thicker, wider graft. Though it's a female patient, we are seeing a slightly thinner graft. So I'm done. Thank you very much for patience hearing.
Thank you, Ashish. Now I request Aslam to give his talk on graft harvesting techniques again, and BPTB, bone patella.
Morning, everybody. It's very nice to see a packed hall on a Sunday morning. Continuing with the topic of graph harvesting and graph options. Um, One thing that we can say about Petlatin is it still remains to be the gold standard. It may not be the most common, but could be the most appropriate tendon for all purposes. Okay. Now, just for curiosity, I'd like a show of hands on all those who do ACL surgeries here in the hall. Can you lift your hands, all those who do ACL surgeries? And keep your hands elevated if you do it with a patellar tendon as a primary graft. So we are in a terrible minority. Yeah. In fact, actually, during the COVID days, we had a lot of webinars, and one very senior arthroscopic surgery, in fact, mentioned that it is 100 times more difficult than doing a hamstring graft. Okay, so one reason probably is that we feel that it's more difficult. Second thing is that we are very worried about donor site morbidity. So I'll try and address both these issues by the end of the talk, and I hope to make it much more simplified for you. We have a lot of ACL surgeries going on, and sooner or later we are going to have revision ACL surgeries. So when you don't have a hamstring, what are you going to do? Okay, so you either go to peroneus or you go to a patellar tendon graft or a quadriceps graft. So just be prepared with other options so that you can progress with surgeries. And now we are seeing motor vehicle accidents which require multiple grafts at the same time. Okay, so we start with the okay. You first take your surface marking. We're just trying to make it simple for you. You first check with your surface marking, inferior surface, inferior pole of your patella, tibial tuberosity, both the margins of your patellar tendon, medial lateral. Take your sizing, so middle 1/3 or 10 mm in the middle. Okay, and then gently slide your blade down along the collagen fibers without using too much of force. So once you do that, you have the marking. Mark your tibial bone block, which should be ideally 2.5 to 3 centimeters in length and 10 mm in breadth. Just make sure that the continuation of your fibers is with the continuation with your bone block. All you require is a 10 mm blade, which is 0.6 mm in thickness, which makes your life very easy. The depth should be about 8 to 10 mm. And make sure that you go all around your block, leaving no attachments of bone or soft tissue. And then use your osteotome. Here I'd like you to observe that just by using and simply moving the block around, you can just lift it out of the bed. We haven't used any force or pressure while removing the tibial block. Remove the attachments, elevate it from the fat pad. Okay. Wrap it up in a antibiotic soaked gauze so that it helps in two ways. One, moistens it with antibiotic. Second thing, it gives you enough pressure in your hands to stabilize the patella and mark your block on the patella. So your patellar block also is marked with 2 centimeters length approximately and 10 mm in breadth. Now stabilize the patella with your fingers. Okay. Hold your blade horizontally so that you don't skive off deep into the patella. So these are just some points simultaneously on both the sides. And finally, your proximal end. Just see that you're all connected all around. Once you're sure that everything is clear, turn your saw around. Okay. Just clear of the block because you're going from under the patella to remove a block of bone. This is the modification that we have used. Okay. Support the blade with your middle finger and gently in full power, just slide it down and then you have your block in your hand. Okay. So there is no force used for which we were afraid of post-operative and at a later time you have chondromalacia of the patella. So you now have a 10 mm graft without using any force, simply in quite a short time. Now what you need to do is to be able to get it through your tunnels. Once your tunnels are formed, the only issue with a bone block is that it doesn't travel as smoothly as a hamstring tendon. So it is your responsibility to see that you smoothen out the edges and allow it to pass down through very smoothly. The other aspect you would have noticed that we haven't made any drill holes before removing the patellar tendon. So the only reason is that once you size your blocks and then you know about 4 or 5 mm, you leave that a distance of 4 to 5 mm from the edges before you make your tunnels, making them much more strong and they don't fracture in your tunnels. Okay. So remove all the soft tissue. And I would suggest that if you're doing a patellar tendon, then you do it by yourself because your assistant may not be as good as what you are. And then you get into trouble because of somebody else. Okay, you size both your femoral and the tibial blocks. It is worth spending time on preparing the tendon than struggling when you're operating. Now leave 4 or 5 mm from the margin, from the end, to make your drill holes. And if you notice, we are making them from the cancellous bone side. So you don't engage the soft tissue while drilling. So ethibond 2 or ethibond 5 can be used on the femoral side. And I tend to use stainless steel wire on the tibial block so that I can tension it enough before I put my interferential screw, which is normally the implant that I use. So you have a very robust, a big tendon, which theoretically is the most viable of the lot at present. Finally, I'd like to finish by addressing the patellar morbidity. So there is always some amount of cancellous bone that you have left over. Just pack it up into the patella, and within 3 weeks, you have good bone growth in there. So you have addressed number one, the requirement, number two, ease of harvesting your tendon, and addressing the morbidities that are related to the bone patellar tendon bone harvest. That you haven't used any force, and you're compensating the patella by using a bone graft. Thank you very much.
Thank you, Aslam. There is one more talk in this session itself. Ideal tunnel placement in ACL reconstruction by Dinesh Chidambaram.
Thank you.
Good morning, everyone. At the outset, I would like to thank the organizing team for giving this opportunity. Myself, Dr. Dinesh Chidambaram from Coimbatore. Today, I'm going to cover about ideal tunnel placement in ACL reconstruction video techniques. So, coming to the anatomy, it's a complex ribbon structure. It's wider at the insertion, particularly in the tibial side, than at its midpoint. So, it's impossible to achieve the entire footprint coverage using a conventional cylindrical graft. So this article by Freddie Fu, he showed that accurate tunnels are critical for successful ACL reconstruction because it ensures appropriate graft positioning and thereby restoring the normal knee kinematics. We all know what can happen if the tunnels are placed wrongly and the clockwise concept is no longer followed. The conventional transtibial technique, it's more of a vertical tunnel which leads to poor rotational stability, thereby ending up in failures. So this is a recent anatomical reference term as described by Clancy. The first is the intercondylar ridge, which is the anteriormost limit of the ACL. And the second is the bifurcated ridge, which separates the anteromedial from the posterolateral bundle. These landmarks are present in most of the cases, even in chronic scenarios. They help to place the tunnels anatomically. So what is anatomic on the femur? All tunnels which falls within this large footprint of the native ACL can be considered as a anatomical ACL reconstruction. So when we move from transtibial to anteromedial low portal tunnels, initially we had good results in terms of rotation stability, but in the long run there is change in the length when compared to the uh, low anteromedial tunnels, which increases the forces on the graft, ending up in graft failures. So this article they compared between anteromedial bundle versus central position. Though there is no difference in stability at time zero, in the long run there are more re-ruptures when we place the tunnels centrally. So they concluded that anteromedial bundle position is more isometric to the native ACL. This article in AJSM, they showed the concept of direct fibers, which are just underneath the lateral intercondylar ridge. They bear most of the load, particularly they are the main resistance to anterior translation and internal rotation because they got greater density of collagen fibers with highest tensile strength. So how the tunnel position should be? Based on that acronym, it should be isometric, should involve the direct fibers, that is just under the lateral intercollar ridge, and should be anatomical and eccentric, high and deep in the notch, and should be low tension throughout the range of motion. So coming to tibia, the insertion points could be triangular or elliptical. So we have various landmarks like lateral meniscus as demonstrated by Dr. Amin in the live surgeries. We have PCL, medial tibial spine, intermeniscal ligament. Ideally should be the center of the remnant so that there is no impingement and got better rotational stability. So going to the video technique, the first tip is to place the anteromedial portal, just brushing the femoral condyle so that we get good trajectory when you're going for the femoral tunnel. Here we could see the tibial remnants. So first we start preparing the femoral footprint with the help of shaver. Particularly radiofrequency ablator is used to skeletonize the footprint so that we can go for those reference terms. We can go all the way up to the posterior articular cartilage like shown here. Go all the way up. That is the posterior femoral cortex. And in line with that is the lateral intercondylar ridge. So first here I mark the entry point with the help of RF. Then weaving to the anteromedial portal, I just reconfirmed whether it's an ideal position in the high and deep. So once the position is satisfactory with the help of microfracture all, that is the lateral intercondylar ridge, just beneath it, targeting the direct fibers, particularly the AM bundle, center of the AM bundle. Just few gentle blows. As usual, just again reconfirm by weaving to the anteromedial portal to see the adequacy of posterior cortex. Once we are happy with the position, with the bead pin and knee in hyperflexion to get a good length, just through and through drilling done. Here we can feel the second cortex resistance. That of tunnel length should be somewhere around 40. Once the reaming is done, we can use the endo button reamer then. With the help of depth gauge, we can measure the tunnel length. It comes around 40. So it's better to clean the debris with the help of shaver or every time you ream it. Then here adjustable loop is selected. So a socket length of about 20 mm is reamed. So when we weave from the anteromedial portal, we can see the adequacy of intact posterior cortex. Then shuttling is done. It's better to do before any meniscal procedures. Then comes the tibial footprint assessment. That is the lateral meniscus, posterior bord of the anterior round of lateral meniscus. You should always go for the center. With the elbow of elbow image jig, just in front of the PCL, that medial tibial spine, just in the center of the remnant. Once you're happy with that position, bead pin is drilled. Right now, we can confirm whether we are medial or too anterior with the by checking the impingement thing. Once we're happy, then we can go with subsequent reamers. It's better to protect with curate to avoid any inadvertent damage to the cartilage when you are trying to drill. Then this technique we can still adjust after 6 mm reamer to move a little bit more medially or anteriorly. Once tibial tunnel is done, we can shuttle the fiber. It's brought down and then the graft is passed. Here we can see through the anteromedial portal whether it's flipping under vision. We can see that mark is matching the tunnel length. So this is the final reconstructed ACL with good tension and intact posterior cortex. And in the end, always try to retain this fan-shaped attachment on the tibial side. It has got good mechanoceptus, which is good in assessing proprioception. Always check for impingement at the end. This is the final image. And in this technique, when we try to preserve some remnant, we can't take out like previously described. So just with probe, just mark the AM bundle. It's better to use an offset here, go all the way underneath the posterior articular cartilage with knee in hyperflexion. Then we can go for routine drilling and other stuff. first with the help of bead pin, followed by endobutton reamer and 8 reamers. So at the end, we can see the intact posterior cortex. So this is the help of offset. So the take-home message is we should play the tunnel portion ideally as described the acronym. It should be isometric, should be involving the direct fibers, should be eccentric, high and deep and equidistant, and anatomical and low tension, so that there is no change in the length through the knee range of motion. And for tibia, with other landmarks like lateral meniscus and PCL, should go for the center of the remnant. So the goal is to restore the normal knee anatomy, thereby restoring the knee kinematics. Thank you.
Thank you, Dinesh. Now questions from the floor, please.
So, Dinesh, very
Yes, sir.
nice talk.
Thank you, sir.
So, I have a few questions with uh, Dr. Aslam, sir. So, just for discussion's sake, Aslam, sir, I have seen, I've been seeing you operating since 20 years. So, you're more fond of doing BTB grafts, and I can definitely say you have more experience in BTB. We are all fancy of having more of hamstrings and all. Only revisions we do BTB. So with that vast experience, could you please tell us any chances of anterior knee pain happening with BTB grafts?
Anterior, sorry?
Knee pain
Anti-knee pain.
post-op.
Yeah, in fact, that has been an apprehension all around.
Yeah.
And every conference, there are two things that come up: is pain while kneeling,
Yeah.
and anti-knee pain for other reasons. Of all the procedures that we've done, in fact, maybe one or two of the 2.5, 3,000 procedures that we have done would have really complained about anti-knee pain.
Okay.
So here, if you give them a good stability, the other things really don't matter. The only thing that the advantage is that bulk of the procedures we have done under Aragyashri, which is a below poverty line people.
That's
So
the boon for expertise.
yeah, and most of these patients don't come to you for follow up.
Yes.
They vanish after the surgery,
Yes.
and they only will come back maybe 2, 3 years later, saying that I have some kind of a problem. So under this situation, I think it is the safest graft to use. So, and we've had good 12-year, 14-year follow up without any issues in terms of laxity of tendon,
Yes.
instability.
Yep.
So that gives us added encouragement
Yes. So
to
thank
use
you.
this tendon.
Thank you, sir. And one more point to add is when you are sizing the graft, I've seen you doing with your own hand. That is really good technique. So because I want to add with this, if you're drilling it and putting ethibond and trying to stretch it over the tunnels or over the sizer, sometimes the graft will peel off. So that's the really good technique you're doing with your own hand. Thank you.
Yeah. Thank you.
Sir, if I may add, I think the anterior knee pain regarding the bone patellar tendon bone, I think it's been a very important thing. But as people who are doing more BTB, of course, we are doing more of other grafts for the primary situations. But as an arthroscopic surgeon, I think we have to know the harvest technique for bone patellar tendon bone, and we have to be aware of it because there's always a graft to go back to. Actually, various papers have shown that if we suture back the parotinon on either side, after 7 or 8 months, we again can reuse the bone patellar tendon bone graft again. So this, according to me, this is an overhyped phenomenon, anterior knee pain. Most of the patients do not complain of this. They come back with normal strength. They can kneel, they can squat and do things. But if we do not close the parotinon properly, I think people can have, but otherwise it's theoretically not a problem.
Yeah, you're absolutely right. That's what we've noticed.
Ashi.
bone metal tendon, as you know, it has two bones in two tunnels. Okay, so you can hasten your recovery process, whereas hamstrings require uh, 6 weeks at least of protection with a brace. Here, you do not require a protection with a brace. You can start on the second day. But we normally, as a routine, we allow non-weight bearing for 3 weeks, followed by partial weight bearing to full weight bearing from 3 to 6 months. Range of movement right from day one.
Day one, how much range of movement you allow in the first week or second week or
Complete range of movement.
complete
In
range of
fact,
movement
yeah,
from the early on?
we are more interested in having a full extension than
Yeah.
flexion. So
Okay.
we advise more of quadricep strengthening exercises and see that the lag is in there.
Okay.
Extension lag is in there. So that is what we concentrate on. Flexion either way does come.
Okay. Sure. Thank you. And
Sir, one more question, sir.
one more question
Have you
to Dr. Dinesh Garu regarding the tunnel placement. What do you say about drilling the femoral tunnel through the tibial tunnel or separately from the medial portal?
Separately from the transportal middle portal.
Okay, okay. Some do have a habit to drill it through the tibial tunnel. The advantage or disadvantage in both techniques.
Through transtibial, it's always more of vertical. We can't get the femoral footprint anatomically unless we go through transportal.
Okay, okay. Thank you.
Sir, question to Aslam, sir.
So like this, the question of transportal and transtibial. While you're using a patellar tendon, you can use a transtibial also. But only thing is that instead of going from the midline, when you put your tibial guide and you use it from the midline, you just face it away, 2 centimeters away, close to the lateral margin. So when your guide wire exits, it's exactly where you want to enter into your femoral tunnel. So if you tried once or twice,
All are young arthroscopy surgeons. I think we should give a message that the most important part of ACL reconstruction is to recreate the normal anatomy as much as possible. I agree, Aslam sir. Most of our, for example, one of our Sanya Mirza has a trans tibial ACL, and she has played. She has won international tournaments after that. Which means the ACL is working in that. But various papers, research, our seniors' experience has undoubtedly told transportal is the way to go. As young, we all should give be being given a message that anatomic ACL reconstruction is the most important part, and that is where most of the failures happen because of the wrong placement of the femoral tunnel. 40% of the failures are because of wrong placement of the femoral tunnel. I think that is the most important. I think proven point is to stick to anatomic reconstruction. Thank you.
point well taken.
One more question to Ashish. When you take as a primary graft as a peroneus longus for ACL, any specific indications like females, short nature?
No, sir. Only when the hamstring is I won't be taking the hamstring like any medial side injury, multi-ligament scenario and all. Then I think I'll go ahead with the peroneus longus, sir. Otherwise, my go-to graft primary is hamstrings only, sir.
Any adding points from faculty? For peroneus longus as a primary graft, because peroneus longus is easy to take and it's a good tensile strength, whatnot. Nowadays, many of people are choosing as a primary graft for ACL as well.
This is Dr. Dinesh from Chennai, sir. Peroneus longus, I usually do in a multi-ligament setup, ACL with MCL. But for primary ACL, I feel for if the graft is inadequate or if you prematurely amputate the CEMITI graft, hamstring graft, sometimes it happens, very rarely it happens. Or if the person is BMI is very high, I feel the peroneus grafts are more thicker than the hamstrings because not in everyone we get adequate except for sports people we don't find good thickness of the graft with CEMITI. So I find peroneus is more thicker and stronger than CEMITI grafts, so I switch it primarily for obese people. The BM is high.
Yes, please.
So we've published a paper in Indian Journal of Orthopedics with a group of 200 patients who are female obese patients, and we've seen their hamstring tendon, and we've realized that they were very, very thin. So even if a quadruple or a six bundle, we would not get about eight. So we decided to switch to a peroneus longus, and we published this technique, and we've done a 3-year follow-up with them, and then did an MRI after that, and patient is comfortable, the outcomes are very good, and the graft looks very good on the MRI as well. So I would suggest that, in patients who are obese females, short females, it's always better to go directly to the peroneus longus rather than harvesting anything else.
Right.
On that note, I think if we take the tensile strength and the collagen percentage for that matter, both hamstring and peroneus are comparable. The thing, the point of interest these days, which has more collagen and which has more tensile strength, is the quad tendon. Uh, we all know quad tendon is around 20% more collagen than our hamstrings or the peroneus. So it resists tensile loads more better than these two other tendons. So for those patients with ligamentous lax, obese patients, I think people are opting for more and more of quad tendon for these reasons, because the load to failure ratio is very high in case of quad tendon. This is premature still. We don't know which is better, but I agree with Amin sir. I think peroneus is good, especially because it is easy to harvest. Obese females, it is straightforward.
Yeah,
But
we've not done a comparative study between a quads and a peroneus longus. Obviously, the tensile strength of quadriceps is much better, but we're talking about housewives, Indian housewives, short, stubby females. Cosmesis is also not an issue because, your peroneus longus, the harvest scar is pretty small as compared to that of a quads, unless you're using some device from the company. Generally, you would have a little bigger scar on the above the patella, which many people would not like, depending upon what kind of patients you treat.
Fine, sir. One more question to Ajay. You are talking about the pie crusting, which we do it in arthroplasty for the soft tissue balancing, of course, which was coined by Ranawat. So, how frequently you do it? What's the indication like, and how you do it? To perform the pie crusting.
Yeah, we don't do regularly do pry-casting because in normal regular scopies where you want to see both the medial and the lateral meniscus, we can well visualize with a normal scopy only. So with an good valgus stress and an external rotation, we will be able to see the meniscus entirely. The problem comes when you want to address the posterior horn, when you do a root repair, or when you want to go to the do a posterior horn repair, then you need some extra opening about the medial side. So it is then we do a pry crusting. We don't do regularly pie crusting.
Exactly, because it's open like anything. Sometimes we have to use the needle only, not more than that for the pie crusting. Of course, it opens in the flexion, especially it opens in the flexion. Thank you so much, sir. Any last few questions from floor? Yeah, please. Somebody take the mic.
Sir, open versus closed strippers, sir. So when do we use open strippers?
Open strippers and closed. Faculty. Always very difficult to use the open strippers. We try because we will damage the tendon or something like that. One situation where I use the open stripper is whenever I want the attachment there and to augment the MCL.
So the generally for ACL, we do not prefer open strippers. It's only when you're doing an MCL reconstruction with a SEMITI, that is the time when you would want to use an open stripper because you want to keep that attachment intact.
That is the only indication you can say, Satish.
I think now I use an open stripper, but off late there are non-traumatic open strippers available from the companies, where the chances of graft amputation is very less. They're available from even local companies also, not the sharp ones. The advantage of using open strippers is you can, after you strip the tendon, you can have around 1 or 1.5 centimeter more length, because you can peel the graft off the periosteum at the attachment. But I think if you're using open strippers, I think the non-traumatic strippers are very good, and it is working very good in my hands.
Okay, so thank you everyone, and we conclude this session. Now the inauguration. I request everyone to come on the dais. I think the faculty and all. Yeah, please. Yeah, carry on.
We welcome you all to the IAS One program. Now, let's move on to the inaugural section. I would like to welcome Dr. Aslam Arif, Dr. K.S. Praveen Kumar, and N. Anish Kumar to the stage. Sorry, Ashish Kumar to the stage. Next, I would like to welcome our faculties for the day, Dr. Sandeep Bisra, Dr. Prahlad Kumar Singh, Dr. Dinesh Chitragupta, Dr. Dinesh Dr. Dinesh, yeah, Dr. Amin Raji, Dr. Saumya Dev, and Dr. Ajay. Next, I would like to welcome Dr. Arun Kumar, Central Head Medical Hospitals, Dr. Narendra, Medical Director, Medical Hospitals. Dr. Purnasandra Tejashvi, yeah. Sorry, sir, I missed your name. Now I request everyone for the light lamp.
I request Dr. Chandrasekhar Naidu, sir, to please come onto the dais, please. Chandrasekhar Naidu, sir, is not only a senior professor, a mentor for us, but he is now as a NMC observer. Thank you very much, sir, for coming. Thank you, sir.
Dear colleagues, it's my pleasure to welcome you all to the IAS One program. The presidential theme of the Indian Arthroscopy Society this year is Bridging Boundaries. With this vision, IAS is committed to bringing arthroscopy to every corner of India, ensuring that arthroscopic surgery is accessible to all. The IAS One initiative was conceived to realize this ambitious goal. Today, I also wish to encourage our young surgeons to join the IAS family. Membership in IAS comes with multitude of benefits that are invaluable for your professional growth. As a life member, you will gain access to your own personal digital secure logbook, which is the IAS registry. Our knee registry is among the best globally, and we are soon launching the shoulder registry. Additionally, we have significantly increased the number of IAS inland and foreign fellowships. These fellowships provide an exceptional opportunity for members to enhance their skills and knowledge. By becoming an IAS member, you can apply for these prestigious fellowships and gain unparalleled exposure and experience. Moreover, we have expanded the number of IAS accredited training centers across the country. This ensures that high quality training is available to you at a location convenient for you, thereby supporting your continuous professional development. As you engage in today's program, I wish you a day filled with rich learning experiences, vibrant interactions, and of course, a bit of fun. I extend my thanks and appreciation to the organizing team for conducting this IAS 1 program. Long live IAS. Jai Hind.
Next, I would like to welcome Dr. Aslam Arif to for the welcome speech.
Wow. Good morning, everybody. I am really proud to be here standing in front of you all this morning, representing the State Arthroscopic Association. And on behalf of the State Arthroscopic Association, I'd like to thank the IAS for giving us such a wonderful program and on a regular basis. And we have noticed that in the past few years, with your support, we have been steadily growing and steadily helping our young surgeons get better experience and exposures to wonderful faculty like you who keep coming time and again and give us the encouragement that we require. So, from the bottom of our hearts, since I represent the whole AP Arthroscopic Association, I thank you all for being here and giving us an opportunity to experience some of the best surgeons and some of the best academic event in the country. Thank you very much. In special, you are very close to our heart, Sandeep sir. Okay, and you've always been there for us. And God bless you and the IAS. Okay, thank you very much. And I would request you to please come up for a couple of words.
Thank you very much, Aslam sir. Uh, on behalf of our president, Dr. Professor Arumugam, our executive council, and few of our executive committee members, some Dr. Sammedeep and Dr. Prahlad, who are also here with us. So, Indian Arthroscopy Society is a society of over 4,200 members, and like over the few years. Arthroscopy Association of Andhra Pradesh has taken quite a lot of effort to make lots of members. Dr. Aslam Arif, Dr. Sridhar, Dr. Praveen Kumar have been helpful in conducting the membership drive, and that shows the strength of the members which we have today. And I'm very happy to visit this city again. This is my fourth visit, and every time I come, always it's a joyful to visit. So if you are not a member of Indian Arthroscopy Society, please do join Indian Arthroscopy Society, become a member, be part of the society, work for the society, and I'm sure like the efforts which are taken by the current organizing team of this IAS One Vizag are very good. They have been consistently doing activities of IAS, and I'm sure they will be keep on doing. And in future, they will definitely hold a IAS con here. I wish them all the success on behalf of Indian Arthroscopy Society and the whole Executive Council. Thank you.
We would take a few minutes to felicitate our faculty, visiting faculty, and give them a token of appreciation from the association and from the people of AP. I would request Dr. Amin Rajni, um, Dr. Naidu garu. Thank you very much, sir. Dr. Sandeep. Dr. Prahlad. Thank you, sir. Dr. Soumyadeep. Dr. Dinesh Chidambaram. Dr. Purnachandra. Dr. Dinesh Loganathan. Mm. Our own Dr. Praveen. Sridhar. Dr. Ashish. Dr. Sridhar. Dr. Sridhar.
Dr. Aslam Arif, sir. Next, we are going to felicitate Dr. Sandeep Biraris. Sridhar wants to speak a couple of words.
First of all, I would like to thank all the faculty for a wonderful moment and all the time they have spent all the way from different parts of the country, especially live surgery faculty, Dr. Emin Rajni sir, Sandeep Biraris and Prahlad Kumar sir, and all the faculties, Saumadip Datta from Kolkata, Dinesh Lokanatham, Dinesh Chidambaram. So they have spent lot of time in transit and had a wonderful time here. So next two surgeries also you are going to have a wonderful time together. So especially we want to thank Dr. Sandeep Biraris. He has been the executive committee member in 2020. He has been joint secretary 20 to 2022 and Now, last 22 to 2024, he is the secretary of Indian Arthroscopy Society. I can say he's the youngest secretary for Indian Arthroscopy Society. So one great thing is he's connected across the India. So he's known to every nook corner of the country. He's known to every small town and city. He's known to every young surgeons. So he's so reachable. So lot of membership drive, IS webinars, a lot of IS meetings were conducted under him, and he's a techie guy. So he will be in this meeting, but he will be contributing his services, and he will be coordinating a lot of other IS meetings across the country, sitting in one meeting. So he has done so much work on Indian Arthroscopy Society, and I think he will be finishing his term in 2025 March. So I'm very happy to see him as a next future president for Indian Arthroscopy Society too. So one part is he's my batchmate from Kochi, and he's a very good friend of mine and an excellent surgeon. So he works in Mumbai Port Trust Hospital. He has a lot of fellowships under his name, and he has trained so many surgeons and so many special techniques under his name. So I thank Dr. Sandeep Biraris for having his time in Vizag. I think he has come 3 to 4 times in our city. And main thing, whenever we call him, he always says yes, and he has been there. So even for this meeting, he had another meeting, so he could adjust that, and have been here for a live surgery today. So thank you, Sandeep. Thank you so much for having time for that. Thank you.
So just I'll take up 1 minute. So whatever Sridhar has said, that's like that nothing extraordinary about that. What I am today is only because of Indian Arthroscopy Society. So it is society and its member and the friends who has supported, and they have been supporting always. That's why I was sitting here. So all credit goes to them and the society. Thank you.
Can I request Dr. Abdul Khan to come and kindly chair the session? And Dr. Praveen, we'd like to begin the second session of the talks, and for which I'd like to request Dr. Purna Chandra to please come and give his talk on pediatric ACL avulsions.
Good morning. Thank you, IAS. Thank you, Sridhar sir, for this opportunity. It has been an excellent meeting so far. To see a great audience who is keen and interested to learn few things about arthroscopy. So this talk was to be initially given by my friend Kirti. He could not come due to some personal problems. I'll just be talking a few. So hi, I am from Hyderabad. I'll be talking about, I'll just let this be a case-based and more of an interactive discussion. This will not be a lecture. So this is an 8-year-old boy. He presented to me 1 month after his injury. He fell from a bicycle. He was initially treated, he got an X-ray from a local doctor. He was treated conservatively initially. He was started a little bit physio for 3 weeks. Now he's around 5 weeks, 1 month and 1 week after his injury. He continues to have a little bit of deformity at his knee and walks with a limp. So this is his diagnostic. This is his X-ray. You can see an avulsed fragment. In these cases, the fragment looks smaller because of more of a chondral tissue, and you can see that in the MRI as well. And this is flexion deformity at the knee joint. So we all know incidence of ACL avulsion injuries is more common in kids because of the apophysis and the growth plate. It's 3:2 ratio when we compare avulsion injuries with respect to adults and children. Most of these is due to high velocity injuries. We have to understand that majority of these injuries are associated with other concomitant injuries such as meniscal injuries. We all know the lateral anterior horn of the lateral meniscus most of the times in 95% of the cases is avulsed along with the ACL tibial spine fragment. So how does the injury occur? This occurs in axially loaded knees when the knee undergoes hyperextension and femur rotates against the tibia. So what are the options for this case? 8-year-old guy, around 35 days post his injury, treated conservatively. He has a displaced ACL avulsion fragment. So what we do? So can we have a quick raise of hands? Anyone would continue conserve and rehab? So the second option is there is an option to open and fix the screw. We could do this as well. But in this age group, it is always tricky because of the smaller bony fragment. There is always a risk of shattering that fragment and splintering the fractured piece. So the other option is to go ahead, even though it is 5 weeks, treat it like a subacute fracture, arthroscopic debridement of the fracture bridges, and you could stabilize it again by a small screw or suture bridge or a mini tightrope. And the other option is if it's a chronic case, of course, we have an option to debride and reconstruct. I think these are the 4 options. So how did we do this case? So my scope is in the anterolateral portal, and the radio frequency device is coming from the anteromedial portal. You can see most of the times the intermeniscal ligament gets the fragment not to be reduced. So you can see that fragment in the intercondylar notch. As it is a pediatric, it is very easy to use smaller sized uh, shaver blades. Now with your device, when you retract the intermeniscal ligament, we can easily reduce the fragment back to the surface. The first thing is to debride the fracture bed, treat it like an open fracture. We need bleeding surfaces for the bone to heal. So once that is done, you could reduce it by retracting back the intermeniscal ligament. The fracture can be reduced, and as I said, most of the times these injuries have the anterior horn of the lateral meniscus attached. So initially, because it just keeps on flipping because of the intermeniscal ligament between the medial and the lateral meniscus, you stabilize it with thinnest possible K wire coming from just below the patella so that it just holds in place. So what do we do different here compared to adult? In adult, we know that when we are using the suture bridge technique, we drill 4.5 tunnels on either side of the displaced fragment. But here we are dealing with a very small knee, and growing part of the knee. So here we should use as smaller drill bits as possible. Here, a 3.2 drill bit. I use this three. We have this 3.2 drill bit of people who have done AC tight ropes for the AC joint tight ropes for type 5 dislocations. Arthrex has this cannulated drill bits where the pin is screwed into it. So these are small, and you can shuttle the nitinol wire through this. So you can use that. So this is how it is. This is the cannulated drill bit, and this is the screw where we can take it out. After you drill it, it creates a cannulated kind of drill bit appearance through which you can shuttle the suture. So I use this ACL jig, and this is the 3.2 drill bit on either side, one on the medial and one on the lateral side. So the lateral side should include the anterior horn of the lateral meniscus because, as I said, this is most of the times part of the fracture. This is how it looks. So this is how it looks. I do patients in TKR position 90-degree, scope in anterolateral, 2 drill bits coming from the anteromedial portal, and these are around a half centimeter or 1 centimeter apart. So you need 2 drill bits so that the work is easy, the workflow is easy, and that is the K wire coming from top that is holding fragments. So none of these coelies or none of this collide, and it gives us a straightforward reduction and further procedure. This is how it looks from the outside. And once this is done, you can just unscrew this. You can just unscrew this part and just shuttle a number 1 PDS or an ethanol wire. So now, after this is done, you take your lasso device, left and right are both required to take from each side. And now you could use a fiber tape kind of thing, or a fiber wire is also good. You take a double loaded thing and cinch it so that it has extra strength. You could use cannulas here, or if you're not using cannulas, you make sure that you take all the sutures at the same point through the same portal so that there is no tissue bridge that formed in between. You could use the passport cannulas here, which are very useful. Once this is done, and now, as I said, you take the cannulated thing and you just shuttle that, and now these sutures can be shuttled through that lasso loop to form a figure of 8 kind of configuration. Now repeat the same thing. Now shift the scope to the anteromedial portal and your lasso device from the anterolateral portal to get the bite from the opposite side. So the bite is at the level of junction between the bony piece or the osteochondral piece and the ACL, so that that has the maximum strength and it prevents the cut through of the tissue through the ACL. So repeat the same steps. So different color sutures are preferable just to avoid confusion and tangling of these sutures and making the procedure more cumbersome. And once this is done, this is how it would look. The same step is repeated to the tunnel you have created laterally, and this is how the configuration would look at the end. So you could see that when this is done, the lateral meniscus and the bony fragment are reduced quite well, and this gives a very stable fixation. Normally, because we have drilled 2 small tunnels, there is a bony bridge in between. You could either opt to use a button on the tibial side, or I preferably do not use a button and just tie it over the bony bridge. So in summary, even subacute fixation is possible. So the important thing is adequate debridement and preparation of the fracture bed, like in open surgery, for the bony fragment to heal back. Smaller size tunnels in this age group to minimize damage to the physis, and to appropriate sizing of the tunnels, because this is a very small knee. Usually no implant is required on the tibial side because of the 2 tunnels. Rehab, I start 30-degree range of motion, that is partial range of motion, from day 1. Weight bearing can be started from day 1. And after 3 weeks, I gradually increase by 30, 30, 30 over the next 3 weeks. Thank you.
Thank you, Purna. So any facial sparing ACL reconstruction?
Yeah, in this age group, sir, I mean, because there is a very good bony fragment, I would not prefer. Even if it is 3-month-old, adequate debridement, and the healing potential is very huge in these patients. So my first preference, even if it is 3 or 4-month-old, would be to fix it than to do a reconstruction in this. Of course, if there is a tear of the if there is a tear of the ACL even proximally, where by fixing the fragment also it is not going to heal, or the integrity of ACL is in doubt, then I would do a physical sparing.
Thank you. Any more questions for this talk, please? You want?
Any difference in rehab post-op in these cases compared to the standard?
No, because this is we are depending on the bone to heal. I would not, only difference is I would not allow full range of motion of the knee from day 1. I would just keep it I would not keep it complete in extension, because this is a very stable fixation, and we tighten the tibia at 30 degrees of flexion. So that means I can allow up to 30 degrees of flexion from day 1, just to keep the flexibility of the knee. From 3 weeks, what I do is 3rd week 60 degree, 4th week 90 degree, and after 4th week I allow them to do full. So from 3rd week I do 30, 30, 30. That's what I do. Weight bearing, if there is no other concomitant injuries, if I've not done a meniscal repair or anything, I would allow them to weight bear as tolerate, because this is in the intercondylar notch. So principally weight bearing does not have an impact on the healing.
Thank you. Any doubts? Any questions to the?
Let us break for a coffee for 10 minutes, and then after that, we'll continue with the sessions. Thank you.
We all know that the number of ligament surgeries being done in this country outnumber that in many other parts of the world. We all know that the number of ligament surgeries being done in this country outnumber that in many other parts of the world. We all know that the number of ligament surgeries being done in this country outnumber that in many other parts of the world. I think this registry will help us understand the trend of ligament surgeries that are happening in India and help us in bettering our outcomes in the long term. The Indian Ligament Registry will help Indian surgeons showcase their work on the body stage. Dr. Armugam and his team needs to be complimented for the exemplary work that they have done for the Indian Arthroplasty Society. By setting up the ligament registry, I think they have notched up the game by a couple of points. I again compliment the IAS for setting up the Indian ligament. We all know that the number of ligament surgeries being done in this country outnumber that in many other parts of the world. I think this registry will help us understand the trend of ligament surgeries that are happening in India and help us in bettering our outcomes in the long term. The Indian Ligament Registry will help Indian surgeons showcase their work on the world stage. Dr. Anusha and his team needs to be complimented for the exemplary work that they have done for the Indian Arthroplasty Society. By setting up the ligament registry, I think they have knocked up the game by a couple of points. I again compliment the IAS for setting up the Indian ligament.
So, good afternoon, everyone. After that short coffee break, I am Dr. Vishal Kulkarni from Bombay. As Dr. Sandeep Birare sir is in a life surgery, I'll be speaking over him about rehabilitation, about prehab and rehab after the ACL reconstruction. So, we all know that ACL injury in acute settings, always there is some stiffness, there is hematoma, there is some loss of flexion extension at the knee. So, prehab is very important when we plan to go in, scope it, and do an ACL reconstruction. So this is just what happens after an acute ACL injury. The first response, as we all know, there is swelling, there is inflammation, there is joint effusion, there is hematoma, and there is nerve inhibition, which causes a firing rate, decrease in the strength and the firing rate of your quads. There is loss of range of motion, tightening and guarding. There is the gait pattern, the walking pattern of the patient is affected. This becomes a vicious cycle, and there is abnormal walking pattern and pain along with inflammation, which aggravates the symptoms. And what we recommend is use of crutches. But nowadays, only a long knee brace if it's a single ACL injury without any MCL or LCL injury. So a long knee brace is recommended now immediately post-operatively, pre-operatively during the prehab period. So there are two factors which needs to be kept in mind when the psychological factors, because the patient undergoes a series of changes in his psychology, and preferably in sports enthusiasts who want to return to sports, high level sporting activities, and physical factors. So the psychological factors is that the readiness from the patient side, whether he's in for the prehab as well as the surgery. And the adolescents and adults, they exhibit different types of readiness, so that the patients usually consult too many doctors in and around. They get confused, so it plays along with their psychological effects as well. So the goals for prehabilitation is the same. You need to reverse the swelling, decrease down the hematoma, the inflammation, increase or retain the range of motion, retain the muscle size and strength to avoid wasting, and normalize the gait pattern of the patient, and cardiovascular fitness. So for swelling control, as we all know, we follow the RICE protocol: rest, ice, you give compression and give elevation along with a long knee brace. Improve the range of motion at the knee joint, which is affected or injured by stationary bikes. You do heel slides, you do prone hangs and wall slides. So these are all recommended for a period of 7 to 10 days before you actually go in and do the ACL reconstruction. So this is just range of motion increasing by giving a stationary bike. So back and forth movement until full rotations are achieved or revolutions are achieved. You do it 20, start with 10 to 15 minutes a day and then gradually increase the number of repetitions. The higher seat, if you higher the seat levels, it works on knee extensions, and the lower seat level works on knee flexions. So this is all explained to the patients. The range of motion is heel slides using a TheraBand or a normal dupatta can help the patient increase his range of motion. He can do it while lying down or in sitting position as well. So basically uses to pull the heel towards the buttock, which will also increase his hamstring and thereby increasing his range of motion. So you start with 10 reps, 5 seconds, and you increase the number of counts till you attain the 90 to 120 range of motions prehab. You do prone hangs. In this position, you can also use the opposite leg so that you attain full extension at the knee before actually going in, and you don't leave extension lag in the patient. So this is just you lie down on the stomach and the foot hangs off of the edge of the bed and you do prone hangs. You can start with 5 minutes and gradually increase to 7 to 10 minutes. And as I told, the opposite fit can be used to give a downward pressure on the injured leg. And you can do wall slides as well as the patient is lying down with the normal limb on the wall and the affected injured limb using the heel as a support to slide it back and forth so that the range of movement increase. So this is what I've told. So maximum you can do it for a 1 minute and repeat it for 5 times a day and gradually increase so that you attain good ROM before going in for the surgery. The third part is strength, where you need to strengthen your quadriceps, your VMOs. So it also it's also an important part of the prehab program. So you can do quad sets, you can do straight leg raises, heel raises, and chair squats with support. So these are quad sets. So as we all know, you contract the quad muscle, ask the patient to hold it for 5 to 10 seconds, strongly as possible, and then release it. So when contracting the quad muscles, the knee should dive down towards the ground. So it should be fully extended without any gap seen. And repeat it 10 times, 3 to 5 times a day. Straight for strength, again, you can do heel raises. So patient standing onto the forefoot and raise slowly onto the tips of the feet. So all these repeatedly 15 to 20 times a day, reps, and 3 to 5 times per day. After this, if the patient is comfortable with heel raises on both the sides, he can gradually do it with the injured side. On then chair squats with support, he can do half squats, not full squats. So standing in the front of the target of the chair with the back of the hips resting onto the chair. So you squat back to touch the target and then stand back again. So again, these repetitions 15 to 20 times will increase the ROM and the muscle strength. The main part is walking pattern. So the heel always should touch the ground first. As we all know, the gait cycle, gait pattern. The tip of the toe should then leave the ground last, and the foot should remain straight forward. So he can do it, practice this by looking at the mirror himself at his home. So ask him to walk straight. That will improve his gait pattern and the muscle strength as well. Then cardiovascular fitness can be started about a week after he's started all these exercises. He's attained good ROM, range of movements. He's attained good strength of his muscles. He can use an exercise bike, an elliptical trainer. So all these come into the part of cardiovascular fitness. 3 times a week, he can start with 10 to 15 minutes gradually and then increase it to an hour or so. And this can be immediately started after an ACL injury, along with your RISE protocol and strengthening your muscles. So this is basically key to retain the ROM at the affected or the injured knee. So this is the elliptical trainer, same as your bike. So this can be started after achieving good ROM. So if the patient has achieved about 90 to 100 ROM and he's able to full weight bear and he's got good muscle strength, he can start with elliptical trainers and start slow with minimal resistance. So one tip should be to start the elliptical trainer, he should be able to walk without limp and his gait pattern and walking pattern should be normal. And this is not recommended by us, but he can also start with flutter kick swimming. So basically in our setup, we usually end up operating the patient 10 to 15 days down the line. So prehab for about 10 days is enough if he's achieved good strength, muscle strength and ROM. The post-op rehab is also very important and important in athletes with high demand sporting individuals. So there are some guidelines. So we need to discuss it with the patients, keep in mind about his psychological and physical status, mental status, the symptoms, the post-operative symptoms, the pain. So you need to assess it every 2 weeks. So at 2 weeks, at 4 weeks, and 6 weeks, post-operatively, and then slowly start with his sporting activities. For performance activities, we started at 3 months, and then return to sports is usually recommended at 9 to 10 months post an ACL injury. So it's divided into basically 4 phases. The phase one, which includes functional balance and core strengthening. So in this, basically, the patient is advised single leg weight bearing strength. So we need to strengthen that. Side to side symmetry in the operated, single leg balance, and core stability. So the exercises include lunges, single leg squatting exercises, treadmill, and balance activities. And once the patient has attained all these, he's able to do lunges, he's able to squat single on the single leg. Then you move on to the phase two, that is able to single leg squat to 60 degrees. So you move on to the second phase, that is the functional strength training. So improve the overall lower extremity strength of the operated limb. You enhance the force contribution symmetry during the bilateral gait pattern and walking phase, and enhance the single leg landing force. So in functional training, what it involves is high intensity balance training activities. So you continue and increase the amount of weight bearing strengthening of the operated limb, and then you also improve the single leg landing activities to improve the dynamic muscle control of the operated limb. So once the patient has achieved this and he fits into the criteria of phase two, and he can be moved on to phase three. So the side to side symmetry in peak torque, knee flexion and extension. Once he's achieved that, he's able to move on to the phase three of post-op rehab. So the phase three involves the power phase, wherein we improve the power production, the lower extremity muscle endurance is increased, and the plyometric activities like rock jumping and then box jump, then you do lunges, then you do bungees. So all these things are included in your plyometric activities, which is in the power phase. So the exercises include the double limb jumps, the rock jumps, then you do jumping jacks, and then you also include bungees, uh, single leg repeated hops, and the focus is mainly to improve the plyometric activities. So once he's comfortable, then you go on for the single leg hop for the distance within 15% of the uninvolved side. So if he's able to use his operated limb for more than 15 to 20% as compared to the uninvolved side, he's fitting into the phase 4 criteria. And then it also include triple hop over 6 meters. So basically phase 4 is making him ready to return to sports. So sport-specific symmetry is included in phase 4. So basically, the goals of phase 4 are equalizing the ground reaction force between the limbs, improving confidence and stability, along with improving his psychological endurance and mental stability, and using safe biomechanics when performing high-intensity plyometric exercises. So power cutting, change of direction, verbal and visual feedback are all included in phase 4 of post-op ACL rehab. And then once he's able to do all this, drop vertical, jump landing, uh, landing on bilateral symmetry within 15% opposed to the uninvolved limb. So he's ready to return back to sports. So the World Congress has devised three-phase model, wherein the first is return to participation in rehabilitation and training, but at a lower level. Then is the return to sports, and then is return to performance, where he's participating in national and international level sports activities. So the measures of success when you do a post-op rehab is there is absence of instability, there is no knee joint swelling or effusion, successful return to sport, and symmetry of quadriceps and hamstring strength as compared to the uninvolved side. The psychological readiness is most important, which is often overlooked and is most strongly associated with failure to return to high level sporting activities. So, the most common reasons could be lack of trust in the knee, fear of a new injury, fear of twisting his knee again, and poor knee function. So, the length of time from surgery to return to sport is important. So, ideally, what the guidelines says 9 to 10 months is the ideal time to return to sports. And the psychological impact with the fear of being out for so long is also important and needs to be kept in mind. So this is just the three parts, the rehabilitation, the surgical part, and the other factors, which includes social, psychological, as well as any other associated injuries. They play a major role in return to sports in a high level training athlete. So thank you for that.
Do you do any difference in post-op rehab for sedentary lifestyle patient and a highly active individual?
For sedentary active, for the first 6 weeks, I keep the protocol same. So if it's an ACL injury, full weight bearing on day one itself with a long knee brace in extension. And for high demand athletes, we start with eccentric training exercises at 3 to 4 months down the line, and then power cutting at around 6 to 9 months. And then about after 9 to 10 months, we ask them to return to sports.
Okay.
I request Dr. Sridhar to give a talk on revision ACL reconstruction.
Yeah. So very good afternoon, everyone. So I'll be speaking very crispy about the revision ACL reconstruction today. So what are the main key points and how to assess a patient and what are the factors which leads to ACL failure? So if you see across the globe, the incidence is around 4 to 25%. So it is as high as 1/4 of the patients getting revision later onwards. So most commonly, the initial 1 to 2 years is the time where the patient gets the instability or any other failure where the patient gets a revision ACLR. So by definition, what is a failed ACL or why you do an revision ACL reconstruction? So most common factor is the persistent knee instability. So soon after the surgery, so patient goes on complaining that he has a persistent instability, he has the same feeling that his knee is giving way as before the surgery. So the other one is we see a lot of patients complaining the pain and swelling. So sometimes it could be a knee synovitis, sometimes it could be a foreign body reaction which gives the persistent swelling to the patient. So you need to assess this patient whether it is an aseptic swelling, synovial effusion, or patient has any infection. So the other one is the arthropibrosis. So if you don't access the cyclops lesion, if you don't debride the scar tissue, or if you don't have a perfect tunnels, patient may have a stiffness in the knee joint. So they may have a knee stiffness, mostly flexion deformity, or may they have loss of complete knee range of motion. And if you see the sports person, so most of the sports person have a deficiency that they can't go back to the previous sports injury level. So this is a condition where you feel that it is a failed ACL and the patient needs revision. So many factors contribute to the failure of ACL reconstruction in the postoperative period. But one third of these patients, or you can say as high as 50% of these patients, are due to surgical technical errors. So almost half of these patients, they get revised ACL reconstruction because of surgical technical error, which is mostly in our hands. So that is the main key factor which is to be taken care by our surgeons before attempting any ACL reconstruction in our starting days. The other one is the improper graft placement. So if you do a femoral tunnel and the tibial tunnel, if the graft is not placed in the accurate anatomical position, so that again may cause impingement or a re-tear or any other issue. The third one, as earlier speaker Dr. Vishal has spoken about that. So 50% is the surgery. That's what happens in our hands. But next, the 50% is mainly in the rehab guys. So you feel that you have done an excellent arthroscopic ACL reconstruction surgery, but in the post-operative period, patient has not been reviewed or not revisited you in the post-operative follow-up and not done any physiotherapy, then it is again a day one failure. So most of these patients come for surgery, they'll go back to their own hometowns, they go a local physiotherapist and do a local rehab center. Most of these rehab guys may not be knowing what is ACL reconstruction or an arthroscopic surgery and what is our protocol in the post-operative period. So this lack of communication between the surgeon and the post-operative rehab guy who is sitting in somewhere other own town of the patient. So this miscommunication leads to the patient's failure in rehab program. The last one is a re-injury. So some of the patients may re-tear again. Mostly this will be an road traffic accidents or sports injuries. So what are the surgical technique errors which we can elaborate is improper graft placement, that is maybe because of the tunnel placement, improper tunnel placement, inadequate fixation of the graft. So you wanted to use some fancy implant or some particular implant which is not suitable for that patient itself, but still if you go ahead with that improper implant, so you may not get an adequate graft fixation on the femoral side or the tibial side, so that may lead to the graft failure. The third one is the technical errors in the making femoral or tibial tunnels and inadequate visualization. So most of the time, if patient has a chronic synovitis or acute synovitis, lot of debris, and some patients may have some cartilage lesions or an arthritis set in case of neglected ACLs. Some patients may have a bucket handle tear of the medial meniscus. So these patients, the moment you put the scope inside, you may not visualize the femoral condyles clearly, and you may not assess where is the meniscus and which part is the ACL. So sometimes most commonly these of ACLs after torn, they get fall back in intercondylar notch and they get stuck to the PCL. So you can see ACL and PCL together fibrosed. So these things makes us difficult to visualize properly. So you have to know which is PCL and which is the fibrosed or cyclopsed ACL, and you need to debride that to have a proper visualization. And another thing is the meniscus, you have to identify any concomitant injuries. So most commonly you may miss the ramp lesions or a PCL lesions, which may be missed and cause for instability in the post-operative period along with the persistent pain. So most common surgical techniques is placement of the tunnels on the femoral and the tibial side. So femoral side, it is very common that you keep it on the anterior half of the femoral condyle, because we may not visualize the posterior aspect, the posterior border of the medial lateral femoral condyle, we may not visualize. So we tend to keep our tunnel on the anterior aspect, so that may impinge on the tibial side. So that may be a day one failure for these patients. The other one is orientation of the graft. So the on the tibial side, if tunnel is too anterior, so it may impinge. If it is too posterior, it may again re-tear in the postoperative period. So making an anatomical femoral and tibial tunnel is very important in getting our ACL reconstruction right in the intraoperative period. So the inadequate graft fixation, again same, it may be a fixation devices. The implants which you use for femoral and the tibial side, that should be very important. So once you have fixed it, if you feel it is still lax, that is better you may add another post or screw onto the tibial side and refix it with a second device. Don't just leave because it is lax inside and you don't want to put in another implant on the outside of the tibia. But still you can do that. What we want at the end of that is no impingement in the intercondylar notch. You need a full flexion extension, and you see that the ACL after fixation is taught in the intraoperative period without any lax ACL. So that's how we assess that intraoperative, it is a successful ACL reconstruction. The other one is the tensioning the graft. So you can pre-tension the graft. We have the graft master boards. You can pre-tension the graft, or the other one is if you are using, especially if you are using adjustable loop. So usually the guidelines is if you are to start younger surgeons, you are starting arthroscopic surgery, it's always better to use a fixed loop device, because adjustable loop, every company comes with a different method of doing it. So you may be carried away of doing in a fancy adjustable loops without not knowing the proper tightening of the loop. So the loop may uh, come out of the tensor fascial lata. Sometimes it may be sit in the subcutaneous fascia, sometimes outside the periosteum. So that may cause the lax of the ACL graft itself. So you need to be very cautious whether the graft has fixed properly or not. So once the graft is fixed on the tibial side, you have to make sure that you cycle it properly so that you make the tibial graft side also taut. So once this is done, you should make sure that assistant holds the graft properly so that you have a taut tibial tunnel graft so that you can fix it in the tibial side. So other one is inaccurate tunnels, that what I already elaborated initially. The other one more important key factor is the graft handling. So this is especially important if you are not the primary surgeon in the hospital. If you are a visiting surgeon, you are going around different places, operating in different setups. The most important is the person who is handling the graft. So most of the time you will be doing the arthroscopy and just giving out after the graft, after the harvesting, some other person may be doing the preparation of the graft. So this is the one what you need. If a assistant is doing that, he may contaminate, or 3-4 people handling the graft and moving it from one table to the other table, that may cause a post-operative infection. So that is one more cause for infection in the post-operative period, where some mild infections or subacute infections, these patients may come up with mild synovitis persistent with mild pain, which you cannot differentiate whether it is a synovitis or an infection. That causes a problem where you cannot decide about our revision ACLR. So graft handling is very important. And nowadays it has come up that guidelines has come up that after the graft harvesting and preparation, either you can soak it in vancomycin or a gentamicin so that the graft will be in the antibiotic soaked. So we will have some antibiotic coverage for the graft. And the same thing, the meniscal tears and other ligament injuries. So patient has any posterolateral corner injury or a posteromedial corner injury or a concomitant MCL or LCL injury. If you fail to address that and do a ACL reconstruction, again after mobilizing the patient, again it may be a day one failure for the patient. So that you need to assess the MCL, LCL, the corner ligaments and meniscal injuries so that you get a perfect ACL reconstruction along with the other ligaments. So for steps of successful ACL reconstruction, initially you should assess the patient what is the reason for failure. You should know whether it is because of the tunnel failure, whether it is because of the graft issue, or whether it is an infection, or because of the post-op rehab issue. So you should assess the patient preoperatively what is the reason for the failure. So unless you know what is the reason of the failure, never attempt to take this patient for revision ACL reconstruction. That may cause him another surgery and cost for another graft, losing another graft for the surgery. You should do a meticulous surgical technique. So you should confine it, or should customize this graft what should be taken for these patient, whether you want to take a peroneus graft or an opposite contralateral hamstring graft. And once it is done, you should know the tunnel position, whether it is the same tunnel, whether you are going to do it or a different tunnel. So once you know the reason, so you do a clinical evaluation, imaging, and you can do sometimes a diagnostic arthroscopy if you're not sure why it has happened, and then you can plan later and confirm surgery. So technical errors, drilling errors, and fixation problems, these are the common things. So one picture I am depicting where you can see that after the initial ACL reconstruction, sometimes our femoral and tibial tunnels may get loosened or enlarged, so that you cannot do it in a single stage revision. So these are the patients where you need to do double two-stage revision if it is a non-infective cases. So this you can see the tibial tunnel is so much dilated, and usually if it is 10 to 11 mm more dilated, then you should not attempt any single stage revision. You have to do a two-stage revision. So initially you will do a single stage revision if it is 8 to 9 mm graft. If the tunnels are perfectly placed, you can use the same tunnel with a larger graft and use 1 to 2 mm larger screws for fixation of these grafts. If it is more than 10 to 11 mm, then try to do it in a two-stage, remove everything, debride all the graft, tunnels, everything, graft, both femoral and tibial tunnels. And after 6 months, you try to do a revision ACL reconstruction as a standard procedure. So in case of inadequate rehab, always make sure you shouldn't do any overzealous rehab. Some guys or most of the people who are active people into the sports injury, they are always ready to go back to their sports. They just don't want to wait on for the graft to heal. Usually it will take around 4 to 8 months, roughly around 6 months for the graft to heal. But most of the people, once their pain comes down in 1.5 to 2 months, they want to go back to the sports. But even then, the graft doesn't heal properly. So you should not advise them for an accelerated rehab, which may cause a re-tear of these ACL grafts. Another one is inadequate progression. So once you are not satisfied that patient is not going according to the rehab program, then you can accelerate our program. And always you should supervise. It should be one person, either surgeon or the assistant surgeon or the rehab guy. One guy has to assess the patient in every follow-up so that the supervision will be accurate. The re-injury is another one more cause, one, and especially in first 1 to 2 years, it is a main cause for re-tear rate. So management, as I said earlier, physically non-surgical, we can manage initially if you feel that whether it is a dilated tunnel or an aseptic this thing. So you can give physiotherapy, medication, antibiotic, etc. But if you feel it is completely lax and you need to revise, then you have to plan preoperatively. You have to think about your graft selection, what tunnel you have to make, what are the fixation devices. Everything should be addressed beforehand before you take the patient inside. So this you can decide whether you are going to do one stage or two stage. So prevention strategies, it is always important to have a proper surgical technique. Whatever case you do, stick to your basics, do a same surgery on and on once you are acquainted with the surgery, and do not change the implants for different surgeries. And you have to have a comprehensive rehabilitation program. Stick to the one physiotherapist who trains all your ACL cases, so that he knows or you know what happening to the patient, and patient also knows what protocol he has to be followed. And patient education on activity modification, when patient has any issue, you should advise him what modifications he has to bring to his lifestyle, and then go ahead for his future rehab. Thank you.
Thank you, Sridhar. Nice talk. Yeah, I request Dr. Amin Rajani, sir, for all inside meniscal repair.
We still have to go down, because you see the picture. I mean, like with this picture, we cannot work.
Thank you, the organizers, Dr. Sridhar, for inviting me for this wonderful IS1 meeting. I'm going to be talking today about meniscus repair by all inside technique. Um, so, before we start, we should understand that this talk is going to help you as far as the tips and tricks are concerned. It's a more practical based talk rather than theoretical. So we're going to cover all these points during this talk, and I think it will help you to gain some insights into meniscus repair. Now, it is very important to identify a meniscus repair. So, as you go inside with your arthroscope from the anterolateral portal, and when you come to the medial compartment, the picture on your right hand side would show you the flounce sign, which is an S-shaped curve. And this gives you a certain idea whether the meniscus is torn or not. Now, if it is not torn, you will get this sign. If it is torn, you will not be able to appreciate this flounce, a characteristic flounce which we see when it is not torn. Now, sometimes it becomes so difficult, when you're in the medial compartment that you feel that there is a flounce. Like in today morning's case, there was a little flounce in the medial meniscus, but it happened to be a big tear. Now, looking at and probing this meniscus, how many of you all do you feel that there is a tear over here? Can you raise your hands, please? Okay, so yes, there is a tear, and we are going to show you. Sorry about that. We're going to show you how that tear looks like uh, in just a moment. So by probing, not being able to reach the periphery of the meniscus, it becomes slightly difficult, and that is why sometimes pie crusting becomes very, very important to identify if there is a tear in the peripheral red zone. Now, going forward, if you can see, there is a small tear in the inferior, in the posterior horn, very, very peripherally, and we could have just missed it had we not probed. So probing becomes very, very important, especially so in such a tight joint. And pie crusting of the MCL also is very, very important. When to identify such kind of tears. Now what we did in this particular case was we went inside with a all inside device, and we did a vertical mattress repair of the small peripheral tear. Now what happens is, if you miss this tear and if you don't do this repair, even if you're doing a good ACL reconstruction, patient will have some kind of instability, because the posterior horn of the medial meniscus is the gateway. It also protects the anteriorization of the tibia. So even if you're doing a good repair, it can fail because of this small tear in the posterior horn of the medial meniscus. So this is exactly what we did. We repaired that posterior horn with an all-inside device, and you can see that the tear is completely secured. Now, identification again in the lateral meniscus. Now we are looking at. If you see, looking at the lateral meniscus, I mean, just plainly, there doesn't seem to be a tear. But the moment you start probing it, you realize that there is a small tear, which I will show you very shortly. There you go. So this is like a horizontal cleavage tear, which is going to probably open up and kind of eat up the entire meniscus. Now there is a controversy recently in the IAS Con also, whether we want to repair such kind of tears or just rasp them and leave them. If I see a tear, I'm going to repair it. I don't know what the audience has to comment on that. The faculties over here, but in my hands, I would not leave a meniscus which is torn without stabilizing it. So this is what we did. We rasped this small horizontal cleavage tear in the lateral meniscus. And I did a all inside repair, putting my first stitch on the superior surface of the meniscus and my second stitch on the inferior surface of the meniscus to roll and wrap the meniscus and close my book to give it some stability. So this is exactly what is going to happen now. I'm going to close that fish mouth, and I will be able to sleep well in the night. Now we have supporting literature. So literature is very funny. I mean, you can talk about meniscectomy and you can have literature and show that, and you can talk about meniscus repair and you have literature and you can show that. It is what you believe in. It is what you want to do. And I feel that meniscus is a very, very important structure in any human knee. And if we can repair it and restore it back to its original hoop strength, I think we are doing a good job for the patient. Position which you take or use when you're repairing a medial meniscus is that there has to be a side support. Your limb has to be in slight amount of flexion if you're in the body and anterior horn. If you're in the posterior horn, it is better to have a complete knee extension, about 10 degrees of flexion, and a valgus force with external rotation of the limb. So this is the best position to repair a medial meniscus. The position to repair a lateral meniscus is a figure of 4 position, where your assistant is pressing down on the thigh so that you're opening up the lateral compartment, and then you can repair the lateral meniscus. It is also important that we are perpendicular to the meniscus, the torn portion, the tear. If you are too up, you're going to hit the cartilage. If you're too down, you're going to go to the meniscus. If you're not in the right direction, then you will not be able to address that particular tear. So it is very important that you put in a spinal needle, know what direction, what trajectory you're going to apply, and then make your portal rather than making multiple portals. Uh, the direction of the working portal. Now, if you see, if I'm going to put in a spinal needle from this from the medial side, it is not reaching my tear. So I'm going to switch my portal like I did today morning, and I'm going to address this tear from my lateral portal so that it becomes much more easier for me to repair this tear with the correct trajectory. So if you guys can take a picture of this because it's very important. This shows you the direction or the trajectory in which you would want to go ahead and do an all inside meniscus repair. There is a table here which also you can probably take a picture of. So if it's a medial meniscus posterior horn, the viewing portal is lateral and the working portal is medial. If it's a medial meniscus body, it's a medial portal which is the working portal, and the viewing portal is medial and the working portal is lateral. Lateral meniscus is the medial portal which is viewing, and the lateral portal for a lateral horn posterior meniscus, and vice versa for the lateral meniscus body. In the morning, I wasted a little time showing you this technique. Now, it is very important that you clear the fat pad. This is the first thing that you need to do. If you're using different company shavers, make sure that it is in an aggressive mode, or you're using a 4.5 or a 5.5 shaver blade, so that you can clear all this fat pad and not struggle with vision. Once you are completely sure that your fat pad is cleared, you will be able to visualize the lateral compartment, which is slightly more difficult to enter into and visualize. So it is important that you remove the fat pad from the lateral area as well along from the central and the medial area. As I said in the morning, the shaver blade, if it's facing you, you are not at risk of any damage to the articular cartilage. And it is very important to fix the shaver blade in the handpiece in that particular mode. I used to use passport cannula a few years back for my meniscus repairs. I don't do it anymore. I don't feel the need to. But when you're starting off, this is a good cannula. It's a short cannula. It's stable. It does not move. Easier suture management, and it's much more stable as compared to the other cannulas. As far as opening up the medial joint is concerned, I do pie crusting. As I said in the morning, I do it from. Sorry. I do it I do it from just above the joint line, just below the epicondyle. But you can do it any which ways. You can do a pie crusting at the tibia as well. I find this much more easier, so I stick with this. And this is how the joint open ups when you do a good pie crusting. So there you go. So you can see that the joint is open now. You can see the tear and address it. And this is very important to do if you can't access that posterior horn. Again, rasping of the tear is like, when you're fixing a fracture, you freshen up the edges so that it helps in biology. It's important that we rasp the tear so that, you create some kind of biology and then repair it. So all inside devices does not mean that they have to be, fancy gadgets. They can be a simple Scorpion device like this, or a fancy gadget like this. Depends on what you want to use or what the tear is like. I'm not going to go into the detail of any specific all inside device, but I'm just going to show you two cases. One case with a fiber stitch. This is how what the tear looked like, and we repaired it with an all inside device like we did today morning. If I'm running out of time, please let me know because I feel the clock has not started. So I'm rasping the tear and I'm going ahead and I'll be going ahead and repairing this meniscus like this. So this is a vertical mattress stitch which I'm taking. It is important to understand the configuration. It is because the fibers are located vertically. It is ideal that we go ahead and do a vertical mattress. It has most strength as compared to a horizontal mattress. But I mean, even if you're doing a horizontal mattress to start off with, it's a good idea rather than leaving the meniscus all by itself torn. I'm sorry, this video is taking a little longer than what I had planned. Just give me a second. I just want to show you something at the end of this video, which is going to be important. So as you see, as I'm tightening, I'm getting that flounce, which was not there previously. And this is a sign which we described in, as I said, in the Malaysian Orthopedic Journal, which is the adequacy of the meniscus repair, which we get to know that you've repaired the hoop strength. You've restored the hoop strength back to its normal position when you get this flounce. So this flounce is basically a tension in the meniscus, the hoop strength, which we are restoring so that it can act like a shock absorber for the knee. So you see that S-shaped curve back to where it belongs. This is another case for with a scorpion device. This is for the lateral meniscus. This is what I prefer for the lateral meniscus. You see a vertical tear there, and I'm going to take my first bite in the periphery and making sure that I'm not damaging my articular cartilage. So I'll turn my scorpion away from the articular cartilage, and then I'll take the bite in the on the anterior side. Now, this is a very, I could have easily excised this meniscus. Many people wouldn't have repaired it, but I have good results repairing this kind of meniscus as well. So this is what we did. We passed multiple stitches with half hitches, and we repaired this meniscus. Uh, so we were talking about neurovascular structures. Now, this is a very, very good slide. You might want to take a picture of this, where the neurovascular structures are shown and the direction of the trajectory for the medial and lateral meniscus repair is very classically shown in this paper. And it's a very, very good, anatomical landmarks which you can identify and know where your neurovascular structures and how do you want to avoid them whilst doing an all-inside meniscus repair. As I said again, this was published, the absence of flounce signs and recreation, which we had done in about 3-4 years back. And this is what it looks like once you repair the meniscus. Thank you so much for your attention.
Thank you, Amin Rajani. So I would like to tell one thing. I worked with Rajani in Mumbai in Bridge Candy Hospital in 2006, and I would like to have one photograph with him. Maharaj. So it's a good surgeon. We have good time in Bridge Candy in 2006. Thank you. Any more questions? Thank you. Any more questions you can ask, or otherwise we'll go for the live session.
Thank you so much.
Live is ready. So I think live is ready. To chair this session, I would like to request Dr. Soumyadi and Dr. Ashish. Come and chair the session, please.
Hello.
Eh, Yeah, Sandeep. I am Dr. Praveen here. Yeah.
Kintu?
Yeah.
Dr. Sandeep, Somadeep here. So please tell about the patient profile.
Somebody, this is 54-year gentleman. He had a very recent episode of trauma 10 years back. And clinically, he has got ACL laxity on MRI. There was a irreparable type meniscus tear on the lateral meniscus, which we have repaired. So I have harvested the graft and prepared the footprint of the femur. So I am going to show. So what we are going to demonstrate here is partial reconstruction with CVT with internal brace. So graft diameter is almost 8 degrees, 8 mm, sorry. So can you see the image?
Yes, we can appreciate. You have already harvested the graft, I hope.
Yes, graft has been harvested so many.
Tell us about the graft diameter and the length.
Graft length equal. Graft. And now I have done quadrupled, so it is coming 8 mm diameter.
Okay. So you are cleaning the intracondylar notch area. So getting the
That's the fragment of the meniscus.
yes, we have see same thing in the morning. So it's very important for all of you to clean these tissues. Otherwise, this patient comes with a extension lag and pain in the post-op and just bother you.
So that I have removed it. So and we'll come back to that later. So and what I'm going to show, start with the taking femoral tunnel first. So what I do, there are various angles available. But what I do, that's but because my graph diameter is 8 mm. So you see, that's where is the ideal footprint. Where exactly it should be promoted by a resident ridge and behind that.
Yes, that's the resident ridge. So you have to clear all the tissues to get the full view. Otherwise, your resident ridge must be you may go on the resident ridge and it will be too anterior at the
So
end.
what I'm going to do, my graph size is 8 mm. So that's 8 mm reamer I'm taking. I'm going to use this reamer itself as a AMR. So that's where I'm going to enter. So I'll see I'm behind the cartilage, just behind the posterior cartilage, and come slightly entry, and that's going to be entry point for the femur. So that's bifurcate ridge here, just behind the bifurcate ridge. Take the pass.
Yes, so you are using your remark to guide your guide wire and to get the actual position of the tunnel. Do you use your offset jig ever?
I used to use now, I don't use until you are. So now, present here, Ramesh from Arthrex, he's going to give this reamer. So that will work as my now. This please. Go, 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 yes, pass. Wait. I will immediately pass my shoulder from the top, clear out the debris because so we have 150 inside. Go, 25. Go, go, go. 20 going in. Can you appreciate that? Go, go 25. That's it. Come out. Okay, yeah. Apply 4.5. Can you appreciate it, Somebody?
Yes, yes, yes.
So my socket is ready.
What is the fixation device you're planning on the femoral side, sir?
Sorry?
What is the fixation device you are planning? Is it endo button or?
Flexible loop. From Atrex. Good.
Okay.
Good. Good.
It's a straight rope.
Yes.
Oh.
So they have already treated. So my femoral tunnel is over. I'm going to show you from the anteromedial portal later on. Now, what I'm going to write now, I'm going to start my loop there so that that can be helpful for passing the graft. Samalo, 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 samalo. Yeah, perfect.
What is the femoral tunnel length you got?
I don't measure the tunnel length. What I do is socket of 25. I don't think it is required to measure because it will be adjustable. Now I'm going to that's a footprint jig. So we have seen very clearly that's the root of the anterior root of the lateral meniscus. That's the original footprint. So ideally it should be around 7 mm from the anteriorly and around 10 mm from the posteriorly. It was very well described or shown by Dr. Amin Rajani in his surgery. So I will try and come somewhere here. So it should be posterior and lateral to the root of the lateral meniscus. Yeah, please. Pass, yeah, pass, yeah. Perfect. Go.
So what angle you are keeping the jig? 55 or 60? 50 or 60 or 55?
Please. Right.
Yes, it's exactly the footprint of the tibial footprint. So what angle you are using or you are
55 degrees.
55 degrees?
Big angle was 55.
So what is the length of the tibia tunnel?
And I think since amplitudes, yeah. If I'm going to use the screw, and for improved place, I'm going to put the swivel lock. How many people routinely measure the length of the tibial tunnel? Good. You measure somebody?
Yes, please repeat the question because your voice is breaking. Please repeat the question.
Measure the tibial go.
How many?
If you measure the tibial tunnel length, slowly go, gently go. You see that someone else, yes. Okay, ready.
Was I routinely measure the tunnel because I usually do screw on the tibial side. So because we have to check that how much graft is there. So I usually check the tibial tunnel because sometimes if it's too short or too long, that will be creating a problem with the graft and the screw, and I don't want to create a problem later. So we can adjust accordingly. We can change that degree of the jig and play.
And so you the tunnel.
Yeah, once we fix the jig, tibial jig, so we can see on the bullet also that what is
Yes,
the
that
length of
what's
the
the
tibia.
length. So
We
it's a
really
good
don't have
practice
to.
for the beginners also. So good
Looking
practice
any
to
case,
see.
you will get minimum 7 length graft. Okay. So depending upon if you put 18 to 20 in the femur, remaining in the joint and rest of the will be in the tibia. So even if it is small or long, it doesn't matter. If graft is coming out of the tibia, you put the screw. If it is not coming out the tibia, put the suture disc. That's how I make it. Okay, so that we have passed it. So now we are going to immediately go and prepare a graft.
So please focus on the graft. AV guy, please focus on the graft.
Where is the camera? Okay. Light, please. Yeah, can you see this?
Yes, no, we are not. Now we can see the your.
Don't worry, I'll change the position. Can you see now?
Yes, we can see the.
Yeah, so that's a adjustable loop of the Arthrex with IB. It is called as IB because there is an internal brace which has been incorporated into it.
Okay, it has a fiber tape within itself.
It has been incorporated. So it is going to be like this. Like this.
So what is this device? What is it called?
Tightrope IP. So that's a regular tightrope. There is a press in between. See this fiber tape?
Yeah.
Yes, yes, sir.
So we'll quickly prepare a graph. Leave it as it is. Hold this. Hold this. Number 581, please. Needle holder. Yeah. Yes. So what I have done, I have already quadrupled the graph. Okay. Now I'm going to just
What is the length of the graft, sir?
32.
320.
So let's see if you want number 5. I have straightened the needle. So what I'm going to do, I'm going to puncture here at the end. You see? And now brother Ramesh here is helping me. Again, I'm going to puncture closer. So that makes such a wonderful look for me. Zoom out, please. You see?
Yes, yes, sir. We can
I'm
see.
going to use it for making the graph. Hold this now. Not you, some other person. And you, that's a double graft. Okay? So I'm going to do this wonderful technique was taught to me by Dr. Pradeep Nemare, who is a very famous polyacetabular surgeon. I stopped using it, but I have been using it very routinely and frequently. So it can be very well done with the help of number 5 if you want. Helps in making the hip stitch very quickly. So effects also have a loop which can be used like this. I just wanted to demonstrate no offense against anthrax people, but I just wanted to demonstrate to the people that with the Ichwan also you can very well manage and you get very nice compression of the graft from either side. So there is only single hole inside the graft tendon. So see this?
Yes, yes, sir. We can see.
So now what I'm going to do next is I'm going to load internal brace into this. I mean first loop and then that's internal brace. Hold this, make it equal. Open and equal. Huh? Yes. So ideally, there is no how do you put it is nothing like that. Because you just people say you try and hold it inside the graft. So that is not always possible. You can do it. So I'm just working in such a way that brace is there inside the tendon. So when we start doing tightening, then this will also will be spiraling. 1 second, I'll just take out from here.
We lost the video, sir.
Yeah.
Yeah, you're back now.
So I'm going to just put that internal brace into the incorporate into the graft. I don't know how much helpful it will be, like if it can hide or anything, but that's how it's going to be on the graft. So beauty of this is once you tighten, the graft will go inside, internal brace also will be shortened. And then I'll be fixing this internal brace in a differential rotation. So if you ask me if I do it routinely, no, I don't do it routinely. And you should not go with a message that internal brace is gold standard and कहीं जाके मैं क्या कर सकता है. No. It is just for the sake of demonstration. Sizer, please. I'm demonstrating. There is no message that you should do it very routinely and for all the patient. No, I don't do it. But it is important segment of patient, like always feel, you know. So that's my 8 diameter graft. Very nicely. Passing. Okay. So I'm going to pass this and I'll show how the internal brace needs to be fixed. And I would also like to show on this only graft. See, if at all you think patient is getting reaction and all, you can anytime pull this out. Okay. Like even though it is getting incorporated into the screw also, but we'll be fixing this brace with a swivel lock onto the shin like switcher post. So this will be, I'll be fixing at 90 degrees flexion and I will be tightening and putting the screw at 20 degrees of flexion of the knee. That's what is the plan.
So you'll fix the tape separately, sir.
Yes. So if you remember, we have done a 25 socket. So I put it here, mark at 20. Yeah. Okay. Come on. All this. How many of you prefer internal brace or use internal brace?
I have not used yet. So maybe one from the audience was Dinesh, please share your opinion.
लगा टाइप करने के लिए hold it here.
I tend to use internal brace very rarely, sir. But when the graft size is small, I feel that for the person's BMI is very high and the graft prepared is very small, I use. internal brace, but I don't think internal brace is going to increase the diameter of the graft.
That's the most important message, that only this very graft is very small. As Dr. Dinesh is using this, he is telling that when he thinks the diameter is very small, then he can use.
So now see, that's the from anterior. You see, 5 to mm from posterior articular cartilage, around 3 to 4 mm from the inferior. That's the canal. Yeah.
Yes.
Okay.
The button is flipped on going and.
Now I'll be visualizing. Go, pull, wait. Yeah. Go, pull. Give him artery, please. So always in my case, I always check if it is getting flipped under vision. Pull. Always see to it that it flips under vision. Relax. Yeah. Wait for 1 minute. Take deep breath and then pull. Okay? Otherwise, sometimes people, yeah, that's it. Okay, done.
Yes.
Hold this. Yeah. So at this moment, show. I also like to do check doubly cross check myself. Show. Pull. Show. Pull. No, leave it. Oh, pull.
Sometimes even after exiting, it will not flip. I think tightrope 2 has a flipping thread also, so you can use that and flip it.
Oh. Yeah. Sort of. Yeah. Okay. Yeah. No. Okay.
Now it's flipped, probably. Coming out. No.
Oh, no. You flip. Oh, okay. Like, pull and check, please, brother. Yeah. Okay. Done. So always be doubly sure that it has flipped. Yeah, and region. Very good. I'll shift scope back into the anterolateral porta and we'll start tightening. Please do. Shortening the. Yeah, please counter, please on the knee. Yes, very good. Go. 1 second. Wait. Hold it. Now you see there is a little laxity of the internal brace.
How much graft you are planning inside the tunnel?
Around 20.
20.
Yes, I have till 25. Yeah. So I'll remove the slack of the internal braces. Around 20. I have marked at 20 only. You will see the mark. Tighten, please. Counter. Yeah. Counter. Tighten. Tighten. Hold this. Wait. Yeah. Yeah. Please tighten. Yes. Go. Wait. Hold. Very good. Pull. Tighten a little more. Very good. That's it. Perfect. So that's the graft. Internal brace is inside, and these are the two free ends of the fiber tape. Are you able to appreciate it?
Yes, we can appreciate the graft well inside the femoral tunnel up to
Check.
the
Of delegates. There is no impingement there. Knee straight. That's some remnant of the ACL. No impingement. It is moving very freely, and and that's the graft. So I'm going to fix the internal brace now. So I'm going to fix it in 90 degrees. Let's see here, please.
Yeah, IMS, I still use mostly screws. So what you are planning in the TBL side? Screw.
Yes, so ultimately it's screw. So you see right angle retractor, please.
So how to assess to what diameter of screw you have to use? Please.
Graft is 8. So I'm going to put 1 diameter higher. Right, right. So that's the internal brace. This you keep it out.
So first, what would you fix, sir? The graft or the tape?
So when you use the internal brace, it needs to be fixed at different place separately. In case I want to take it out, I can straight away pull and take it out. It can be removed also.
What's the position you would fix it the tape in?
Point of flexion. So I'm going to fix it right here with the swivel lock.
You'll be using civil law?
Yes. Let's swivel locks stop because this one is not that soft. So I'll go. So I'm still getting the resistance. So again, I'm still the all the delegates. This is not the case. This implant is not for all arthroscopy cases, not for the social media gimmick that you use. I use internal bricks and when feel back to your sports and all that. But you should also have a knowledge when it needs to be used, how it needs to be used. So, yeah, look, look this please. Take it. So that's a swivel lock. Yeah. Closer.
What is the size of the tap?
That's all. Correct? Yes. What's up? And again, doubly cross-checking with the Prabhakar from Netflix. Very helpful person. Kept everything ready. Chal. Good.
Dr. Sandeep, I have a
Do you give any posterior drawer when you are fixing this?
This I'm just
tape?
putting at 90 degrees of flexion. I yet to put the screw. Go.
Dr. Sandeep, Dinesh here. I have a doubt. Is the internal brace to be fixed in full extension or in 90-degree flexion? 90-degree flexion.
Why I'll tell you? Because in 90 degrees, if you see the graph is a bit in the because why separately that also one reason is there is some load on the graph. But to avoid that load on the graph, we have to give this internal brace. Our objective is not that this internal brace is going to transmission. Yeah. Or give one. Yeah, 1 second. Yeah, one. Take out. Sorry. So just to prevent stress onto the graft. Sorry. Yeah. Cut. So that will cut at the end. So internal brace we have already fixed. Can I appreciate it?
Yes, sir.
Now I'll come and screw line down 2023. So graft is solid. Solid is there or
What is the size of screw you are using, sir?
one size higher. So that's the graft is outside. Can you see it? Outward please. So Samadip.
Yes,
Yes.
Graft is here, still outside.
Do you use regularly dilator, sir?
Sorry?
Before fixing the screw, do you use any dilator?
It's okay. And I don't know, but fortunately I never experienced breakage of the screw also, because in literature was mentioned sometimes that screw may break, you know. So far I have never experienced it. Sure. So that's bio screw by Artrix. Still driver, please. Very good. Perfect. Very nice. Ranaji,
It's a biocomposite screw.
composite screw, yes. 9 by 23. So after 23 and 28, and even longer size as well. But for ACL area of this, so I prefer usually 23. Very nice resistance. So when it is about to, the head is about to disappear, I'll take out the hook to listen. Because sometimes if the big pin is little angulated, it may get compressed, it may break, many sort of things can happen. Yeah, very happy. So these are the two different things. Now here also another thing is the advantage of, as I explained, I have done 25, but I'll put the graph till 20. So now I'll ask whether here to tighten it again. So if there is any laxity left, that also. So we'll again retighten. So that is the purpose of keeping that 5 mm short of socket.
Inside picture, please. Please show the now. You're putting the scope again.
I put after tightening. Oh.
You don't do tightening under vision, sir?
No. Put. Pull. Okay. And put scope now. And with a very good stability. They can show you earlier wherever we had done anterior driver at the beginning. Token sheath and token. There is quite a lot laxity.
That's the what's then look for this thing.
That's a graph. Good.
Yes, it's a tight graft.
And that internal brace is not to be seen. It is somewhere between both the ends of the graft or tissue of the graft. Okay then.
Okay, thank you. Thank you for your nice demonstration. Thank you. We are all spellbound. Thanks, Sandeep.
Okay.
We'll catch you here soon. So we have two important talks now. So first one is from Dr. Purnachandra Tejwasi is from Hyderabad. He will be talking on meniscus root and ramp lesion. Very important to diagnose. There will be another talk by Dr. Prahlad because after that, so he will go for live surgery from here. That after these two talks, we'll break for lunch.
Yes, yes, yes. Yeah. I just close this remaining of the acid. Take the knife.
So can we start?
Yes, yes.
Thank you again. It has been a wonderful meeting. I'm enjoying it thoroughly, and I hope everyone is doing that as well. So this is a very important because this is a very important talk, as Soumyadeep sir said, because most of these lesions are underreported by our radiologist. So we should have a primary understanding of what is happening with these things, because not treating them as part of a regular arthroscopy would lead to decreased outcomes and persistent complaints. So I'll break this again. We'll do it as a case-based discussion, not much on the theoretical aspect. So this is a 27-year-old male. He complains of right knee pain and instability while running. He had a fall while he was dancing around 5 months ago. Uh, and Yeah, sorry. He had instability and pain while running and dancing. He's an avid dancer since 5 months. However, his injury was due to skid and fall from a bike around 5 months back. He had opted for a non-operative management even though he was advised a surgery by his local surgeon. Right now, he has Latchman and anterior drawer grade 3. So this is his MRI. You can see the first image on the left and the top shows a complete ACL tear. However, we have to look keenly at these injuries, 5 months, 6 months old injuries with ACL tears. We have to be very cautious to look very properly at the MRIs to see if they have any concomitant injuries. Here you can see both in the sagittal and coronal sections, you can see the small cleavage, the one image on the right, which is suspicious of a posterior meniscocapsular tear, which is most often which is most often the location of ramp lesion. The same can be seen in the sagittal images. Unfortunately, most of these is not reported. We have to be very cautious and try to recognize them in the preoperative stage so that we can counsel operations appropriately regarding the treatment and the postoperative regimen. So diagnosis, this is a ACL complete tear, medial meniscus posterior horn tear, and a ramp lesion on the medial meniscus. So what is a ramp lesion? Ramp lesion this is where the location of the ramp lesion is in the posteromedial, in the posterior part. Most of the times it is the medial meniscus. Of course, it can affect the lateral meniscus as well. So what is the anatomy of this area? It connects the meniscus along to the tibia. This is the meniscocapsular junction. This also acts as a stabilizer against translation. Those ramp lesions which are undetected, and only when an ACL reconstruction is done, patient has residual instability, showing that this definitely plays a role in stabilization of the knee. And of course, it has to be identified and treated. Most of the times it is associated with ACL rupture, and it seems very naive. It is not diagnosed on simple arthroscopy. That is why we say that we have to probe every meniscus that we do along with an ACL to identify these injuries, because without probing the meniscus, this can go undetected and we might not be able to treat it. So what do we need to treat this kind of ramp lesions? We need lassos. The regular lassos that we use with our shoulder, that is a 30-degree, the blue and the dark blue one. The problem is they have a far ahead curve. So when we take a bite in the medial aspect, the exit is more lateral. But for the shoulder, that is okay. But for an area like knee, where there is where it is tight and posteromedial compartment is very less space, this becomes very problematic. So this is where this quick pass lasso comes in. It is available with Arthrex. The advantage is this has a tight curve, so that wherever we take the entry, the exit is just ahead of it and makes our life very easy. So how do we do it? We always probe the meniscus, as I said. Then uh, if we suspect a ramp lesion, we have to do a posteromedial portal or a posterolateral portal, sometimes both of them, but I perform with one portal. I sometimes use a 70-degree arthroscope in this area if the lesion is located little below in the meniscocapsular junction. We use a left curved lasso for a right knee and vice versa. Then we can insert cannulas, but I think passport cannula helps because it is not rigid and helps in the maneuverability. I personally don't use cannulas. You pass the lasso with your device and then shuttle it with a 0 number fiber wire and then tie it like you tie a shoulder knots. This is how we do it. So this is what I did for this case. You see, this is a right knee. The arthroscope is in the anterolateral portal, 30-degree arthroscope. You can see this is a 6-month-old injury, so it is completely ACL deficient. as you can see this here. And once we do this, the knee is taken into extension at around 30° with valgus translation. We probe the meniscus. To see with naked eye, this meniscus looks pristine. There is no problem at all. However, the problem is when you put your probe in the posterior part, and this is abnormal mobility. You see, if you leave this alone, and that meniscus which comes back, front and back, can cause residual instability. Now you drive your scope into the posteromedial compartment, and this is where you see that there is a defect. So this is where, when I suspect this is where I personally use a 70-degree arthroscope, and this is how it changes the vision. If the scope is coming from the anterolateral portal, but this is a 70-degree, and you see this ramp is located quite below. Sometimes it can be very tricky with a 30-degree arthroscope to identify this. Once this is done, you do your posteromedial portal, that is a spinal needle. You could do it in many ways. You could do it over a Wissinger rod, dilate it, and put a cannula. And once this is done, so it's because this is a chronic lesion, we need to have the healing milieu there. So it is very important to create some bleeding edges. Although research-wise, this is controversial whether this is required or not, but it makes you feel better. So this is a diamond rasp. I think everyone should have this. This is a very useful instrument. Again, as I said, research-wise, this is not very useful, evidence-wise, but it makes you feel better when you do that. So once this is done, this is a right knee. So you need a left curve lasso. That is a lasso. You see, curve is very tight here. It does not go way ahead, because if you start your, as you see, if you start your bite in the lower aspect, in the medial part, if the curve is too far ahead, the bite would come too laterally, and this would make the repair look not so nice. So you sequentially do this. You take your you shuttle your sutures out and shuttle this with a 0 number fiber wire. You repeat this with as many stitches you want. So this is the second one, similar kind. So first take in the inferior capsule and then come in the meniscus. It's sometimes easy to take bite into the meniscus when the knee is a 90-degree, because the condyle would push the meniscus posteriorly, and then it takes easier to take bites. So this is second. So because of the tight curve of the instrument, it is very easy, and it makes it a straightforward repair. So there are various techniques that have been described. One of our colleague, Dr. Sheetal, has a very good paper published. He uses a knee scorpion to do this into a shoelace kind of technique. You could do that as well. But I'm quite comfortable with this, because I know where my bites are going and how deep. So you see 3 consequential vertical mattress stitches, and you just tie them one by one, starting from lateral to medial, and you can have a very good repair. So and then you follow it up with a regular ACL reconstruction. So important thing here, take home message is always probe every meniscus along with an ACL, probe the posterior part and see if the meniscus is coming inside. Most of the times it is the medial meniscus. Of course, lateral meniscus can be seen. With lateral meniscus, it is very easy to see the capsule. But however, medial meniscus sometimes can be difficult. So probing is very important part. And the repair is cheap, easy, and just we need to have a couple of things in our ACL armamentarium to just finish this off. Otherwise, it can become a hassle. Coming to the meniscal root tears, this is a total different entity, most often seen in middle-aged or elderly patients. So again, so this is a 49-year-old male. So he is operations in charge of a big MNC, quite active. He was an avid golfer and frequent traveler. He has had knee pain since around 10 weeks. Has had some Kinocort shots. He has had a PRP injection. He has done a lot of rehab, lot of fitness related work. He had only transient relief with the injection, but pain is troubling pain. Even he can't walk for few steps. On examination, he had medial joint line tenderness, mild effusion, knee ROM was okay. So this is his alignment film. You can see a obvious varus thrust gate in his both knees. However, it is more on the right side. His slope is okay. Here, this is his meniscus. You can see this is the ghost sign. Very clearly in the image on the right, you can see that there is a medial meniscus root tear. So a 49-year-old young active individual, quite active in sports, a slight varus thrust gait, grade 1, grade 2 osteoarthritis with a medial meniscus root tear, failed conserve. I think this is a very good thing for treat. So what do we do? So diagnosis, as I said, medial meniscus root tear, varus aligned knee, or very, very early OA. So options would be conserve, rehab and NSAIDs. Of course, we can try this, but for a young, we could try conserve and rehab for a root test, but I would do this only for elder 65, 70-year-old patients who are not very high demand. We could try conserve for 1 month, 2 months and see if the pain is coming down. If the pain is not coming down, if there is less OA, I would progress to repair. However, for a young active individual, I will tell you why we should not conserve. So when we operate, we know the options. We can do a meniscectomy, we can do a root repair, we can just do a HTO or a high tibial osteotomy plus repair. So how does this function? We know that the meniscus functions as a load distributor. It provides lubrication and stability to the knee joint. So what happens with a root tear? The meniscus is very important because it provides load distribution and helps in the hoot function, as Dr. Rajani said. So loss of this root tear leads to this important loss of hoop function, and this is equal to doing a total meniscectomy. Just the meniscus tearing off from the posterior root is just equal to us doing a total meniscectomy. Many studies have repeatedly shown this is direct correlation with progression of osteoarthritis from early to later stages. So this is very important. What is early OA? We have 4 lesions in early OA. We have chondral lesions, that is cartilage degeneration. We have degenerative meniscal lesions. This is frequently seen in MRI. We have grade 1, grade 2 posterior horn degenerative tears. And the third, and we have meniscal root tears and meniscal extrusion. So 4 lesions, chondral lesions, degenerative meniscal lesions, and meniscal extrusion and meniscal root tears. Even though the first 2 lesions, that is cartilage degeneration and degenerative meniscal lesions, might not be so important in terms of progression of the knee from early to late OA, vice versa, the meniscal extrusion and meniscal root tears have a direct correlation. And so it is very important for us to tackle that to give a good response to the patient. So this is a very good study done in 2019, published in AJSM by Fossat and Leprad et al. They studied 355 patients with root tears, and they randomized these patients to meniscal repair, meniscectomy, and non-operative management. You can see meniscectomy in meniscal root tears, the rate of progression to TKA was almost half. 50 out of 100 patients progressed to knee replacement in less than 3 years for those patients who had meniscectomy in a meniscal root tears. Sometimes it might appear just good to leave it, to not treat it, than to do a total meniscectomy in these cases. However, the best results were with meniscal repair as per this paper, because only 1/3 of them progressed compared to those who were not treated. So between medial and lateral meniscus, medial meniscus is most often in a middle-aged, high BMI, early OA. Whenever a 45, 50-year-old patient walks into my OPD with acute knee pain, no frank history of trauma, complaining pain on the medial side, not even able to walk for 5 or 10 steps, I always suspect a medial meniscus root tear the first instant. In contrast, lateral meniscus tear is most often seen in the young patient. It is traumatic. Associated lesions in medial meniscus are varus knee, but in lateral meniscus, when there is a root tear, we often suspect a traumatic etiology like an ACL injury. So as I said, medial meniscus root tear is more common than a lateral meniscus. So whether do we add a HTO or a HTO plus root repair? There have been various contrasting studies. Some studies have shown HTO plus meniscal repair when done versus a HTO alone gives greater joint space increase and might give better results. However, at the end of 2 or 3 years, whether only a HTO was done or a HTO versus meniscal repair was done, the results seem to be similar. So further studies are really necessary to see if we need an HTO alone or we need to do a high tibial osteotomy along with a root repair. So what are the things that we need to have in our armamentarium before we go for a root repair? I think every case that we are doing arthroscopy for the knee, especially an ACL or a middle-aged patient, we should have all these, and this is very easy to have. We should have a device to take bites to the meniscus, let it be a knee scorpion or some other knee retrograde kind of device. The important thing that we need to have is fiber link loops. We could use 0 or 2 fiber wires. However, the fiber link loops make our life very easy because one step you can just cinch the knots. We need passport cannulas. We need you could drill the tunnel with a bead pin and a 4 mm pin. However, the retrograde retrograde drill bit from Arthrex flip cutter makes it very easy, and one step to drill the tunnel back makes our easy faster. So what did we do for this patients? So right knee, So we planned for a osteotomy for this patient. So my sequence is, you can see that there is an obvious root tear. You do pie crusting just to open that area up, and you identify the footprint where you want to put your middle meniscus back. Sometimes these have meniscal extrusion component. This patient did not have it. Is necessary to treat them to get the meniscus back to its footprint. Otherwise, it does not make sense. You roughen the area with your curette, a ring curette, or a whatever device that you have, so that to increase the healing potential. And once that is done, so there are jigs available for root repair, but I feel very comfortable with this ACL jig from Arthrex, because it gives me the results are very good, and it gives me a very good tunnel. So this is the flip cutter. This is one step. You can do this with a bead pin and a 4 over ream with the 4 mm. However, this is a single step procedure. Just ream back for 40 mm with a 6.6 mm drill, and that would create the tunnel in single step. And once this is done, you put your passport cannula. Scope is in the anterolateral, probe is in the anteromedial, and this is the fiber link. So you load this. I'm sorry, because this is two talks, I'm taking a little bit more time, sir. Uh, so this is the fiber link. This is how it is. So this has a loop. You just load the loop end to the shaft of your knee scorpion. So that's how it is. And the end of the loop, you just take bite. This is how you load it. It has a loop at the end, the fiber loop, and you take so. And now once this is done, once you load it, you take bite into your meniscus with whatever retrograde device that you have. And this fiber loop, because it has already loop that we have loaded onto the shaft, so you just slip it along, and that would create a cinch in one step. So that is how it happens. And you similarly, you do another stitch of the same type, and you shuttle your sutures out through the tibia, and then that is how you would look. Yeah, of course, this is done after the HTO. I would take the bites into the meniscus, finish my HTO, and shuttle the sutures out after the HTO. So this is how it would look. So of course, I did a high TPL osteotomy for this patient. And yeah, so in conclusion, conservative for root tears. According to me, we should only try for elderly, non-traumatic tests with low demand. We can definitely conserve them for 2 or 3 months before we go ahead with surgical option for this patient. However, in acute tears who have failed non-operative treatment in the elderly, the repair is the best option to give optimal outcomes. And important thing is to correct the alignment before we do any root repair. So in conclusion, root repair significantly improves functional outcomes and seems to prevent the progression of osteoarthritis in our patients. Thank you.
Thank you, Dr. Purnachand. No, so I'll request Dr. Prahlad Singhvi to for his lecture on evaluation and management of knee chondral injuries. So chondral injuries are very common in as ACL tear. So we have to be prepared to deal with it, and we have to read the MRI correctly before going to the surgery or before going to the theater, because otherwise you may, if you don't have the armamentarium in your OT, so you'll end up in crisis.
Sir, at the outside, I thank the Vizag team and Sridhar, Aslam sir, and Praveen sir, everyone, for having such a wonderful meeting here today. So, uh, as Soumyadip was telling, cartilage is one thing like which we often overlook, and and we land up in problems. So it is very important you identify these injuries before you go into, yeah. So before we you have this, or shall I use Okay. So you all know I am Dr. Prahlad and I come from Madurai Priti Hospital. So yeah, this. Yeah. So we all know uh, cartilage is not just a cartilage, hyaline cartilage, but it is an unit, osteochondral unit. So which is again made up of the hyaline cartilage, the calcified cartilage layer, and the subchondral unit. So all these three together forms a very important structure, and it is very useful for doing the joint movement and all. It is moving on own. The slides are moving on own. So this is how it looks on the MRI and histopathological examination. And this is the function of the cartilage. It is the load dispersion, uh, frictionless motion, and then you have the chondro-osseous junction, that is the calcified layer, which forms a bridging anchorage between the cartilage and the bone. And then we have the subchondral bone, which is most important, and it gives mechanical strength and nutrition and nociception for the cartilage. So this is how a normal cartilage looks, and the degenerative cartilage, it is moving on own. The slides are moving on own, so you have to display.
So you are pressing.
No, I'm not pressing that. So there is the setting, no?
No, here it is.
Okay. So this is how it looks on the arthroscopy and also on the histopathological examination. This is the subchondral bone. So the subchondral bone is very important. Suppose any pathology in the subchondral bone, you can see the effects seen in the cartilage. As if you see, this is like Sonk lesion where the cartilage gets degenerated, and this is subchondral osteochondritis dissecans. So when the cartilage plate is intact, so you don't see anything on the arthroscopy. The cartilage look pristine, but similarly, when the cartilage, the subchondral plate is broken, you can see the cartilage gets degenerated. So it was way back in 1887, the Koenig coined the term uh, osteochondritis dissecans, and then there are these several osteochondral fractures because of the severe trauma. When the lesser trauma, it is called the bone bruise. Sometimes it can cause a chondral separation, and a traumatic lesion can be the osteochondritis dissecans. So the joint stability instability can also be a cause of the ankle cartilage injuries. So we have to know that 80% of these ligament injuries, and particularly the patella dislocation, can be associated with the osteochondral injuries. So when we are planning for ligamentous injuries, we should be aware of these things. These are various terms to describe the cartilage pathology. So to have a very good idea about the cartilage pathology, the diagnosis is very important. You do a very thorough, take a proper history, clinical examination. Then we have the various radiological modalities, and particularly the MRI is more useful. So acute injury clinical examination, as I told, is very important. Sometimes we tend to miss these on the clinical examination because they are overshadowed by the ligamentous injuries. So it is very important if the patient complains of locking episodes or unusual pain. So we should be very keeping in mind of these cartilage injuries. So high index of suspicion is very important, and then you can do an appropriate investigations. Uh, like X-ray, CT, MRI to identify this pathology. So X-rays are again very important, but it is very difficult to identify these injuries on the plain X-ray, but you should again have a high index of suspicion. But the delayed pathology as given by Kellegren's classification can be identified well on the X-ray. So ultrasound, again, it is operator dependent and it has a steep learning curve. So it is very difficult in deeply seated joints. CT arthrogram has a very minimum role, but you can still think when the MRI is contraindicated for assessing the cartilage pathology. So the MRI remains the most important modality of investigation to identify this pathology, and it is the most viable non-invasive means of investigation. So there is something called gadolinium enhanced MRI and also integrated it can be integrated with the PET scan to better delineate and identify the cartilage pathology in advance. Arthroscopy remains the gold standard for evaluation of the cartilage pathology, and we should be always have certain things in our armamentarium when we are dealing with these kind of our routine cases to address the cartilage pathology also. So most of the cartilage lesions are either classified based on the arthroscopic findings or the MRI findings. So outbridge classification is the most common classification we come across for these cartilage lesions. So outbridge is was defined for the chondromalacia patella initially, and now we have extrapolated to all cartilage injuries. So it is grade 1, which is just softening of the cartilage. Grade 2 are the fibrillations, and grade 3 is when the cartilage get exposing the subchondral bone. Grade 4. So this is International Cartilage Repair Society classification, which is again into 4 types depending upon the various depth of the lesion. So high index of suspicion in acute osteochondral injury is again important. So sometimes you can pick them on the X-ray if they have some subchondral bone, but pure cartilage injuries are again very difficult to be identified on the X-ray. So MRI, as we discussed, is investigation modality. So what are the various treatment modalities for these injuries? Again, these are the various procedures which we know can be used. Like we will go in detail one modalities of treatment. So based on the acute injury, you can, if the cartilage fragment, osteochondral fragment is big enough, you can fix it with biopins or Herbert screws, or you can use compression screws. But in chronic injuries, then we have to think of various modalities like mosaicplasty, OAT, ACI, and others. So hyaluronic acid is again like we can think of degenerative cartilage lesions in the osteoarthritis. So this now are again mixed with platelet-rich plasma. Again, an important thing which is orthobiologics is coming into big way. In my practice, I don't use these much. Now, even we have these stem cells and BMAC for these kind of osteochondral injuries. So BMAC is again an important, is one of the good option for lesions which you come across. You can use these as a one of the option for treating the chondral injuries, contained chondral injuries. So again, ASI, that is autologous chondrocyte implantation. So now we have moved from first generation, second generation to third generation, but also now there is a fourth generation also. First generation was where they have harvested the cartilage chondrocyte and then reimplanted, grown and reimplanted with a periosteum sleeve, then collagen, and now with the MASI, with again collagen matrix. And the fourth generation is coming with the growth factors included in this. Microfractures remains gold standard for any unidentified when we see in our day-to-day practice. But again, the role of microfractures is very limited nowadays. Sometimes we have to be very careful that it can be done for a contained lesion, smaller lesions, not a very big lesions. So OATS is like osteochondral autograft transplantation. So this is you can do arthroscopically taking a healthy cartilage osteochondral unit from a non-weight bearing area and then transfer it to the weight bearing area when the defects are very big and huge, so you can do this by an open procedure, and it is called mosaic plasty. So this is where the various ways you can do these procedures. So this is one case example. A 31-year-old lady, lactating mother, she had a patella injury, and she had an uh, big osteochondral fracture. You can see this has a little of subchondral bone. So it is ideal you fix such a big chondral lesion. So we did fixation with biopins and also fiber tape, fiber wire, sorry, and then we did a medial imbrication, and this lady did excellent. We did an repeat MRI and CT also to see the healing of the cartilage, which healed perfectly. So this is again an 20-year-old osteochondritis dissecans. This young chap presented to me during COVID time. We treated conservatively. Again, after 2 years, he came with persistent pain and decreased activity. And then we did this. So uh, here again, there was just a softening of the cartilage. You can see there is an bulge of the cartilage around that area, but there was no any breach in the cartilage. So as I showed that previous X-ray and film, no. So we decided to do a in situ fixation for this young chap with a Herbert screw, and this after again 2 years he started trekking, and he's just shared these pictures. He's doing excellent. His pain has come down. So again, osteochondral injuries, we do a lot of trauma. So biopins is a very interesting thing. You can always keep in your armamentarium. You can always fix using biopins. This is on the femoral condyle. So again, microfracture, chondral ablation are certain common we should keep in our armamentarium. This is the micro fracture, all which can be used for the patella fracture, patellar lesions. So to sum up, clinical history, physical examination is very important, and your imaging, try to identify these cartilage injuries well on the MRI so that we can be well prepared when we go for the arthroscopy. And the role of conservative treatment, then we can think of arthroscopic procedures. There are various procedures depending on the type of the lesion and the size of the lesions. Thank you for the patience listening.
Thank you, Dr. Prahlad. So, any questions to Dr. Prahlad and Dr. Bruno Stock?
Sir, any role for retrograde drilling?
Yeah. The retrograde drilling is again a good option, particularly in talus. So we have done in several cases of talar osteochondritis, we have done retrograde drilling, but there are papers from, I think so, Santosh and Karthik, they have done the retrograde drilling, and they have good results.
Your case, that stable OCD you showed.
Yeah.
You have put 2 intraarticular Herbert screws. Did you remove it or just left it?
No, they are buried synced inside.
Okay. Yeah, I think it's a good technique because it combines the both stable fixation as well as retrograde
drilling.
So it helps to heal.
Yeah.
Okay, thank you. We'll break for the lunch. We'll meet after the lunch.
Pen drive.
Review.
It is not playing here, but playing there. Huh?
Sir?
It is not playing here and playing there.
Okay.
Okay, so I have to see there. It's not showing here. Right. Maybe here. Okay.
Next is yours.
Yes. No, no. Next, I think it's live surgery.
Yeah.
After that.
Otherwise, we
So charge will not go, no? Okay. Going to take another 1 hour. Oh, okay.
ये पावर पॉइंट ओपन नहीं हो रहा है, एक बार देखो ना सर। हाँ, ये सोम इस दत्ता करके देखो, एक बार पावर पॉइंट ओपन नहीं हो रहा है। एक बार डेस्कटॉप पे कॉपी है उसमें। हाँ, ये फाइल you're afraid of it. That's क्या भी हो रहा है। पेन ड्राइव लगाने से डायरेक्ट पेन ड्राइव से नहीं चल रही है यहाँ से। कहाँ गया?
So, good evening, everyone. Let us start with the panel discussions. I invite Dr. Ashish to start his case presentation for the panel. So, I request Dr. Aslam sir to chair the panel discussion. I request Dr. Dinesh Chidambaram to Dinesh, Dr. Dinesh Chidambaram to please come on to the dais for the panel discussion to chair the session. This is right. Slogan. Yeah. Yeah. Please come, sir. Dr. Swami Devitatta. No, either way. Other way. Sir, Islam sir, please. You know, 1, 2, and 3.
Good afternoon, everybody. Let us start with one case discussion. 36-year-old gentleman, he is a construction worker. He presented to the clinic roughly 1 week after the injury. He had an injury of fall from bike, and on clinical examination, inspection, he had mild ecchymosis on the medial aspect of the knee, and there was diffuse swelling around the knee. On examination, Lashman's test was grade 3 for PCL laxity, and whereas valgus test was also positive. Medial opening was there, almost grade 2 to grade 3. I don't have the clinical picture, but the X-ray was like this. There was no bony injury, and this is the MRI images. I would like to ask the panel, like, what are we suspecting? Can you just, if you can read the MRI, sir?
Can we have the other pictures also?
Yes, sir.
It's a posterior medial injury,
Yes,
very
yes.
uncommon injury. The first thing is that for the all of them, I used to say that you have to look for the pulses. It's very important. So it's an uncommon injury. So for me, I will put the patient. I will wait. I will not do immediate surgery because I want to get things to be settled down. So
So it's 1 week after the injury, sir.
yeah.
And
So I can ideal time of this kind of injury is around 1 to 3 weeks is the
so
ideal window.
this is a PCL and
MCL on the femoral side.
yes, MCL on the femoral side.
So
So how you want to like go ahead?
so I will do PCL for my PCL. I'll do a single stage. PCL I will do with my central quad tendon, or I can use my peroneus. And this depending on the situation.
When you want to time the surgery, sir?
Yeah.
When you want to time the surgery, what would be
Yeah,
the
1
ideal time?
week if soft tissues is okay, if the everything okay, 10 days for 2 3 weeks is the window. So that I now if everything is settled, I can go straight forward to the surgery. 1 week is passed.
Is there any role for conservative panel? Anybody for especially for the MCL femoral tear from the femoral side? Can we wait for 3 weeks? Let it gel it up a little bit.
If it's isolated, we can wait, but along with PCL, so once the skin condition and the knee range of movement slowly improves, go with single stage PCL with MCL.
So, sir, what's your takes?
Uncommon injury with a PCL and an MCL combination, right? And normally you require a different rehab protocol for MCL and different rehab protocol for a PCL. Right. So definitely initially to let the edema settle down instead of doing a primary repair for the MCL. Okay, let the edema settle down, reevaluate how much of opening is there, then go in for reconstruction. First would be MCL and then would be PCL. So ideally both, but if possible, we can phase out both would give a better result than doing two at the same time.
So if it was a isolated femoral tear of the MCL from the femoral attachment, if it was an ICL MCL tear, would we try to conserve it?
We can leave on the femoral side. We can give trial, but explain both
So,
options to the patient.
so because there is an associated other ligament tear, so we are treating MCL surgically. So that's the message. Isolated MCL tears, I think we can wait and watch for at least 3-4 weeks, and then if there is any residual opening, grade 2 or grade 3 opening, then I think we have to contemplate surgery for that. So
Only on the femoral side.
only on the femoral side. That's what. If it was a substance or a tibial side, then there's no question of conservative management. So another question is like, you want to do a single stage in this first week of injury period. Do you want to do MCL only repair with reconstruction, or PCL reconstruction, or you want to like augment it or directly straight away go with reconstruction after 10 days of injury?
So I plan it as a single stage because this MCL may be repaired with augmentation. So my
If you want to augment it, what do you want to
with
do?
some kind of uh, graft, I do not touch my hamstring there because it's a medial side injury. I can use fiber tape or this kind of implant if you can get good hold with the repair, or I can augment with this some kind of synthetic graft if I available, and I will repair this MCL because in a early setting I have a very good chance of repair this MCL back in its position, having a chance of good healing. And at the same time, my first protocol will be to do the PCL because PCL is the pivot of the knee. So until and unless if you do MCL first, then your knee is subluxated posteriorly if you don't do your PCL. So first do the PCL, get your pivot back, and then fix your collateral. So I will do my PCL arthroscopically with whatever say CQT or peroneus graft, and then I will do my open MCL repair. I think mostly in early setting, even in up to 2 to 3 weeks, repair with augmentation with synthetic graft. So this
So I
is my
think
choice.
for the PCL reconstruction, I think we cannot do straight away in 1 week, 10 days duration. I think we have to wait for some time. What will be the ideal time?
If the repair augmentation PCL, if the if the whole the I cannot say from this that whole the fiber of the PCL is avulsed, we can keep the stump whatever piece two bundles are there. So whichever bundle is there, we can keep this bundle intact. Just augment keeping this bundle in position. We just augment another bundle with a graft,
Like a biological
the
fixation.
biological graft.
What is your take, sir, Dinesh?
Yeah. As I mentioned before, once the skin condition is
Timing of the procedure and
yeah,
what you would do first.
the main condition for me is skin condition and at least some 9 degrees of ROM. So then we can go ahead with arthroscopic PCL with peroneus longus, and then open on the MCL. Try to mostly it will come within less than 3 weeks, right? So we can do direct repair.
A repair and an augment.
Mostly the tissue won't be that much friable. We can most get away with that just repair.
Aslam sir, anything different? You would
Under ideal conditions, okay, MCL PCL combination, MCL with augmentation plus or minus depending on the tissue, and PCL reconstruction. If the condition is not ideal in the sense if there's too much of edema, kind of swelling in the leg, restricted range of movement. Okay. Now looking at the MRI doesn't look too sublux posteriorly. Okay. So there is an option of doing a stage procedure, but it's equally good to do a combined procedure with or without augmentation. So PCL, MCL with or without augmentation, depending on the condition of the.
One thing will give you a very good information in this scenario is your OR stress view. If you do a stress view, you can subluxate your tibia posteriorly, see that how much subluxation is there.
Depending on that, how long.
And as Dr. Sir has said, so and same thing on the medial side, that how much opening and compare with the normal side. So that's where you get an idea that how you can grade your injury, and accordingly you can manage yourself. And PCL, as it sir said, it is has a good chance of healing. It's a grade 2 tier PCL. If you can do a PCL brace or you can put a plaster class, you can get the tibia back in its position, and then in the second stage, you can do a MCL repair or reconstruction, whatever is left behind. This is also an option. So I think it has to be. It is there is
Patient is young. He is a construction worker. Can we like wait for 3 weeks for his?
No, I think if the soft tissue conditions permit, I will go with
No, is there any role for conservative treatment for PCL or MCL? Because it's a
this MCL, I don't think will going to heal up, because this there is a you, as you have said, grade 3 laxity. I think this there is a very less chance of MCL to be healed. So
That's what isolated MCL. I think we can wait and watch. But here we have a PCL. It's a very high velocity injury. I think we have to fix it. We have to reconstruct or uh, uh, simultaneously. But the only issue is the timing of the surgery. When can we time? That is, I think, what the panel has telling us. 2 to 3 weeks is a good period to do an MCL repair plus augment and PCL reconstruction.
Doing a PCL with hemarthrosis, okay, is not very convenient to do. As it is, PCL is not very convenient to do.
Yes, sir.
So you let the swelling settle down, because all the tissue is going to be very boggy. And when you open up, all the soft tissue is going to cause a little issue there. So that's why that 3 week issue is that you put him on a brace, wait for 3 weeks, let the tissue settle down, and then you operate comfortably.
Fine, sir. Is there
That's the
any
idea.
like apart from tape, do you want to like augment it with a gracilis graft, or is there any role?
Sometimes we can use the open stripper, retain the end, and then just cut it proximally. And if you want to augment, just fix it like.
Superficial MCL augmentation with the gracilis or a semi
If
like.
your tissue is okay, and if you're still doubtful whether, because it's a combination with PCL, they can use a fiber tape also.
Fine. So there is
With two single locks on either side, you can, that is good enough, because it's just to allow the primary tissue to heal. Because you
so
don't
it-
want to do a reconstruction now, because it's an acute injury. The chances of healing in an acute injury with grade 3 is good enough. So you give it chance to heal, and if it in future it fails, then you can do a reconstruction.
fine. So anything below 1 week, I think we are not touching the patient. We have to wait for at least 2 weeks for anything. If you are planning any procedure and all, I think these injuries, let the soft tissue heal, and then you plan your surgery accordingly. At least minimum of 2 weeks, I think we have to wait. And in this period, I think if the patient pain has come down, like we have to get a minimum range of movement also. At least 90 degrees minimum requisite should be there to contemplate any procedure on this thing. If the patient is an immobilizer or if he is on a cast for 2 weeks, and straight away we should not go ahead and do any surgery, because these people will again land up in arthrophyrosis. So a lot of stiffness will be there. So the principle is you have to give at least minimum 90 degrees of range of movement, and at least to wait for 2 to 3 weeks would be the ideal time for surgery. So what happened is this guy didn't turn up. He took a native treatment elsewhere. Uh, it's very common in this part of the India. So his knee was completely stiff. Then we have to put him on a physio protocol. So after 6 weeks, he presented to us. So after the physio and all, we could get his range of movement, and again we checked the laxity. So it was PCL, it was grade 3. and MCL is almost the same, grade 2 to grade 3. So at this juncture, like our plan is the same plan, or any change or anything different you want to do, or anything alarming or which you want to look for, or you should be cautious for.
I think go with the same plan. So regarding MCL, I will do the PCL first at this point, and I will check for the laxity on the medial side with the
On table.
on stress view. And then 2 to 3 is a very if it is, I feel that it's still lax. I think there is no question of repair there. I have to reconstruct this MCL.
So MCL is complete reconstruction. And what
At
reconstruction?
that point of time, I think reconstruction will be the only option. I think 6 months down the line.
6 weeks.
6 weeks. Okay, oh, sorry. 6 weeks we
He
can
presented for
see.
6 weeks. After physio and all, I think it took almost 8 weeks.
2 months
was over.
down the
2
line.
months were over, and
Okay, there is, we can, depending on the table on the stress X-ray, I will decide on the MCL, and then I can open up and see
the MCL is grade 2 to grade 3, sir. PCL is
PCL
cross
I have to do
laxity is
first. I'll do PCL first, and then decide on the MCL depending on the stress X-ray, and go ahead with a repair if possible, then reconstruction, or repair with augmentation, keeping all options there open, I think.
Same. Sometimes after PCL, sometimes the opening becomes less. So the same plan: repair plus or minus augmentation.
Repair. Is there any chance of repair after 8 weeks, sir?
And as sir mentioned, depending on the tissue quality, we'll take a call. If
Fine.
it's not so, then direct reconstruction.
Yeah, the pitfall is your posterior subluxation, whether it is reducing or not, and your range of movement. Okay, either way, you said that it is grade 3 laxity. That means it's still moving. So you're able to reduce it well. It's coming to 0. PCL.
PCL, sir. Gross instability is there, sir.
Okay, no. I'm asking whether it's coming back to 0.
It is coming back, sir.
No, it hasn't gone back and subluxed.
No. Sir. It's not
That is
fixed.
the pitfall. If it's coming back, I'm unable to treat surgery. We have a 12-week threshold for a medial collateral ligament, okay, for repair. So 6 to 12 weeks is the repair period. And still you can assess if you can repairable, fine, augmented. So since it is 6 weeks, I think we can go ahead with the same plan of therapy. But here, before you operate, you see whether the range of movement is at least 90 degrees, if not 110 degrees, or wait, put him on CPM for a few days, get that range of movement, and then intraoperative also arthrolysis is necessary to get it to 110 degrees or 120 degrees, and then again in the rehabilitation put him back on CPM, because otherwise he's going to have a rebound stiffness of the knee, and whatever you've done is not going to be of too much of use.
So fine, sir. What we did was he had a financial constraint, so we did him. This was the laxity video after 8 weeks. This was the last one. You can see almost it's grade 3. And this was the opening, medial opening. So we did a staged PCL reconstruction. Like standard posterior portal and so viewing through the posterior portal, drilling the tibial tunnel. This is the femoral tunnel and passing the graft. So we did a PCL reconstruction and waited for almost 6 weeks, and still there was laxity. So then we went ahead and this is the immediate laxity video, intra-op video. So We kept him on a brace, PCL brace, and the range almost after 6 weeks of surgery, we got a good range of movement, but still there was laxity. So we did something like an anatomical MCL reconstruction, Laprad's technique. I just want to skip through all these things. So this was the double bundle technique which we did, reconstructing both the superficial MCL and the POL. And this was the somebody's not playing. I think let's go with the next case. Praveen sir. Thank you, sir.
So, good evening, everyone. At the outset, I would like to thank all the delegates for attending this IAS One program in Vizag. And I would like to thank my sincere thanks to all the faculty who attended this IAS One Vizag. I have two cases to discuss. Very briefly, I'll go with this. So, I'll go with the next. Okay. And it is a 25-year-old. Next, this, sir. Yes. Okay. 25-year-old male. He got a sports injury 1 year back, right knee twisting injury. He has a pain and instability on the right knee. And he came to me with the pain and instability. He's a young chap. He's a software engineer. Sometimes he goes for sports. So this is his MRI. So MRI showed he got ACL injury as well as a medial meniscus ramp lesion. So I went in and so this is the posterior portal. Now you can see the ramp. With the needle, I am probing it. You can see the ramp. The posterior medial meniscus capsular separation, ramp lesion. So at this point, I would like to take the opinion of the panel. What would you do? You go with the posterior or you go with the anterior regarding this meniscal lesion?
Do you have a complete picture of the meniscus? Is it associated with any other tears, horizontal or?
No.
No. Oh, it's just a ramp lesion.
Yeah, it's a simple ramp lesion.
Yeah. Have you probed the meniscus? Is it moving forwards?
Yeah, it is
Grade
moving
2,
forward.
3?
Yes, it is moving forward.
So the other
1 year injury. Yes.
This is post 1 year.
1 year. Yes.
Okay. Now, if the meniscus is unstable
Yes.
and if there's a ramp lesion behind it, it requires surgery.
Yes.
I mean, it requires fixation. So, since you have a posterior portal, you can do a repair from the posterior portal.
Okay.
Posterior median portal.
Same with all.
Same thought with us. Yes.
Okay. So sorry. So the same. Excuse me. How to forward this? How to forward this? Not next slide. I want to forward this one.
Video forward.
Video forward here.
Video forward.
Video much forward here.
You freshen it. Since the meniscus he doesn't need, we still don't know. But at least.
Sir, it's a no. Forward here and cover.
It's not reported.
In excessive pivot patients,
Okay, it's to. So on chain.
Can't tell them that also you missed the van.
Right. Thank you. There's a problem with video forwarding. So okay. So given posterior portal, took a lasso and then I've taken a bite. This is the meniscal lasso. So I'm probing it. It's a big tear.
It's a big tear.
So that is the lasso. So I'm taking the bite. Okay. So once I took the posterior horn bite, now I could see another lesion in front. Saw that? There is another lesion in front. So the meniscus on the posterior horn has a double lesion here. One is the capsular separation and posterior horn tear also. So now what to do, sir?
Now this is a described lesion.
Yes.
So this is a complex tear which
Complex tear,
involves the
yes.
posterior horn,
Posterior horn as well as
meniscus
ramp.
also, as well as a ramp lesion.
Ramp also.
Okay, now both have to be taken care of. Now,
Yes.
since the ramp lesion is subluxed down below the tibial plateau,
Okay.
right? You can't do an all inside procedure because you will not get the posterior margin. If you can get a posterior margin in the all inside procedure, then you can get both in the same
Yes.
all inside sutures. Otherwise, what you're doing with the lasso now,
Okay.
first fix the ramp lesion
Yes.
and then go inside and do an all inside procedure so that you can fix the ramp first and then the posterior on the horizontal tear.
Yeah. That's what I did.
So you just check the distance on how much it is and how much you have to do it.
So just what you said, I did the same thing. I fixed the ramp lesion first and then went in front and then did all inside meniscal repair.
Take caps right? And then again second through all both of posterior meniscus in this second thing.
So
get into that. So that you go into the cartridge. So you can use a scorpion action to say.
and then
So what can be done is you grasp it, lift it up, you pass this from point. So you're going to make it.
so start putting the knots and then fix the ramp with arthroscopic knots.
Did you
With
use
the knot
cannula,
pusher.
sir?
Sir?
Was cannula used?
No. I initially I used to use cannulas. Now I stopped using them. So once the ramp is fixed, then I went in front and then in front I did the pie crusting on the medial side with the Bunch's magic point, and you can see the tear on the medial meniscus tear, posterior horn tear. And now I use the all inside device and fixed it. Any comments, sir?
To the audiences who are having a look at this procedure, it is not at all easy to do this procedure. This is very difficult and one of the most difficult procedures to be done and done so elegantly. Wonderful procedure.
Thank you, sir.
Thank you.
Thank you. So I have one more question, one more case to discuss. So this is the all inside. So, I took a bite. Now you can see that fluent sign is coming now. And that's all. We go for the next case. And this is, yeah, this is second case. This is a 28 years male, sports injury 5 years back. He has pain and instability. So I don't have MRI right now, but I can show the arthroscopic video. He has ACL injury as well as in MRI itself, they mentioned that there is loss of substance of the lateral meniscus. It's a 5 years old injury with ACL tear and loss of substance of the lateral meniscus. So, you see that? That is the ACL injury. The shiny part is the lateral meniscus root, posterior root. And then when you go in, up to the body only, I could see the meniscus, and the rest from the body to the till the posterior part, there is no meniscus at all. There is a loss of substance. You see, I proved till that part only meniscus is there. After that, there is no meniscus at all. MRI showed there is loss of substance. What I could find in the arthroscopy is also the same. At this point, what is to be done? I could manage with the ACL reconstruction only because I'm not prepared for this loss of substance. What is to be done, and his financial constraints also will not help much. So I would like the panel to talk about this substance loss of lateral meniscus and that much fuse. What is to be done?
Problem?
Problem with this lateral meniscus is that lateral condyle of the tibia and femur, the both are convex surface. So lateral meniscus played a very important role. So it's a very challenging scenario. So I will be do the same thing as you have done. But there is a paper came from Dr. Amit Joshi in Nepal. He has done a kind of meniscus transplant with semi-T graft.
Okay.
So you can try if this is learning for all of us. So you can use your semi-T graft to be folded and it to be done a root repair kind of thing in posteriorly and it stitched with the remaining meniscus to get a some kind of cushion effect on the tibial and the femoral condyle to protect the uh, uh, knee along with your ACL because otherwise this without lateral meniscus there is high chance of lateral way in coming years as a 5 years old injury. So this is a one way of thinking. I think panelists elaborate.
Just thinking aloud, if possible, there was a meniscal injury, right? A part of it is in the intercondylar notch, which is now turned into like a cyclops lesion, fibrosed. You can see a part of the ligament there, but the rest of the ligament probably there was a posterior horn tear, and that just went back subluxed under the tibial plateau, and that froze there. 5 years now it has been. That's a non-viable tissue now.
Yes.
So that's not going to be well. Something has to be done. So considering these two options like a SMT or a meniscal transplant,
Allograft transplant.
if they are not affordable, like you, there's another procedure like you do for a Banker's lesion.
Okay.
What you do is bring the capsule up and put it up onto the glenoid, something like that. You just release it and see till where that meniscus is lying.
But that is not that easy, sir.
Huh?
But that is not that easy. So something is better than nothing. Yes.
Something that kind of a thing. So just a salvage procedure.
I've started probing it. Even with the probe
So
itself.
that there's a little, you can see a little kind of, torn meniscus which is lying under the tibia.
It was
So if you
difficult.
can release that fibrous tissue
Yes.
and pull it up a little and then centralize it a couple of anchors, at least for the time being, you can save his cartilage.
Yes.
Till some other procedure can be planned.
Yes. Right. Thank you, sir. Thank you. Thank you.
Thank you. Thank you. So I think we are ready for the live surgery. Oh, sorry. I'm sorry. Dr. Dinesh, if you're ready with your talk, we'd like to proceed with the talks.
You are there? Can we go live?
Applicant for this talk.
Good afternoon. This is Dr. Dinesh from Chennai. So I will talk on the most commonly performed knee procedure, arthroscopic procedure, the meniscectomy. Though it is supposed to be very easy, actually it is the most difficult part. Many of the budding arthroscopic surgeons will have a lot of difficulties in doing a proper meniscectomy, particularly the bucket handle tear. So I will di discuss my topic under few salient headings: relevant anatomy, goals and principles of meniscectomy, and some indications. Still, meniscectomy has a role in certain cases, and what are the types of meniscectomy and the instruments used, and some technical tips to do proper meniscectomy. So, as you all know, there are three types of fibers in the meniscus, the most important being the circumferential fibers, the deepest fibers in the outer third, and the outer third of the meniscus is vascular and it has blood supply. We aim to repair the tears in that area. So the primary goal of partial meniscectomy is to remove as much as unstable tissue and non-viable tissue as possible. At the same time, you have to leave as much as normal tissue as possible. So remove only the degenerated, loose or avascular portions and achieve a stable meniscus rim. So the meniscus should be balanced on either edges after meniscectomy without any overhanging or sharp edges. So indications, what are the common indications? Degenerative tears producing mechanical symptoms or pain, effusions, complex tears where the tear pattern is involved in more than two planes, white zone tears, small tears, particularly small radial tears, flap tears and parrot beak tears which are not amenable to repair, and chronic irreducible bucket handle tears, discoid meniscus, and in combination with repairs also, we are doing meniscectomy. So this is the most important instrument, the meniscus probe. The probe is like a surgeon's hand. You have to assess the proper tear configuration and the stability of the meniscus. Morning, the previous speaker told that on one view, we are not able to see the tear only. Only by using a probe, we are able to identify there is a tear. So probe is very important. You have to probe. You can't just simply go in and see and come out telling that there is no tear. Okay. So the next important instruments will be the punches. Variety of punches are there. In the name of all animals and snakes, we have duckbill punches, we have crocodile, alligator punches, all those python punches, right, left, curved, and the tip also 45-degree punch. The 45-degree side punch is very important for anterior horn tears. And there are very latest arthroscopy instruments launched by Arthrex called nano arthroscopy instruments, which are just 2 mm, which can work in small joints and in tight knee joints, degenerative joints, where it is very difficult to reach with the conventional 4 mm or 4.5 mm instruments. So also you can use radio frequency suppose you are not able to identify the tear pattern properly because of the very friable nature, or even after meniscectomy, if the ends are very friable, you can even use the RF probe to smoothen out the edges. So the leg positioning is very important. If you are going to do ACL surgeries, the leg on the top of the table position is preferred. Whereas if you are going to do only meniscal work, the leg hanging position is more preferred because leg maneuvering is very easy. So the commonest maneuvers we perform for doing medial meniscus work would be valgus in 30-degree flexion, and foot in external rotation will open the posterior half of the medial meniscus. Whereas flexion, you will be able to see the body and the anterior horn. This is MCL pike resting. I think previous speakers were highlighting about Bancha's point, where they will release on the femoral side. I prefer to release on the tibial side because most of the time we take ACL graft. So through that incision only I will put my needle. So it is typically 1 centimeter below the joint line. You can see the needle being pike resting the posterior half of the superficial MCL and the medial joint opens. So leg maneuvering for the lateral meniscus would be the figure of 4 position, either in flexion or extension, in whichever way the trajectory allows for the addressing the correct pathology of the posterior horn. So the portal management is very critical. There is something known as Colles phenomenon, where if you don't do the portal, the skin and the capsule in the single line, it will be very difficult. Always try to put portals after localizing it with your needle, spinal needle. You can use the spinal needle to localize the exact region where you want to work, and the needle should be in such a way so it should avoid the tibial eminence and to reduce cartilage scuffing and the medial meniscus as well. So I think previous speakers have highlighted this. So you can always do the portal switching if you are not able to address the anterior structures on the body. So for lateral side, try to localize with the needle because lot of obstacles are there. Like if ACL is intact or if your condyles are intact or a tibial spine, it is very difficult to reach the posterior part of the lateral meniscus. So the figure of 4 positioning along with proper localization with the needle before establishing the portal, it will be easy. So for addressing the posterior horn of the lateral meniscus, you can switch the portals, and majority of the body work can be done with the anteromedial portal. So meniscectomy is described as partial, subtotal, and total meniscectomies. Total meniscectomy is not at all preferred. Partial, we do often. Subtotal, where you are not able to repair a bucket handle tear, you end up removing majority of the meniscus, leading to subtotal meniscectomy. So these are the 3 common tear configurations we see in our practice: this vertical or the longitudinal tear, and the radial tear, and the horizontal tear. Horizontal tear is just splitting of the meniscus into superior and inferior halves. If the flaps or the leaves are stable, we just leave it. Sometimes the flaps will tear and they themselves form a flap tear. So the vertical tear can progress into bucket handle tear, whereas the radial tear can progress into a parrot beak tear. So meniscectomy has a role in oblique tear or parrot beak tears, transverse small radial tears, and flap tears, and chronic irreducible bucket handle tears and complex tears. Some case of discoid also you will have to do partial meniscectomy for the inner third and outer inner 2/3 and outer third. You will have to do a repair, or you can just leave it alone. So each moving on to the radial tear, type 1 type of radial tears where there is a small radial tear of the inner white zone. We can address it with partial meniscectomy. You first palpate with the probe, just find out whether it is restricted, the tear is restricted only to the inner third. You can take bites with your meniscus punches, different types of punches, and use shaver, and you can balance the meniscus. Moving on to the horizontal tear. Usually horizontal tear, if just noticed, we can be left alone or it can be repaired by circumferential stitches. Suppose if the one leaf is torn and a flap has formed, you can remove that unstable flap alone. You can use your punches to cut the flaps where it is getting attached to the body of the main meniscus, and you can use your shaver to debride off. Once it is done, you can use your probe to assess the stability of the other flap. The edges you have to balance. Otherwise, you should not leave any sharp or proud edges. And in this case, there is a stable superior flap of the horizontal tab. So bucket handle tear, actually it's very difficult. Even when I started my practice, I used to middle around nearly 1 hour, 1.5 hours I spent to exercise a bucket handle tear properly. So the standard described techniques, the technique one would be first cut near the anterior axilla, I mean posterior axilla, hold the loose end of the fragment, hold the loose end of the fragment. First assess the meniscus, try to reduce the meniscus, and here the meniscus has a radial tear as well. Try to use a arthroscopic scissors if it is available, or a punch. Try to cut near the posterior axilla or the posterior end of the bucket handle. Always leave some fibers there. Don't cut it fully so that it will keep the meniscus reduced. And now use the scissor or the meniscectomy punch to cut the anterior attachment. Then try to use the artery forceps or a grasper to hold the meniscus bucket handle fragment and gently twist and remove it. Now you have two free proud ends on the anterior and the posterior aspect that can be shaved off with a shaver. So this is the anterior end, and you can use your shaver to smoothen it out. And this is after removing the bucket handle fragment. So the other technique would be to cut in the middle and try to use a shaver and or the meniscus punches to remove the meniscus as piecemeal. So this is a discoid meniscus. How do you do that? A complete or incomplete discoid will be seen if it is already torn. You can use that torn end to gain entry for your punch. Otherwise, you can use the punch to cut the inner half. Always there will be a horizontal component on the outer third. Try to leave 8 to 10 mm of the meniscus in the outer rim. So if one leaf is unstable or you find the other leaf is very thick, you can always remove the inferior leaf, or you can use a repair and you can repair the superior and the inferior half of the leaf of the horizontal tear. And this is a side punch. You can use it. Use the probe to assess the stability of the balanced meniscus. So complex tear can remove the free edges, unstable ends, and repair the horizontal part. You can always use a ablator if you're RF ablator if you are not able to identify the tear configuration properly. So this is one last slide where the anterior structures are very difficult to do a partial meniscectomy. Even you can use a 11 blade to make a small nick and gain your shaver entry, and then you can remove the anterior horn. So to take home, goal is to save the meniscus as much as possible and remove only the unstable and irreparable ones and achieve a stable rim, either using a shaver or a RF. Proper leg positioning and proper maneuvering is critical for any meniscus procedure. Correct portal placement and portal switching according to the need, which zone you have to address is very critical. And always you can use accessory portals. You can add the third portal also if you're not comfortable with two portals. And instrumentation, proper punches should be there along with your shaver and RF. Thank you. Right, sir. Yes, sir. Thank you.
Thank you, Dr.
Okay. So just pull the button again. So yeah, good evening. Who is there? Sridhar, Ramadip.
Yeah, Dr. Prahlad, I'm Dr. Shomudi Fair. We can see you. So tell me about the patient.
So this patient is a young chap. He had an injury 2 weeks, 3 days ago. It was a small road traffic accident, and this guy he sustained. On my clinical finding, there was not much of effusion. His joint had the valgus opening under anesthesia grade 2. And also, which we confirmed arthroscopically by drive-through sign, which I will show you. And ACL was completely absent. So it was an FT lateral wall sign was positive. So I just took only semi-T, and we had a 8.5 mm on the femoral side and 9 on the tibial side, and length is around 7.5. So we are flipping the graph now. So you can see it from the anterolateral portal. Somebody can talk little bit.
So what is your graph length and diameter?
Length is 7.5. Diameter is 8.5 on the femoral side, 9 on the tibial side.
Okay, 8.5 and 9 on the tibial side. So what is the minimum diameter you accept in an ACL tier?
8, minimum 8.
8. So this is very important that you need to have a 8 millimeter graph on either side to get. If you don't get, you go for other options.
Because it is tight rope, just you can just dance. Just dance. You are able to feel the dance. So now we have flipped. See, no, it is not flip. Pull again. You pull.
See the inside picture, zoom in, so zoom out. Yes, we can see the tunnel, different, very nice intact lateral cortex and the posterior cortex, and button going in. Yes.
So we did not mark that. Okay. Bring it back. Pull. Can you hold the scope again? Sorry. So you should have marked, no? Okay. So, okay. Just pull back. No, it is coming. No. Yeah, leave loose. See, I can do the dance here now.
Yes, it's fixed to the lateral cortex now.
So now, Prabhakar, there is absolutely no. So now again we'll pull the graph here. So I am seeing through the anterolateral portal. I did not switch to my anteromedial portal. Okay, so you can nicely see with the anterolateral portal also by rotating the scope. So now again I come in the front. So this is pull the graph inside.
So what is your femoral tunnel length?
My femoral tunnel is 8.5.
Length.
20 mark with the vehicle stitch. Okay. So the 20 is gone. Enough.
You want 20 graft inside the tunnel. Okay.
Yeah. So you can see this nice flat horizontal ACL.
Yes.
So that thing which I can still pull in little bit more. Okay, again. Okay, so now you can see this. This is a beautiful ACL which is there. Can you extend, Jody? Extend the knee. Super. Jody and Chini are the very good assistant. They have done good job. Okay, so complete extension, absolutely no notching, nothing. So what important, before fixing the tibial side, I would like to show you on the valgus. Normally we do pie cast to see everything. So here, without doing any pie cast, there is so much of opening. It is called go-through side sometimes. So we went in the ramp area also, we saw the ramp was okay. So I will try to demonstrate our MCI tunnelless technique. So that's the reason I have retained the Grassalis graph. I will just stop here. I will not fix the ACL now. So I want outside camera here. Sridhar, is it okay if I do tunnelless MCL?
Yeah, please go ahead, sir.
Yeah. So what we will do is, so we will just follow. So we have plotted the graph. Come this side, one person. Okay, I want open stripper now. So I have retained this Grassalis purposefully so that I can use it for tunnelless MCI technique augmentation here. So one retractor please. So today somebody was asking about open retractor now. So this is again one of the indications where you can need to do it. Can somebody sit here? Yeah. Are we able to see there? Can the camera come here inside? Move this table little bit. Move this table little bit so that they can
Yes, sir, we could see that.
Yeah, see in this graph, how do we plot the graph? Yeah. So I just keep my scissors open without uh, going close to the graph so that I don't cut the graph here. Okay, give me the open stripper. So this is the open tendon stripper. So I just got open tendon stripper here. Okay. So as you can see, there is some vincula there which is not allowing it to go. It may cut. It may cut. Give me this. There is something here. Can we do little extension? Okay. Hold it. Hold it. Okay. Give me this. Let me try again. Okay. 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 Yeah. Now it is good. Okay. So now got the Gracilis. Give me an Alice. Give me scissors or something. Yeah. Yeah. 580 bond. So what we will do is
Sir, how many days since injury? This one?
20 days. 20 days. Actually, I was asking Sridhar yesterday, but he had grade 1 clinically under when he was not under anesthesia, but under anesthesia, it is always again very important you evaluate so that can I have a scale? Yeah. So give me the scale. So we need at least 24. So we have good. So I'll just cut it here. Straight away cut here again. Cut it here. Okay, blade. Give me alum. Give it 180 bond. You can keep it comfortable. No. Yeah. So I will just take some whip stitches. Can somebody hold the arrow? Yeah. Use this. So I need actually we have to see the isometric point of the MCL, but I think so it is because not a scheduled planned surgery. So let me see. We can go through the landmark, anatomical landmark, the face marking.
Prahlad sir, this is Sridhar here.
Sridhar?
Yeah. Sir, if acute ACL plus MCL comes, what will be your protocol?
ACL plus MCL.
Yeah.
If it is grade 3 MCL,
Grade 3 only.
femoral side, I will still wait for 3 weeks and then
Mid substance.
mid substance and tibial side, I will take the patient to the surgery. And if ACL is repairable, I repair the ACL. As I did yesterday one case before coming here. So we repaired ACL. We now take out all this stuff back. Take out all this. So I need periosteum. So now I will keep in figure of 4. I need a retractor. So don't worry, it will not go anywhere. Again, you go retractor to Ajay. So we all are aware about this technique of this thing. So I will just move. If you see this gracilis, no, I will just move through the MCL here, and ideally we should put an anchor and fix it here, and then one more anchor down. So that Prabhakar, I hope he can give me 2 anchors, 11 number blade and periosteum.
What is your plan, sir, now? You want to tunnel it and fix it with the anchors?
He arranged one anchor.
Okay.
So let what we can do.
Any
No, I don't.
reinforcement you are planning?
Sridhar, do you have any staples, bone
No,
staples?
no, sir. No. Right now we don't have.
So if we have bone staples, that is very good. Give me periosteum. Give me osteotomy, periosteum, anything. Okay. 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 Super. Thank you. Okay. Yes. Bring in. Give me one plate. No, no, it will not come. Bring me Ethibond. Ethibond.
Prahlad sir, if you want to take little time, we'll have one talk and come back to you.
I just need 5 minutes.
No, no, that's okay. You can take 10 minutes also, whatever you're comfortable.
No, what she did? Sorry, I did not get.
No, no, sir. If you want take time for preparation, we'll have one talk and come back to you again.
No, no.
If you want to continue, we'll continue.
Here, I will just show you this step here. See,
Okay.
just give me this. Yeah, just look this graph here. So now if you see, I am going to pass the Grasalis below the MCL. Okay, please.
Okay, sir.
This hand, yeah. So now you can see this. Okay. So this is rerouting of the Grasalis. So now we have reroute the Grasalis here. You can see, otherwise, if I just take Grasalis directly like that, it will be an not isometric. See now, I will put an anchor here and I am done with the procedure. I will bring it back here. If the staple is there, I will put that, see it will come like this. I will fix it at an anchor and another anchor or staple, I will fix it like this. So this will be MCL augmentation. Okay?
Yeah.
The paper is now published in IAO. It will come in the November edition.
Okay, fantastic, sir. Fantastic.
Yeah. So give me the knife here so I can feel the adductor tubercle here. So I will just pass the graft, everything, but I am not anchored. I am not going to, I will first fix the ACL, then we will fix the MCL. Give me the blade. So I can feel here, this is the adductor tubercle, secondary. So I have to be just posterior. I'll just make a small nick here. Okay. So I will go deep to the bone here. That is very important. You have to go deep to the bone and put an anchor here. Give me the anchor.
Camera angle to be changed.
So deep. It will go. Is it sharp enough? Because no, I want to just record it. We will cut the needle. I don't want the needles. Just go. This is very important. Bone depth. Give me one more. So it is very important. You go bone depth. Okay. So
Prahlad sir,
usually I do it under CM visualization. This. So before appreciating, just relax. So also I will show you clinically. See there is valgus opening. You can appreciate this.
Yeah, sir. Yeah, we can see that.
So you have to come like this. Yeah. So now you can see there is valgus opening now here. So if I do this, definitely the valgus instability will reduce. So give me an anchor now. You do this. Hammer. So again, the landmarks. Okay. Hammer. Red panna. Again, you should tell when to stop. We're not saying. Enough? Okay. So now we will take the, you cut the needles. So give one straight artery. Yeah. So just separate and keep it. Okay. Straight artery will come from this. We can make along the plane of the MCL. So give one thread from there. Give one thread. Yeah. Three thread. Loop. Ajay, give me a loop. Ajay. So I will just pull this map here. So give me the graph now. Ajay, pull the graph. So now, okay, this is what we got it. Huh? So come here.
Ajay, give me some space. Yeah. So now what we will do is we will just put some sliding knots here. You can cut the needle. All the 4 needles can go with the knot, please. Someone should tell if it is 4:30, I will leave here only and I will go. Please cut this also. Body, chinny. Okay. So give me that first. Yeah. So Ajay, you should hold full tight. Okay. You have no pusher. So I just put our favorite Duncan loop. I still keep it in figure of 4 so that it goes automatic. So hold the leg. Anchor came out. Anchor came out. Okay. Your switches came out. Anchor is not there, but switches have come out. Okay. So we have an issue here now. Okay. So give me no problem. Just give me a Valkyrie 2 number. Yeah. What civil lock? Give civil lock. How many civil lock you have? But we have to make tunnel for that then. So what other now he doesn't have an anchor. See, this would have been very simple. We will just have to put a sliding knot and put. But now what else we can do is we will have to bring this in the center and put it in the civil lock and bring it back. So you got the concept, Sridhar, Somadi?
Yes, sir.
We are live or not?
Yeah, we are live, sir. We are watching you.
See what the basic principle what is there is I put the anchor here. I
Okay.
just put a sliding knots. So this end gets fixed here, but this knots this did not work. The anchor switches all came out. So what we will do is we will take a fiber wire in this. We will put a civil lock. We will put the graft inside along with that. Then bring the other end and we have to put another civil lock.
Okay. Okay. Sir.
So yeah. We'll just remove this. So the concept, if you have got, then you can continue, Sridhar.
Yeah, sir. Yeah.
So I'm going to fix it at the isometric point here with an anchor. Then again I will bring this down here and then again fix it with either staple or another civil lock.
Right, sir. Right.
After that I will do ACL. Yeah.
Praladji, this is Dr. Praveen. One question for you. What are the indications of this procedure? Is it grade 1 and 2 augmentation or what? What are the indications?
The indication for this procedure is MCL anteromedial instability. So now our graft, ACL graft is already inside. So now if you see, still there is some valgus instability is there.
Yes.
I am put the ACL hard. So we saw arthroscopically also. Arthroscopically, drive-through sign was there.
Yeah.
So without doing any pie crusting, I was easily able to go over the entire medial meniscus. So that is so whenever there is a drive-through positive and valgus grade 2 positive, that is sorry grade 3. See, this is definitely a grade 3 instability is there.
Okay.
So this is the case ideal for this kind of reconstruction. So otherwise you have to make lot of tunnels and you have to do this procedure. So this is a simple technique we can do.
Can we do this for grade 3 MCL tears?
Yeah, I am doing all for my grade 3 MCL tear. In acute situation, I repair MCL first.
Okay.
Then I augment this for my repairs.
Even for the mid substance. Even for the mid substance.
Yeah. So if it is a repairable tear, I usually repair within 1 or 2 weeks. If I take the patient, I definitely repair. But if like now this is 3-4 weeks down the line, it is very difficult to find Where is the car? Right, forward. So
Okay.
in this situation, we just do reconstruction.
Okay.
So this is a kind of a reconstruction procedure we are doing now.
Okay. Right. Thank you. Thank you, sir.
So instead of making tunnels like we do in the lint procedure or Laplace reconstruction. So this is just tunnelless technique. So now we have moved it here. So this will be along the line of the MCL. I just put an anchor, put switches here, again bring it down here. I usually fix it with staples. So since we don't have a staple, so I will use one more anchor. So this will give, so I hold it like this. See, this becomes stable now. There is no valgus only. So this is the concept for this. You can continue with the talk. I'll try to finish this in the civil note and come back to you.
Sure, sir. Thank you.
Something? Yeah. But I need some, I have to make a tunnel. நான் கிராஃப்ட் உள்ள போட்டு ஃபிக்ஸ் பண்ணணும் ஒரு ஸ்க்ரூ வச்சு ஃபிக்ஸ் பண்ணிடலாம் I make a 7 mm tunnel. I have passed the graft here. So we'll fix it with a screw. Huh? Give me 7 mm.
So next talk is Dr. Soumyadip Datta based on management of multi-ligament knee injury.
No, you will take the point. So from morning, we are seeing the multiple surgeries. So ACL, bimeniscal repair, and then we are seeing an MCL repair. So I'll going to a bit complex scenario, that is multi-ligament injuries. Display this one. Slides. Okay, so if you see an MRI like this, so it's a bicruciate injury with a probably MCL is injured, lateral side is injured. So it's a very complex scenario. If you find a MRI like that, it only the MRI will not give the answer. So it's very important to classify them and manage accordingly. So some classification is the very simple classification that has been described in the literature, that is KD1 is single cruciate with any collateral, medial or lateral, like this one Dr. Prahlad is operating. KD2 is ACL bicruciate injury. KD3M is bicruciate with medial MCL injury. KD3L is the bicruciate with lateral sided injury. And KD34 is all four ligaments gone, and KD35 with fracture dislocation. But at the same time, we have to note if there is any vascular injury, if there is any injury to the neurovascular structure, mostly the common peroneal nerve in the lateral sided injury. So the first thing that this patient is not seen and isolated. So these are the trauma patients. So if you're dealing with an ER or in an emergency setting, so first thing you have to see the patient as a whole. You are not missing any other traumas. You need a help of your colleagues. And first thing we have to see is an X-ray. And we have to see the pulses distally. We have to see the neurovascular status. You can add a, if any suspicion, you can do a Doppler, arteriogram, whatever. And then in a later stage, you can do an MRI. So you have to then classify this injury. So splinting is of in acute injury is very important. This kind of splint is always helpful. So keep your knees open so that blister or any soft tissue changes you can see in every time you go to the ward. But casting is big no in this scenario. So
A role of external fixator in acute scenario. Yes, there are role of external fixation in knee dislocation. If you have an irreducible dislocation, if you have a concomitant vascular injury, if you have an open dislocation, you just put an external fixator in and take care of the knee to keep it in position and rest your vascular or plastic surgeon colleagues do their job, and then you come back again and do your job. So the first thing is what to do with this, operative or non-operative. So in multi-ligament, mostly the treatment is operative. There are a lot of studies that shows non-operative trial is very not very effective, leading a longer time to heal, leading a residual stiffness and deformity. So timing, as it's been discussed before, so around 3 weeks time or less than 2 to 3 weeks time is the ideal time to operate in these multi-ligament injury. Don't go in a hurry to operate this, because you need your soft tissue to be settled in, otherwise you are been in trouble. So there are few scenario where they have to do the immediate surgery, like arterial injury, if you have a compartment syndrome, along with if you have an open dislocation, if you have an irreducible dislocation. And acute, that means around 1 to 3 weeks you have a, if you have a bony avulsion along with you, because bony avulsion having a very good chance of healing if you do it properly in early setting. If you have a displaced or flipped meniscus tear, if it is a extensive lateral sided injury, you can repair it. And if it is repairable in early stage, they do always 1 to 3 weeks time is a very good window period. So when to repair, when to reconstruct, there is different thought process. So repair is mostly if you have a peel off. ACL repair is very controversial. PCL is a very vascular structure. I'll show a case in the letter that PCL can be repaired, but reconstruction in a mid substance injury. So this is a scenario of a case in acute setting. I got the patient around 2 weeks time. He has a lateral sided injury along with a fracture of the fibular head, along with a Gardis tubercle fracture, along with an ACL. So around 3 weeks time, I did a this is his MRI. So see there is a lateral sided injury, avulsion fracture of the Gardis tubercle, and the lateral sided avulsion in the fibular collateral, along with an ACL tear. So in a single setting, I have fixed the lateral collateral with the implant. I have fixed the Gardis tubercle, and same sitting I have done ACL reconstruction. You can stage the procedure. You can first fix the lateral sided injury, and later stage you can do an ACL surgery. There is no harm. So this is the patient getting a good range of motion in 6 months time. This is another case. This is a some proximal tibia fracture. There is a avulsion of the lateral collateral in an acute setting around 2 weeks time. This is his CT scan. This is his MRI. There is PCL, complete PCL tear. See the posterior subluxation in the MR of the tibia. This is what have been done. This PCL has been repaired, not reconstructed. This is an open incision. Get the PCL and we repair the PCL and put the PCL back on its position. So this is a post-op X-ray. We have fixed the fibular head avulsion with a screw and a proximal tibia with a small buttress plate. And this is the range of motion around 7-8 months of time. So this is the acute scenario. But in our country, it's very common that we get these patients late, because as these patients go on roaming around and then come. So late scenario is something a different ball game. So there are three things we have to take care of. And first is stiffness, second is the deformity, and third is the instability. So what do you do about the stiffness? If you have a stiff knee, you cannot go for a multi-ligament reconstruction immediately, because first thing you have to gain the range of motion. If you rehab will do, that's very good. If you cannot do it or you have, you can do an arthroscopic, or if you are not comfortable with arthroscopic arthrolysis, you can go with an open arthrolysis and gain the range of motion and then reconstruct your knee. So deformity is also very common, because this patient having a fixed flexion deformity. So this is a patient of a 30-year-old male with a fixed posterior dislocation. So 6 weeks down the line, the first thing we have to get the tibia back its position. And the first thing we have to do in this patient is not the MR and everything. First, you have to check the integrity of the posterior vascular structure. So that has been checked. It has been seen there is no such vascular injury we are dealing with. Then we have done a eraser of fixation, able to reduce the tibia back in its position, and then you can use a hinge fixator 3 to 4 weeks time, then start mobilizing, and then after that we can do reconstruct whatever reconstruction is needed for the patient. This is another thing. Same type of injury has been managed with an external fixation. So alignment is also very important in chronic scenario, especially in a PLC and PCL injury. You tend to have a varus thrust and leading to a varus deformity. Also take care of a recurvator and deformity. So corrective osteotomies are been described. So slope changing osteotomies are very helpful in this kind of scenario. If you have a PCL deficiency knee, increase the slope, it will reduce the posterior slack. If reverse in ACL, if you in ACL decrease the slope, you will take care of the anterior instability. So assessment is always very important in a chronic scenario. You have to do all your varus stress test, valgus stress test, your dial test, your posterior sag sign, so and note it accordingly which type of injury we are dealing with. So as has been described in the literature, stress test in chronic scenario and especially in multi-ligament is very helpful. So how you have to always compare, if you don't have a facility to do a stress test, take the patient in the ward, do a fluoroscopy compared with the normal side. If it is a lateral sided injury, less than 2.7 mm compared to the normal side, it is considered as a normal. 2.7 to 4 mm is isolated FCLTR, and more than 4 mm you are doing with a complete PLC, that is fibular collateral along with your popliteus complex is gone. Same thing with the posterior sag. If you have more than 4 mm of translation posteriorly, you have a dealing with a PCLTR. So what is the sequence? First, you have to do arthroscopic thing. As we have said, that PCL is the pivot. You have to get the tibia back in its position. Do your PCL first. You can do your ACL and arthroscopically. You can assess the chondral lesion and the meniscus lesion. If you had addressed, do it arthroscopically, and then come back, do it after that. So main thing we are concerned here is the tunnel convergence. So if you are doing in a posteromedial reconstruction, you have to do with the two tunnels. That is your PCL and your superficial MCL and the medial collateral. So the trajectory of the tunnel has to be very taken care of. And same thing, if you are doing a lateral side, posterolateral with an anterior type, you have a 3 tunnels in your lateral condyle. So the trajectory of the tunnel should be taken care of. Always check and recheck before drilling and then come back, because tunnel convergence will lead to further failure. So this is the sequence of the graft passage. First pass the PCL and the ACL. First fix the PCL, then pass and fix the PLC, and then tension the ACL and fix it, and last you do the superficial MCL and POL. So in which position you have to do? PCL, you have to fix it in 90-degree knee flexion. PLC, 30-degree with a valgus stress. ACL in 30 degrees neutral rotation. Superficial MCL in 30 degrees of varus stress, and POL is in full extension. So I'll just forward नहीं हो रहा वीडियो थोड़ा फॉरवर्ड होगा नहीं मिल रहा है ना और इससे दिखाए इसमें दिखाए हाँ वो पावर पॉइंट से आ जाएगा
सही हाँ ठीक है ठीक
So this is a case of a failed ACL reconstruction due to missed PLC injury. So this is a PLC incision. So I'll show this incision. This is a, you have to go a generous incision on the lateral side, make a posterior base flap, and then first thing you have to do is you have to identify your common peroneal nerve, because this nerve has to be protected from for the entire time, entire duration of the time. The first window is made at the level of the femoral condyle, and that position you will get your uh, tunnel for your fibular collateral ligament. This case, I have not used two tunnel. The classical Laprade technique has been described. You have needed two tunnel, one for popliteus, one for fibular collateral, because there is also a ACL injury that has been done twice. I used only one tunnel. The first tunnel is made on the fibula from anteromedial to the posterolateral side. Then you protect your uh, drill bit over there. You are making a small tunnel over the head of the fibula at the base of the champagne deformity. And then you pass your suture over there. Then you make a tibial tunnel. Tibial tunnel made midway between the Gardis tubercle and the fibular head. And same direction, you have to protect your tibial tunnel posteriorly and pass your suture over there. These are the two tunnels has been made, one for popliteus, one for fibular collateral. Then you make a next tunnel over the lateral collateral and the popliteus. I have made a single tunnel. So this is made around 2 centimeter proximal and posterior to the lateral epicondyle. This is my femoral tunnel. The single tunnel made because it's a failure case. We have the same time had to do an ACL reconstruction. We don't want too much tunnel on the lateral condyle. So this is the tunnel has been done. So now the graft, you have used a quadriceps tendon graft and split it into two. Just pass the quadriceps tendon graft, and now it has been now two limbs has been kept, one for as a popliteus complex that will go for up to the tibia, another for the collateral that will go up on the fibula, and it has been fixed with a screw. Then the graft is pulled to the fibula, and then both the graft has been pulled back to the tibia and giving a, and this everything is fixed back in its position with a screw. So in a nutshell, I will always recommend you to multi-ligament cases. There is a beautiful paper by Dinsha Padriola sir. So if it is a chronic tear, if it is a alignment is uh, good, you can go with multi-ligament reconstruction. You can do a staged or single stage depending upon your armamentarium and depending on the patient demand. And if it is limb is malaligned, don't jump for a ligament surgery. Correct the alignment with an osteotomy. You can change the play with your slope. And second stage, you can always come back and do ligament surgery. If it is a unreduced dislocation, and it is very common in India that you get some cases of unreduced dislocation, always do an open surgery. Don't go for anything close. Bring your tibia back in your position. Hold the tibia with an external fixation, Ilizarov, whatever you are comfortable with, and then you gain the movement. And then second stage, if the patient at all need any ligament surgery, do that. Thank you very much for your kind attention.
Okay. So can we go live now?
Yeah.
Yeah.
Yeah, Dr. Prahlad, we can hear you and see you.
We have done this perfectly. See, this is the ACL which is perfect, flat ACL which is tight. Huh? So now initially we had a dry through seal. Now I'm giving valgus. So now I'm seeing there is the medial joint stress is totally reduced. Now if I have to see medial meniscus, I have to do a pie crust. This is because we have done MCL reconstruction now. So if you show outside picture, just hold this. Okay, just show the outside pictures. See this valgus. I'm giving complete valgus. There is absolutely no valgus instability. So no anteposterior instability. Okay. So thank you very much, Sridhar, for this opportunity. I had an excellent team here. So I thank Chinni, Jody, and the entire anesthesia team and team of Medicover. Thank you very much, Ajay, Babakar, entire Arthrex team. Thank you very much.
Thank you. Thank you.
Any comments from the floor? Anything? Sridhar?
Very nice surgery, sir. Very nice surgery. Thank you. We all watching.
Prahlad sir, thank you so much. So I think at the end you got a twist and you managed it very nicely. Yeah, yeah.
Tunnel, we made a tunnel of 30 mm.
Okay.
We bought a graft inside and fixed it with a 7 mm suture and this thing. So screw. And then we bought here and fixed with a civil lock on the tibial side.
Yeah, yeah, sir. Fantastic, fantastic. Actually, patient is a very lucky fellow. Thank you, sir. Thank you so much. Thank you so much.
Thank you. Thank you. Thank you.
Next, we welcome Dr. Praveen sir for his talk on outside in and inside out technique of meniscus repair.
So, good evening, everyone. So, this talk is more about meniscal repair, inside out uh, and outside in. So, more of inside out I'm speaking now. So, this will definitely will give some of the inputs for the youngsters. So, okay. Oh. Oh. Okay. Okay. So this is a small video. Oh, it is not. Okay. This, yeah, this is a small video on the bone model, right? So just to educate what I'm going to do, and next I will show the interop treatment. So these are the meniscal needles designed for inside out technique. So the degrees angulation from 40 degrees, 30 degrees, 20 degrees, and 10 degrees and a 0 degree one. So all the cannulas you can see. So in this case, I took a 40-degree bend cannula, and from the lateral side, I'm putting that cannula. So 40 degrees will help in treating the posterior horn repair system. And when you're coming to the front, till the anterior part, the degrees will come down, like 40 degree will come down to 30 degree, 30 degree to 20 degree, something like that. Arthrex has a similar device, but this is a special device which is called as a zone navigator. They have the cannulas designed similarly. So this is the fully angulated cannula. This helps for the posterior horn and body junction. And this is for the body, and this is for the smaller curve will help for the anterior. And we can use left and right with this. So once the cannula is placed, we can pass the meniscal needle inside the cannula, and it will come on the medial side for the medial meniscus, and that can be repaired easily. So this is for the note, and then we go for a case. We'll see what's happening in here. So this is a case, young male, 28 years, with the ACL tear with medial meniscus bucket handle tear. So here I'm doing reducing the medial meniscus. He has a ramp lesion also, associated ramp with bucket handle medial meniscus tear. So the tear is unstable. Now I could able to reduce it. There is little grade 1, grade 2 medial arthritis is there on the medial femoral condyle. See, once I flex it, again the meniscus is coming back. So that much unstable is the tear is, right? So I started using the cannulas, and then so here I use the midline portal as the viewing portal. And then what happened? No, this one, sorry. And then this is the diamond rasp. I freshen it all the edges of the meniscus. So I did small, yeah. You can see start using the cannulas. From the posterior part, I use the 40-degree cannula. You can see the posterior horn and posterior part of that is the posterior horn and posterior part of the medial meniscus. So with these cannulas, we pass the meniscal needles inside and they come out on the medial side of the knee. This patient has incidentally ramp lesion on the posterior side also. So here the needle is coming on the medial side. Again, the needle is coming on the medial side. So I took almost 4-5 stitches with this meniscal needles and the cannulas. Yeah. And then so slowly from the posterior to middle part till the body, I'm passing the meniscal needles and the stitches. You can see that. So once you pull it, it will reduce. So after placing the 3 or 4, there is eversion of the meniscus. Once the meniscus is everted, I placed one stitch underneath and reduced the meniscus in position. This is the inside out technique. So multiple needles are coming. And here the meniscus is in the reduced portion. You can see there is a little bit eversion of the meniscus. And for that, I have given one underneath needle also. So here, okay. Once it is given, the meniscus is reduced in natural position. Yes. So just I'm giving traction on that and then seeing whether it is reduced or not. Still there is a ramp I repaired the ramp also with all inside device. You can see the ramp repair here. Here is the stitch. Ramp is repaired with all inside. And then finally, yeah, finally you got all the meniscal sutures on the medial side with a small incision. We have tied one after the other on the capsule. We have retracted the muzzle. And final picture, you can see a completely normalized meniscus in its anatomical position. It is completely repaired. The bucket handle tear is completely taken care of by the inside out technique of the meniscus. So outside in usually we use for the anterior horn tears. Anterior horn tears are very rare, but I can show you one case of the anterior horn tear. There is anterior horn tear. There you can see, here you can appreciate the anterior horn tear. With this outside in technique, we can pass the 18 needles. There is meniscus mender set is also available. We can get the stitches, looped it outside from an outside in inside outside, from inside to outside, and then we can repair it by putting the knots. That's it. Even in the next meniscal repair session, we will be showing with this zone navigator. Thank you very much. Any questions?
Any questions?
Do you use the spoon for the safety incision for outside?
Yes, sir, definitely. I do use. So when it, especially from the posterior part, when we are dealing with, so I will see the exit point where I am coming, then definitely use the spoon. Thank you.
So I think we've come to the end of the session, this wonderful session. I request Dr. Sridhar to give us a word of thanks.
So, a very good evening, everyone. So, first of all, I would like to thank all the delegates for their wonderful cooperation and their presence till this Sunday evening for sparing their time with us. So, because of all the appreciation and the participation from the delegates, we could do a very good academic program, at least one program a year. And also, I would like to thank all the faculty who have been there since last night and who had participated in our live surgery and academic discussion, and also all the live surgery faculties who have been here, and also the office bearers of the IAS Secretary Dr. Sandeep Biraris and the EC members Dr. Somadeep Datta and Dr. Prahlad Singh, who have been our backbone of this meeting since its starting idea. And also I would like to thank the Arthrex team and all the supporting staff from the Arthrex who have supported us with the live surgeries and all the infrastructure and equipment. And also, I would like to thank the Skyline Pharma who has managed our front registration desk today. And above that, first of all, I would like to thank our organizing committee members, Dr. Aslam Arif sir, Praveen sir, and Dr. Ashish sir, who have been the instrumental in managing this meeting, and it has come true on this day because of their sincere help and participation. And especially, I would like to appreciate Ashish Kumar sir. We got only 2 live surgeries patients admitted this week. Rest are all some multi-ligamentous injury where we got short of one case. So immediately, sir has sent that first morning ACL plus meniscal repair case yesterday itself. So a very sincere thanks to Ashish Kumar sir for his help. And I would like to thank our organizing members from my hospital, my team, Dr. Gandhi. He has been the backbone of this. So he has been the backbone of this meeting. Not only this meeting, whatever meetings we organize from our hospital side, he is always there for us, and he is the key person about all this meeting, all the bringing all the faculty here, organizing all the live surgeries. So all the live surgeries have come up so well only because of his help, and he managed all the cases single-handedly since yesterday morning. So big thanks to Gandhi, and I would like to thank my assistant, Mr. Jitin and Prudvi, and all my staff who have been there since last 1 week, managing all the registrations and all the patients, and especially to Jitin. Last 2 days, he is the person handling all the faculty from airport to hotel, hotel to Novotel, and vice versa, everything. So all the faculty, they were very happy and they could manage and do everything in time because of his help. And also, I would like to thank the Novotel team for their help and all the things which have been done in time for us. And lastly, I would like to thank our hospital management, Medicover hospital management, who has provided our everything in our hospital operation theater. And to be precise, first time we are operating with a Wi-Fi. So we have done it through Zoom this time. Every time we are putting a cable from the hospital to the Novotel and transmitting it. So first time today we tried through internet so that we can do much more meetings, which many more live surgeries in the future, because that cut shorts our expenses and time also. So we can do much more meetings with more live surgeries in the future. So I thank the Medicare team for helping us with all the equipment and IT support from our hospital side. So thank you so much. So we'll proceed with the meniscal repair workshop at the end. Thank you. And all the certificates, just make sure you have written your registration number and your name and phone number correctly. So everything will be sent in person to you. Within 1 month, if you don't receive your certificate, you can WhatsApp us or call us back in our delegate group. Thank you. Thank you so much. Yeah. Praveen sir. So only one request. I want to give memento to our Gandhi. On your hands. That is Parvatipuram feeling. Sir, please, sir. Workshop. You will go now, you will go. Yeah, so almost same like Yes, but the what is the what kind is enough for us? Yeah, you have that is excellent. I know it. Thanks for that. Thank you. I don't know. I just think I don't go well with it. That's Side how much?